Thank you for joining us for the third annual Multiple Sclerosis Symposium, a joint endeavor between the Department of Neurological Sciences at the University of Nebraska Medical Center and the Nebraska Neurological Society. Your participation today reflects a shared commitment to advancing the care of individuals living with MS, and I appreciate your presence quite a bit. I want to start by acknowledging the organizing of this meeting. Carmen Chinchilla Gutierrez, Executive Director of Specialty Societies at the Nebraska Medical Association, Tyler Egger, Event Coordinator at the Nebraska Medical Association, Mary Soper, Administrative Project Associate in the Department of Neurological Sciences at UNMC, Carmen's, Taylor, and Mary's work has been essential to shaping today's program. Please join me with a round of applause. I also would like to extend my gratitude to everyone involved behind the scenes whose names I may not have mentioned. Special thanks to our sponsors whose support makes the symposium possible. They are our partners in innovation, patient support, and education. Finally, thank you to all our presenters for contributing their time and expertise. This year's symposium centers on innovation and advances in multiple sclerosis, focusing on evolving knowledge and practical issues that affect patient care every day. We will begin with Dr. Hartman, who will address women of childbearing age, navigating pregnancy planning and breastfeeding while the patient is dealing with their multiple sclerosis, a topic which is directly relevant to your daily practice. I will follow with my presentation from phenotypes to endotypes, rethinking MS through mechanistic lenses, examining how shifting from descriptive categories to mechanistic endotypes can reshape diagnosis, therapeutic targeting, treatment selection, and long-term disease strategy. After that, Dr. Crespo will present a hot topic in MS care, long-term considerations surrounding B-cell modulators. This session is highly practical and clinically useful, tackling immunological consequences and long-term complications that often make clinicians scratch their heads, as they are balancing efficacy, cumulative immunosuppression, infection risk, and safety in the context of aging. Next, Dr. Bernitsas will address aging and DMT, an increasingly important challenge as patients live longer and rely more heavily on high-efficacy treatment. Immunosenescence now play a central role in treatment decision, making this session especially timely. Our morning session will conclude with Dr. Ayush Gupta, MS Neuroimmunology Fellow, presenting an illustrative case of white matter disease, one of many complex cases we encounter in MS care and in MS clinic. After lunch, our other fellow, Dr. Sulafa Safarini, will present her case titled Brain on Fire. While you might guess what is the disease about, I'm on purpose not telling you what it is, highlighting the evolving landscape of this category of disease. Once rare and esoteric, these disorders now appear frequently in inpatient neurology and challenge even seasoned clinicians with their protein clinical manifestations, diagnostic complexity, and rapid progression. Following Dr. Arcot will review MOGAD, the chameleon of demyelinating disease, if you recall my presentation last year. MOGAD's pleiotropic presentation and variable management challenges make it persistently relevant. Dr. Arcot will discuss emerging and potentially novel therapies shaping the future of MOGAD care. Our afternoon will conclude with an interactive session led by Aubrey Lindner, Neil Juvenal, and Dr. Renee Stewart, focusing on myth and mocktails. You heard me correctly, it's mocktails, not cocktails, of symptom management and caregiver burden in MS. Symptom management remains a cornerstone of MS care, and caregiver burden grows in parallel to complicated symptoms, making this session essential to a comprehensive MS practice. Before we transition this presentation, I want to highlight something meaningful about today's lineup. As I was reviewing this introduction earlier this morning, I realized that four of our presenters are former UNMC trainees. Dr. Arcot and Dr. Crespo, both graduate of our Department of Neurological Sciences residency program, and our current MS Neuroimmunology fellows, Dr. Gupta and Safarini. This speaks volume about the historical, current, and future impact of our institution on training the next generation of MS neuroimmunologists. The continuity of mentorship, scholarship, and clinical excellence represented here today reflects the strength, legacy, and future trajectory of this program. I hope you enjoy our 2025 MS Symposium and that you find material that is directly useful from expanding your clinical knowledge to improving patient-centered care. I also hope you experience several aha moments that clarify the patterns you see in your own clinic. As time does not permit full verbal introduction for each of our speakers, we have prepared a compiled document summarizing biography of our esteemed presenters. Thanks again, and I would like to ask Dr. Hartman to join us and present her lecture.
All right, good morning. I am thrilled to be here, Dr. Beth Hartman. Thank you, Dr. Spots, for getting us a great intro and getting us started this morning. I have the pleasure to talk to you about some really important topics, especially focusing on pregnancy, lactation, and really the goal here is to make sure that everybody feels more comfortable if you don't already how to handle these patients. So disclosure is not really actually relevant to this talk, but we do have some clinical trials going on. Objectives should have been in that handout, I believe, for you as well. But we hope that we really come away today feeling more comfortable with the normal immunologic changes that are going on with a pregnancy. Want you to feel really more comfortable with our MS disease modifying therapies, how we use them around talking about conception, pregnancy, and lactation. Are you hearing me okay in the back? Okay, thank you. All right, I'll get it closer to me. And then again, really focus on lactation as well. So to put this in perspective, it's always about our patients. And so this is a kind of made up patient named Glenda, or maybe we'll call her Glinda because this happens to be also the release date of Wicked 2, if those who are her tracking it. So Glenda or Glinda, this is a patient who was diagnosed with relapsing remitting MS at the age of 18, initially presented with lower extremity sensory changes, some transient leg weakness as well. Brain MRI showed multiple lesions in classical locations. 2 of them did have enhancement. Fortunately, there was sparing of the brainstem. Cervical and thoracic MRI also had MS involvement, including an active lesion at T8, which explained those lower extremity symptoms, and also a higher cervical non-enhancing lesion. Had a father with MS as well. This individual, after talking through options, would start on disease-modifying therapy, the ozanimod, an S1P modulator, and I'm going to move on. So when we think about these patients, they're already coming in, and even though we're not thinking about having a family then, we really need to think about our whole patient from the get-go. And that's because we know that MS does have a strong female predominance, a 2 to 3 to 1 ratio, so 70% of our patients are going to be females. And MS is most commonly diagnosed during our peak childbearing years, between the ages of 20 to 50. We also need to acknowledge that about half of pregnancies aren't planned. And so we need to plan that our patient may not be planning and to help them plan as well. We really need to be very clear that pregnancy does not negatively impact the prognosis of MS. This is very different from what people were sometimes told 20, 30 years ago. And in fact, our studies have actually showed some potential benefits for women who do choose to get pregnant. Importantly, if we undertreat women, that also exposes them to the risk of relapses and disability. So we really want to feel comfortable with what we're doing. And then we've also seen associations that when we do use disease-modifying therapies, that's not only associated with the risk of reduced risk of disability, but also improves quality of life and allows more autonomy for those individuals to make that plan for when they're ready to make that choice of whether they want to have a family or not. All right. What if a patient is just newly diagnosed and also actively trying to get pregnant? This happens in clinic too. And so the expert recommendation is to start a DMT at diagnosis, establish clinical stability with their MS and get that under control. And then after a year, then we can look at attempts to conceive safely. So that's the expert recommendation to really get that disease under stability, because a healthy mom is going to be more likely to have a healthy baby as well. And again, we know that early treatment is associated with better long-term disability outcomes. So, coming back to Glenda, so when we have that first sit down for a female patient, even at diagnosis, this is one of the things we want to be talking about. So for every patient who is a female childbearing potential, we want to ask about, are they planning for potential pregnancy? And if they say, no, I'm not, then we want to follow up with a question for, what are you doing for prevention of pregnancy, because not wanting to have a baby and get pregnant and using birth control are not always happening at the same time. So we really want to make sure the patients are using something if they're on medicines that could be a higher risk. And then depending on what medicine they're on, make sure we're always talking to them about if they were to have an unintended pregnancy, because even birth control options can fail sometimes. We need to make sure that they know what the consequences could be as well. And then I think as any parent, it's always important to know, what is the risk to my offspring? So for my patient, she did not have plans for pregnancy at the age of 18. She was already on a combined oral contraceptive pill. We did talk about the fetal risk, that there's a known risk of fetal malformations with the medicine we were putting her on. And then we know that for every individual who has MS, there's a 1 to 3% risk their children could have MS in the future. So that background risk, for reference, again, for women is about a 1 in 4,000 risk. Here in Nebraska, which is a higher incident level, for men, closer to about a 1 in 1,000 risk. So this is a definitely elevated risk from the general population. Interestingly, if it is the father who has MS, that risk is a little bit higher. And then, of course, if it's a female offspring, that risk is higher for them too. So that 3% risk was more appropriate for this patient whose father had MS. All right, and then going forward, this is not just a one and done conversation, that all of our lives evolve. And I like to tell my patients at diagnosis, my job as your MS physician is to keep MS in control so you can keep on living your life forward. So we're going to work together to keep you moving forward. And so going forward, we want to check in at return visits over time to say, have your plans changed? Are you doing anything different? Talk about what they're doing with birth control. Continue to educate regarding the importance of pregnancy planning. So we want to reassure, we want you to plan the life that you plan to have. Just give us a heads up so we can help you be successful in it. And then when they're ready, we want to really go through and educate about the effects of MS in pregnancy. So fast forward for Glenda, she's now age 26. She's been clinically stable on her disease-modifying therapy. She's newly engaged, and now she's starting to think about a potential future pregnancy. So let's talk more about what is going on, or what would be going on just with a normal pregnancy. So the biggest picture here is that our body is going through a lot of shifts to make that miracle of life. And the biggest thing from the immunological standpoint is that our body has to have maternal tolerance. So the fetus is half not self. And so there has to be tolerance so we can carry that baby full term. Importantly, a woman who is pregnant is not globally immunosuppressed, but there are very definite qualitative immunological changes. Because of that, we do see that some infection risks are increased. For example, listeria, which is the reason that we do have women avoid uncooked deli meats or raw cheeses. We also know that some infections can be more severe for women who are pregnant, especially things like influenza or varicella. But of course, comorbidities will also impact those risks of their immunological system as well. And so this is a summary looking at all those big changes that are happening with our immune system during pregnancy. So we will see that compared to prepartum, our T cells actually are going to be lower in terms of levels. We see that those high estrogen levels are going to promote more Th2 type responses. The elevated progesterone is going to inhibit Th1 responses. And we actually see increased proportion of T regulatory cells in early pregnancy as well. B cells actually start to reduce in number, especially in that third trimester. Likely some of them are migrating into the tissues, even into the placenta itself. And then estrogen has an effect on lymphopoiesis as well. Immunoglobulin levels will also fluctuate during pregnancy, especially IgG tends to reduce on its own in late pregnancy. IgM tends to stay fairly stable, which is kind of that first response to those infectious pathogens. And then IgA starts to lower in that third trimester. Neutrophil counts go up, monocyte types will change and the reactivity will changes, and then even markers of things like CRP, fibrinogen, D-dimer, and complement activity will be elevated. So that graph kind of summarizes those changes. So all those changes are happening to really allow that that woman to stay as healthy as possible and have a healthy pregnancy outcome with that maternal tolerance. Fertility. Fertility, the good news, is not directly impacted by MS. However, women with MS do get pregnant less often than the general population, and so that may be some choice that they're making based on their disease or potentially disability. The good news is this is changing. So we've seen that from 2006 to 2014 in surveys, that number was increasing from about 7.9% to 9.5% about. So we're seeing some improvements that more women with MS are choosing to get pregnant. However, even though there's not clearly increased risk of problems with fertility with MS, we know that can be a problem with women, especially who are delaying pregnancies. And when we're talking about potentially modifying what we're doing, their disease modifying therapy, we don't want to have gaps in therapy for long periods of times. So for most women, we wait a good year before we would refer to a fertility specialist if they have not become pregnant with unprotected intercourse. For a woman with MS, we'd recommend that if they've had unprotected intercourse for 6 months and not become pregnant, that we would offer that referral earlier on so we can help them have that successful pregnancy. Can also give them some helpful tips about ways to monitor their cycle. There's some kits out there, there's temperature monitors, but there's ways we can help them be a little bit more successful in their attempts as well. Overall, about 8% of women are diagnosed with infertility, and we see that women with MS are less likely to receive fertility treatments. In the past, we were concerned that some fertility treatments could actually provoke MS relapses. As we've looked at more of these studies and more data over time, we are not clearly seeing that the fertility treatments are provoking risk of MS. So that's good for patients who need those as well. We do also see that the risk of MS is going to be lower in women who are going to stay on disease-modifying therapy throughout their fertility treatments. For patients who may need to do IVF or in vitro fertilization, we do not need to hold their DMT for when they do egg cryopreservation, but when they're doing egg transfer, we would consider that the same as this for their truly attempting conception with how we time their DMT as well. What about pregnancy outcomes? Do women with MS have different outcomes? And the big picture here too is not overall significantly. And when we look at MS itself, we actually see that women with MS who have been pregnant overall tend to have a little bit better MS outcome in terms of long-term disability than those who have not. Knowing that that may be some self-selection there as well, that healthier or women with less disability may be more likely to consider pregnancy than women who have more disability at baseline. We know that MS by itself is not making the pregnancy at risk, but the disease-modifying therapy can. And so we need to understand those in more detail too. We do see potential for somewhat lower birth weights in women with MS compared to those without. The difference is relatively small, a 3.4% risk of lower birth weight compared to 2.8% in the general population. C-section rates can be slightly higher, but no major impact in the risk of prematurity or adverse maternal outcomes like preeclampsia and things like that. For delivery, patients like to ask us a lot about this too, and really the delivery should be indicated by OB indications. So how are mom and baby doing? And so we do know though that women who have significant disability, especially if their EDSS has more than 3, where they're having some motor disability especially, they are more likely to require an assisted delivery or C-section, about a 44% rate there versus 30% rate in the general pregnant population. Very importantly, they are okay for anesthesia. They are safe to get those epidurals, safe to get those spinals. No increased risk of disability or relapse has been noted with those. Looking at the risk of relapse from MS, it does change over time over the course of the pregnancy. So that first trimester, the risk of an MS relapse is not really different from prior to getting pregnant. As the pregnancy goes on, that risk begins to drop. However, it's reduced in that second trimester and a little bit further reduced in that third trimester. Postpartum, there can be a higher relapse rate, as much as 1 out of 3 in older studies. Our newer studies are noticing rates closer to about 12%. So we're seeing some improvements in that, perhaps in how we're treating women with MS. We definitely see that prepartum disease control is going to influence how they do during pregnancy. So if they're well controlled going into the pregnancy, what DMT on, that's going to influence these risks a lot too. Many of our patients will tell us that when they're pregnant, they feel great. They feel that a lot of their older MS symptoms are less noticeable. But this is also not always the case. And so I would never promise that to any woman, because everyone's pregnancy is different. Someone will still struggle with other pregnancy-related symptoms, but it is wonderful for those patients who do get to experience it. Pregnancy relapses do happen. They are more likely to happen in younger individuals who are under the age of 35. If they've had a relapse in the year prior to conceiving, again, why we really want to stabilize them as much as we can before we try a conception. And then if they started medicines like fingolimod, other S1P modulators, or natalizumab, we know that those medicines, if we stop abruptly, have a high risk of rebound. But there's ways we can modulate that. We're going to talk about those in a lot of more detail too. If women are relapsing during pregnancy, we can safely use corticosteroids. We should not use dexamethasone, methylprednisolone, prednisone, or prednisolone are all safe to use. We can also safely use plasma exchange or plasmapheresis for a refractory relapse in a pregnant patient if we needed to as well. What about MRI monitoring? We can definitely do it throughout pregnancy. I think by default, we try to avoid anything in that first trimester, just because in that first trimester, we know the risk of miscarriage is fairly high. And so if a patient goes through any procedure and then has a miscarriage, there's always that concern of potential contribution. But we do have no evidence that MRI is harmful at any point in time during a pregnancy. However, we do absolutely avoid the use of gadolinium. It does cross the placenta. It is water soluble. And so the fetus is actually going to have more exposure to it. So absolutely want to avoid gadolinium during a pregnancy. However, post-pregnancy, even if they're breastfeeding, it is compatible. All right, so hopefully you feel more comfortable with what's going on during pregnancy, how we can cancel our patients. Back to this patient. So for Glenda, as she's thinking about potential pregnancy in the future, we know she has a spinal cord burden at her time of diagnosis. She is young, and so we know that continuing highly effective therapy is still very much indicated for her treatment for MS. However, we also know that if we stopped her ozanimod abruptly, there's going to be a high risk, about a 34% risk, that she would have a rebound relapse. And so therefore, we really want to protect her from that as well. We don't just want to stop that therapy and see what happens. And so after discussing risks and benefits, we discuss transitioning from ozanimod to a B cell therapy, in this case, ocrelizumab, because of its long half-life. So let's talk more about disease-modifying therapies in pregnancy and get more comfortable with those. Importantly, oral therapies we cannot and should not continue during pregnancy. Teriflunomide has the biggest black box warning. We know that it causes fetal malformations. But if there is an unintended pregnancy, there is a rapid elimination we can do with cholestyramine, and should do, and then check the level to make sure that we have zeroed it out after we've done the cholestyramine. All the S1P modulators have been found in animal studies cause developmental toxicity at doses that are less than the human doses. However, again, we don't want to stop them abruptly in any setting, including women who are thinking about getting pregnant. And we can consider transitional B cell therapies for these patients, especially to reduce that rebound risk. Fumarates, the studies we're seeing now have not seen risk with early first trimester exposures. And so expert recommendations now are that we can probably continue those up until the time of confirmed pregnancy. They have a very short half-life that they can get out of the system, but we wouldn't continue them throughout the pregnancy. With cladribine, that is a chemotherapeutic agent, so of course we'd avoid it with plans for pregnancy and need to wait 6 months after that last dose. Injectable therapies, on the other hand, are very low risk. Glatiramer has been and can be continued safely throughout pregnancy without any concerns. Interferons, we can continue them until we have a positive pregnancy test. Possible small risk of birth weight, but that data is relatively mild as well. And then thinking about our monoclonal antibodies, so they require placental transfer. That placental transfer does not occur during that first trimester. In order to have it, we need that neonatal or FC receptor, and those are not highly expressed in that placenta until getting into about the first 20 to 22 weeks of pregnancy, when they're going to start being expressed. We typically do not dose B cell therapies during pregnancy because that would expose the patient to a risk of B cell depletion that could impact their B cells and their vaccination schedule. However, we do safely use them both pre and post pregnancy. So again, we're seeing that transfer really developing more in that late second trimester. So the expert recommendation is to avoid pregnancy for about 3 months after doses of medicines like ocrelizumab, ublituximab, and rituximab. Ofatumumab has a shorter half-life. And so for that one, it's out of the system within about 2.5 months, which is also about where we start to develop those FC receptors. And so that one could be stopped at the time that pregnancy was detected as well. We need more data to feel more comfortable because there's never enough data in pregnancy. There are a couple of studies that are enrolling, but unfortunately these results are not yet fully published. They were just completed last year. So we're looking forward to having more about these B-cell therapies in the future. Our other monoclonal antibody, natalizumab, we know that 40% of women would experience an interpartum relapse with stopping that abruptly. And they can have about a 10 to 20% risk of long-term disability from those relapses. And so if we have a couple options here, we can then transition to another therapy, or we can think about extended dose intervals during early pregnancy, doing those doses every 6 to 8 weeks, up through close to week 32, and then waiting until postpartum until resuming. If we continue natalizumab through that third trimester, then we're more likely to see hematologic abnormalities in the newborn, especially anemia or thrombocytopenia that we would need to screen for as well. And again, bridging with B cells would be another therapeutic option here for patients who are thinking about pregnancy. For alemtuzumab, that's another monoclonal antibody, is recommended to wait at least 4 months after that last dose prior to considering pregnancy. And then vitamin D has some evidence of benefit too. This is a great study done back in 2016 where they took women who with MS and so they looked at their vitamin D levels during that first trimester. What they saw is that women who had lower vitamin D levels during that first trimester of pregnancy, they saw that actually the fetus had a higher risk of developing MS in the future. So this is a potential also modifying factor that we can look at as well. And so we should be usually are talking about vitamin D with most of our MS patients, should also be talking to it about our pregnant patients as well. On the other hand, we know that very high vitamin D levels actually can increase the risk of osteoporosis or osteopenia. And so we don't want to get too much of a good thing. So most of us are going to pick a level somewhere in the range of 50 to 90 to keep them therapeutic. All right, coming back to Glenda. She did very well with that transition on therapy. No issues. She is married now. She plans on thinking about stopping birth control in about the next 6 months. She's taking a prenatal vitamin. Very important. We make sure our patients are taking at least 400 micrograms of folic acid on a daily basis if they're thinking about getting pregnant. Her vitamin D level looks normal. She's taking 2,000 units a day. And so we discuss waiting after her initial ocrelizumab infusion, or after her next ocrelizumab infusion to get pregnant. We talked through those issues regarding what to expect with MS in pregnancy, the what ifs of if she were to have relapse symptoms, how would you evaluate them, whether we could do MRIs. And importantly, we talk about whether she's thinking about lactating, and we talk to her that we encourage her to think about breastfeeding as well. We make the plan that if she is pregnant, please let us know. We plan to see her during that second trimester to make a postpartum plan. And this is kind of a summary that's kind of talking about what we've talked about, looking at fertility, pregnancy, childbirth, postpartum, really kind of looking at following our MS patients throughout them to make sure that we're really taking care of them throughout that course. So let's talk more about MS and lactation. So there have been actually several studies, and we put them all together. They did find that exclusive breastfeeding without supplementing with formula or other foods is associated with about a 37% reduction in the reduction of relapse. So that's a really good reduction and very encouraging. We also know that breastfeeding is good for baby, good for mom, crossing of those helpful antibodies to baby. So really want to encourage that. But we do want to think about the medicines. So I'm going to give you more evidence about talking about how monoclonal antibodies and injections are safe to use in our patients who are want to breastfeed. Try to avoid Benadryl as much as we can because it can have some impacts on the milk supply. If we do need to use steroids for any reason around time that someone is breastfeeding, there can be minimal amounts of methylprednisolone in breast milk. However, these amounts seem to be fairly minimal. Waiting even a few hours post-infusion can limit that infant exposure. And then gadolinium, as we said before, is safe for women who are breastfeeding. Less than a 0.4% of that dose is excreted into breast milk. So it is recommended that women can be given that gadolinium if they're breastfeeding. So when we think about our disease-modifying therapies, a lot of things go into thinking about how it's going to be passed into breast milk or not. The drug's molecular weight, its protein binding, lipid solubility, volume distribution, how it's transported, what happens once it enters the newborn's gut system. And then, of course, looking at potential risks to infants. So looking at all of those factors, we see that injections and monoclonal antibodies are very reasonable, consider that they really don't have biological effects. for an infant and are treated in very low amounts. These medicines are very large molecules, not very well crossing into the breast milk. They are proteins that we know are not orally available. Otherwise, we would not give them through injection or IV. We'd be giving them orally. So they are broken down by the gut system. So small amounts that might get in would be biologically inactive. So we know that we can safely use those medicines. On the other hand, oral therapies are not safe for lactation. These are small molecules that do readily pass into breast milk more easily, and we know they are orally active. So we would not feel comfortable using any of our oral therapies during lactation. This is a chart that's kind of summarizing what the USDA says and the European Medical Association. Importantly, we always know that the FDA recommendations are going to be much more conservative. And so the FDA's recommendations are going to be different a little bit in terms of what we recommend in clinical practice. But everybody agrees that we should not be using oral therapies during breastfeeding. Just looking a little bit more at B-cell therapies, lactations. Usually we're going to wait at least 2 weeks postpartum. We want to allow women to get that colostrum in, get mature breast milk, and establish good breastfeeding. And that especially is going to occur that first week postpartum. And then most of us are going to try to resume therapies about 3 to 4 weeks postpartum anyway. The dose that is considered to be safe for a relative infant dose is less than 10% for most of our MS meds, as we talked about before, except the orals, it's going to be a less than 1%. So again, very reassuring. And then more data is coming from Sopranino. The trial finished in 2024. We just don't have those full results yet. All right, back to Glenda. She's now pregnant. Saw her during her second trimester. Saw her telehealth because she was doing a lot of opiate appointments and things like that. Says her first trimester nausea, fatigue have improved. She clinically feels stable. She's planning to breastfeed. We do want to encourage her to make sure she gets all the recommended vaccines during her pregnancy. Those are safe to do, giving both her protection and protection for the baby. And since those B cells, her B cell therapy is not active, may she have more B cells to have that more of a response for her for protection as well. We do discuss the risk of postpartum relapse, which again can be 11 to 33%, depending on which data we're looking at. We talk through the safety data regarding her DMT and breastfeeding, and we're going to plan that postpartum, we're going to do an MRI and see her back at 2 weeks to see how she's doing with that MRI, with the plan that if everything's going well, we'll be resuming her therapy about 4 weeks postpartum. Glenda develops and delivers a healthy infant, no complications. On that postpartum visit that we see her in 2 weeks, she is tired but doing well. She's nursing. Her brain MRI is stable. We offer a referral for pelvic floor therapy if and when she's interested in that as well. We know that not only can women with MS have pelvic floor issues from pregnancy by itself, but also we know that MS often has bladder issues resolved with that. And then we resume her therapy 4 weeks postpartum. The typical pre-dose of diphenhydramine, we just keep as a PRN available for nursing staff rather than giving it upfront. So we're less likely to affect that milk supply. So again, great news. Those postpartum relapses overall have reduced over time. But do remember that women who have a more disability at baseline have a higher scale on that disability scale, what we call expanded disability status score, EDSS. Women who are younger, who had relapses prior to or during their pregnancy, who weren't on DMT prior to getting pregnant, or if they discontinued one of those S1P modulators, natalizumab, all of those individuals are going to be in that higher risk category still. And so we really do want to prioritize and getting them back on a safe therapy quicker. We have not seen any benefit with doing prophylactic steroids, IVIG, or hormonal therapies with preventing these postpartum relapses. And so those were tried in the past, but not medically recommended. We would only use steroids if there is a known relapse. Men are part of this equation too. Babies don't happen on their own. And so we do want to acknowledge too that there can be some concerns about DMTs for men as well. Teriflunomide is one of those. We know that teriflunomide can be potentially transmitted via the semen of males. However, it looks like the risk of teratogenicity of that is very minimal. There was a registry in Denmark. It was a relatively small number, but only saw one fetal malformation, which wasn't clearly attributed to the medication. In the US, it is currently the recommendation that we counsel our patients that we don't recommend that they father during treatment with teriflunomide. However, I don't think the data really is there to say that conclusively as well. On the other hand, cladribine, that is again a chemotherapeutic. It interferes with DNA synthesis. It does have the potential to cause fetal harm through that mechanism of action. And so men who are potentially able to have children while they're on cladribine should be advised to be using contraception and do that for 6 months until 6 months after their last dose. So we've talked a lot about MS and disease-modifying therapies. We don't want to forget about MS symptomatic management. So that's always an ongoing issue for all of our patients, especially bladder and bowel issues. So remember that first-line therapy would be that pelvic floor therapy referrals. They can do wonders for many of our patients, but we can also use pharmacotherapies and then certainly can refer on for additional therapies as well. Looking at some of the symptomatic medications that we use commonly. So baclofen, there is concerns for toxicity for a fetus in animal studies. And that's going to be true really for all of our muscle relaxants that we do see that animal studies do not have safety with any of our muscle relaxants. Gabapentin, there was animal data that showed a risk of harm and death. Again, that's going to be really more in that early period. I have seen that OB-GYNs have been okay with gabapentin in that second trimester and beyond. But again, during that first trimester, we know there's so much organogenesis. We really want to avoid medications that could be potentially causing harm. Medicines for bladder or overactive pituitary, no risk of teratogenicity regarding with animal data, but we don't really have any human data. Remember that modafinil that we may use for fatigue, especially at high doses, could reduce their effectiveness of hormonal contraceptives as well. And sorry, this did not turn out very well on the slide in terms of those breaks there. And then for baclofen with lactation, probably safe, very low levels are going to transmit into the amount of milk. Gabapentin is considered safe with lactation as well. On the other hand, tolterodine for bladder, we don't know that it's going to be, we don't really know how it's going to be effective. And we do know that any anticholinergic can negatively impact milk supply as well. Thinking about other demyelinating diseases, neuromyelitis optica spectrum disorder, unlike MS, excuse me. Unlike MS, where we know that the risk of relapses tends to go down during pregnancy, with NMO, there is going to be a persistent risk of relapses. And so typically we are going to continue therapies as much as we can. I get a drink real quick. If a patient has responded to IVIG, that can be safely used during pregnancy as well. For MOGAD, Risks are not as clearly defined because it's a rare disorder. So we don't really know the course during pregnancy for the average patient. But again, IVG can be safely continued for this. Mhm. All right. I hope you feel better empowered and more knowledgeable about MS and pregnancy. I do want to leave you with a few important resources available. So your local MS neurologists are here for you. That's our job. Also consider high-risk OB, especially patients who have other comorbidities. So any woman who is over the age of 35 is considered a geriatric pregnancy. Yes, it's a very insulting term, but it's what it is. So women over 35 are already going to be going to see MFM, but patients with obesity, hypertension, diabetes, I would highly recommend that they have a pre-conception counseling appointment. And I know that MFM does these via telehealth to make that easy for patients. So you can just put a referral in for them as well. For any of you out there who clinicians are not using open evidence, it's a great resource, not perfect, but can be helpful when you have questions. LACMED is also a wonderful resource available free online. It has a list of safety of these medications as well. All right. A few helpful references for you. We have, I think, a few minutes for questions, or I think we're about right on time.
And I can go around with the mic just so that everyone can hear your
Hartman,
question.
for this very comprehensive lecture. You'll definitely have looked at MS, pregnancy in both directions. You looked at all the potential aspects of this very important topic from DMT to symptomatic management. Thank you. And one more website, which I absolutely love, it's Mother to Baby. It's a Canadian website. It talks quite a bit on symptom management in MS and gets updated every few months with new information in relation to the safety of any medication, basically, during lactation. Any question for Dr. Hartman?
That's a silly question. Exclusive breastfeeding, I use that term all the time. What does exclusive breastfeeding mean?
So exclusive breastfeeding means that they are only feeding the infant breast milk. They're not supplementing with any formula or other food.
Pumping is okay.
Pumping and dumping would be the same.
Yeah. Yep. So it is breast milk, but it doesn't have to come directly from the breast as it's eaten. Pumping counts as well.
So Neil, if you also wonder about, exclusive breastfeeding, the point is the prolactin, right? So there is some anti-inflammatory effect of prolactin, but there's also some pro-inflammatory. We're not going to talk about it. When women pump, even if they are storing, you're doing for the prolactin, and prolactin is doing what's supposed to be doing, and it's protective. So it doesn't matter if the woman carry the baby and breastfeed directly, or she gives them saved milk.
And these are my two offspring. So, yeah. Thank you all so much for your time and your attention. Appreciate the opportunity.
Thank you, Dr. Hartman. All right. My presentation today title is called From Phenotype to Endotype, Rethinking MS Through Mechanistic Lenses. And it sounds very complicated, but the idea is very simple. We're going to be talking to how MS present to potentially what is driving MS under the surface. So basically the phenotype is like the tip of your iceberg. And basically everything else that is happening in MS is below water level. And with that said, all righty. So these are the objective of my presentation, is to understand how MS pathology has evolved from a pure inflammatory model to chronic inflammation and neurodegeneration, and then recognize the limitation of our current disease-modifying therapies in addressing this chronic inflammation and neurodegeneration, and then review emerging therapeutic strategies, including BTK inhibitor, and CAR-engineered immune cells and their potential roles in targeting chronic CNS inflammation, explore the scientific principles behind CAR-T and CAR immune cell therapies, including how allogeneic and engineered approaches may offer precision immune modulation, and discuss the future landscape of MS treatment with an emphasis on how novel immune engineering technology could reshape therapeutic approaches. Yet, phenotype is very important. While my presentation is going to focus quite a bit on below water level when it comes to the pathophysiology of multiple sclerosis, phenotype is very important. Phenotype, it's because of phenotype we're able to recognize the new epidemiology and demographics of multiple sclerosis. MS, that was commonly presented as a disease of the Caucasian childbearing woman between the age of 20 or 40, is changing phenotype. Some of you have been here last year in our MS Symposium. I took quite a bit of time talking how the demographics and epidemiology of MS is changing. Particularly, MS now is happening more often in women of African American descent, and it's becoming more a problem of or disease diagnosed in middle age, i.e. 45 to 65-year-old. This is beside the fact that the incidence and pregnancy of multiple sclerosis is increasing in the world, not only because of improved recognition of the disease, but also due to real biological and environmental factors that we still need to elucidate. The phenotype of MS is also very important, and the phenotype continue to get broadened. It has been known since the 1970s that people can harbor demyelinating lesions without expressing the disease. This has been known from autopsy studies. And this type of findings was further supported by the landmark paper by Darren Okuda and colleague from UCSF, who actually describe what we call the radiologically isolated syndrome for those patients who are found by chance to harbor demyelinating lesions and fulfilling 3 out of 4 Barkov-Tintoret criteria, which is a little bit more conservative than our criteria for dissemination in space today. In parallel to that, we have always known that those patients with a family history of multiple sclerosis, particularly first-degree relatives, they have a heightened risk of multiple sclerosis. And it's not unusual that sometimes you do an MRI on these family members for a completely different reason, and you can find demyelinating lesion that could be as minimal as 1 periventricular, but some of them also will fulfill the Barkov-Tintoret criteria. In parallel to all of that, over the last little bit less than a decade, we have known about a new entity called the multiple sclerosis prodrome. The multiple sclerosis prodrome refers to these patients who develop MS in the future. However, 5 years before their diagnosis, there have been reports of increased healthcare utilization and musculoskeletal and neurological symptoms as well as systemic symptoms. So all of these can be counted as a phenotype of multiple sclerosis that is better codified and recognized today. And in the most recent diagnostic criteria for multiple sclerosis, the group who published this paper, who are worldwide experts, they even allows the diagnosis of MS even in asymptomatic individuals, i.e. RIF, and patients with non-specific symptoms with the presence of certain specific criteria that they outlined in the paper. Of course, this expansion in phenotype should be associated with earlier treatment. If RIS is MS below water level, if MS prodrome is heading toward MS, if people with white matter disease have a family history of multiple sclerosis, somebody can make the argument that this is all MS, developing MS is just a matter of time. And of course, we can continue to argue all the time about it, right, wrong, etc. I think disagreement is healthy, but definitely we are treating people much earlier. This is the list of medications with the first one that hit the market in 1993, interferon beta. And for those of you who like English, read the introductory paper by the late Dr. Barry Arneson introducing the first approved disease-modifying therapy in multiple sclerosis. I always like to go back to this editorial because it represents one of the most beautiful written editorial that merged together literature, English literature, and science. If you look at disease-modifying therapies, you probably can identify 3 different areas depending on how we're trying to control the disease. The first era goes from 1993 to 2004, and during this era, we had primarily interferon beta and glatiramer acetate, and we had few people with mitoxantrone, and then 2004 slash 2005 heralded the arrival of natalizumab. And my time when I did my training, when I started in 2002, I had only to learn about glatiramer acetate and interferon beta. And there was, in my opinion, a lot of discussions that there were real effort to do a little bit more than that. However, the field has definitely evolved. Natalizumab definitely was changed the culture of how we treat multiple sclerosis. And then in 2010 and 2013, the oral era began, and we have here the sphingosine modulator, but also the fumaric esters, and did shift treatment paradigm. During these 2 treatment eras, there was a lot of focus on inflammation. So at the beginning, we wanted to treat inflammation, and we realized with the first era that we're treating partially, but we are treating. Those of us who have been in the field for so many years will know that even these treatments did make a difference. I'm going to keep the last era to a little bit later, but it is an era that is characterized by what we call HET, high efficacy monoclonal antibody or high efficacy therapies. And here we have alemtuzumab, ocrelizumab, obinutuzumab, and we also have subcutaneous that are important for patient convenience, like ofatumumab, and we have the oral option that can cause that work by immune reconstitution, such as cladribine. So this is the natural history of untreated multiple sclerosis before having the first interferon, but we also have the post-disease modifying era. This is taking into consideration only era 1 and era 2, meaning this is data not including highly effective disease modifying therapy. So it's only the first 2 era, the platform, natalizumab, and the oral. And what you can see is all good news, despite what patients might believe. Annualized relapse rate dropped from about 1 relapse per year to 1 relapse every 5 years. And median time to the EDSS was prolonged. So the EDSS of 3 is considered moderate disability, and that time was prolonged from 10 years to 20 years. Median time to EDSS of 6, i.e. using a cane, also was prolonged from 15 to up to 30 years. The percentage of people reaching an EDSS of 6 after 15 years has also decreased by half. I think 50% is good about almost every outcome. It's either a delay by double the time or a decrease in disability by 50% if you look at these numbers. Conversion to secondary progressive MS, 65% did it by 20 years before DMT, and 30 to 40% after DMT. Cognitive decline at 20 years decreased from 60-70 to 30-40, and employment retention improved from 40% to 70%. And these are actually great numbers, and mortality gap. Previous to disease-modifying therapy, we used to think that a patient with multiple sclerosis has a decreased longevity by similar to somebody who smokes 2 packs of cigarettes per day, which is about 5 to 10 years. And interferon beta, the 20-year long-term data has showed that people who received interferon beta, as simple as what we call an injectable platform, these people had normal mortality, meaning their mortality was similar to anybody who did not have multiple sclerosis, which was, in my opinion, a very powerful paper to show that disease-modifying therapy can, in fact, improve mortality. Now, this graph is going to talk a little bit more about some unexpected finding in multiple sclerosis treatment, and typically unexpected finding are very educational, because most of the time you look and you say, what's happening? What were we thinking? So I wanted to follow. So you have the y-axis, which is the current treatment, the EDSS, and you have the x-axis time. The first graph, which is in gray, very light colored, refers to the natural history of multiple sclerosis pre-DMT era. And you can see that people will relapse with incomplete recovery. With time, with age, they have less relapses. And in between relapses, there is slow insidious progression. So this was the natural history of untreated multiple sclerosis. And then we had the highly effective disease-modifying therapy. And we thought, wow, with a 70 to 80% decrease in relapse risk and with 90% control of new disease activity by MRI, we thought we controlled MS. And we thought the natural history should be like this black line. Patients are going to be symptom-free, relapse-free, until you have the secondary neurodegeneration. And then you're going to see what we call the secondary progression. So if you start somebody early, you're probably going to wait 30, 40 years. They will have normal lives. There is nothing happening. And then they will have the natural progression. Unfortunately, this is not what was expected. We were very good about shutting down inflammation. As you can see, no relapses. And you look at MRI, patients are seen daily in the clinic. They don't have any disease activity. And we always get this question. It's now like a rhetorical question. You're telling me I'm progressing, but my MRI is stable. And this is what was happening. No relapses, but very slow insidious progression. And this has been called PIRA, or progression independent of relapse activity. And it is driven by hidden inflammation trapped inside the brain and spinal cord. And that hidden inflammation is also a paradigm shift in our understanding of multiple sclerosis, where we thought that inflammation quite a bit came from the periphery. So this is a slide that summarizes all the failed trial in progressive multiple sclerosis, in secondary progressive and primary progressive MS. And there have been a lot of them. And this is probably not an exhaustive list, because as you can imagine, nobody wants to publish a negative trial. So I think the the scientific journal that publishes these trials, they still get a star and an award for even accepting to publish a clinical trial. However, right now, it's very clear why we're not able to control, because we're trying to treat the disease, focusing on inflammation, and the pathophysiology was completely in a different direction. It was a complete mismatch before what we thought is MS is, and between what MS is indeed is. So basically, we were following the phenotype of MS, how MS presents, etc., and we were not following, or we did not recognize what was driving MS below water level. So what are these concepts in MS pathophysiology, or that's what I call the endotype? And each one of them can take hours and hours to talk about. I'm going to try to make it as simple as possible, because I know immunopathology is not one of the forte for a lot of people. However, the disease starts with what we call beneath the surface, subclinical, preclinical disease. This is what we discussed earlier, radiologically isolated syndrome. Patients with family history of multiple sclerosis harboring asymptomatic demyelinating lesions that are present by chance. People with MS prodrome. So these are people who have the potential for multiple sclerosis, or this is what we thought about them, but this is probably as early as possible as the beginning of the disease. And some of them will come with a brain loaded with lesions, even at this point in time. But at least from what we know, this is as close as it can get to knowing the beginning of multiple sclerosis. And then you have, I call it constellation of mechanism endotype, constellation like in the space thing. So what's going to happen, so you have somebody with the potential for MS, and they will be some unknown environmental factor, some unknown biological factor, some combination of both, some other factors that we don't know what it is, Epstein-Barr, food we eat, etc. And suddenly, these asymptomatic cases now are committed in one direction. So they are going to start moving, heading toward the diagnosis of MS until you have your first attack. And with the first attack, we know that axonal injury happened. One of the well-known landmark paper on axonal injury in very early in MS is the paper by Bruce Trapp. It comes from 1998, where he showed from few patients only that axonal injury happened very early with MS and even what we considered first relapse. And whenever there is axonal injury, now the axons are suffering. There is a stress on the mitochondria because now the axon needs to heal. And in order for the axon to heal, it needs to use energy. And that will create an oxidative stress that is going to feed into the present inflammation, particularly within the brain, or what we call a smoldering inflammation. And that's what I call the compartmentalized CNS inflammation, or the fortress within, because we have a fortress inside the brain. It's hidden from it's not hidden, but it is shielded from the disease-modifying therapy that we are using, and therefore we end up not treating that inflammation. And then that smoldering inflammation is going to cause what we call the fog of war. There is a lot of smoldering inflammation, diffuse gray matter, and smoldering lesion. And then you have the silent progression in the shadows, gray matter damage, and slow burning lesion that evade detection, or what we call smoldering. When I first started in Omaha, one of our colleagues who's not here with us, Kathy Healy, she always used that term, smoldering inflammation. And those of us who know Kathy, they know that she was always ahead of her time. And then once you have diffuse gray matter axonal injury, you have also the failure of remyelination, and that's what we call the broken blueprints. So now that we have all these mechanistic explanation of why MS responds to treatment the way it responds, we might be able to formulate a way to treat it more precisely. And you heard me saying precision medicine, and I know now almost everybody use that word, precision medicine for this, precision medicine for that, but I promise you, this is as precise it can get in comparison to any other field of medicine, so stay tuned. So to summarize, there are the pathology that drives a progressive multiple sclerosis are the classic inflammatory white matter lesions, the way we have all learned it 20 years ago, 30 years ago, 40 years ago. But we also have now the B cell rich lymphoid aggregates and monocyte aggregates. So you have the lymphoid aggregate in the subarachnoid space in a structure that is reminiscent of a lymph node. But these structure, we call them lymphoid because they are lymph node-like, and they are in the subarachnoid space, and they are responsible for cortical demyelination, meaning also demyelinating the neuron, demyelinating the dendrite against around the neuron. And then we have this type of, in addition to the B cell lymphoid aggregate, we also have microglia, activated microglia that are dispersed in the brain. And sometimes we also have microglia that aggregate together, forming what we call microglial nodule. And all of these immunological cells will contribute to what we call slowly enlarging lesion with microglial rim. We call them cells, S-E-L, small s for the plural. And they are also called what we call paramagnetic rim enhancing lesion or pearls. So we have cells and we have pearls, okay? And then it's very important to remember that one prognostic factor and for progressive disease, or one contributor to progressive disease is age. Age. And we talk about age quite a bit in the clinic, why MS is getting worse now that I am 50, 55. And age is very important because with age, you also have a decrease of the brain reserve, or the way I say it to patient, decrease of the money in the bank of your brain. You have less money in the bank of your brain, and therefore you progress. So the question is, how can I diagnose all of that, and how can I show my patient? Well, the technology is available. It's not perfect, but it's also not implemented in day-to-day practice. However, conventional MRI, if properly used, and if you have a neuroradiologist who knows physics well and who can fine-tune, conventional MRI, particularly 3 Tesla, can be used in day-to-day practice to do that. But it is a time-consuming. So how do we look at cells and pearls in unconventional MRI? So as I expect, cells are slowly expanding demyelination due to low-grade inflammation. So these are the equivalent of what we call on pathology combined active lesion. You look at the plaque, it's empty from the middle, and there is a rim of inflammation. So these are the cells. And how do you look at the cells using conventional MRI? You cannot look at the cell by doing one MRI. You have to do serial MRI, and you have to use that technique, 3D FLAIR or a 3D T1. We in the Med Center, we have the 3D. It is still a picture in 2 dimensions, but when they are cutting one by one by one. That's why it's called a 3D. And the radiologist has the way to view a reconstruction. So when they want to look at cells, they can look at the volume of each cell. So basically, the way they do it is you're going to follow the people. You're going to do this technique. And at certain point, you're going to have to decide, is it 1 year, 2 years, 3 years? You're going to calculate how much of the brain around the cell is distorted. This is a technique called Jacobian calculation. Nothing that you need to know. I had to read about it to understand what Jacobian. But basically, they look at the distortion of the brain around the lesion, and you can imagine that as the lesion is getting bigger, there is a different distortion, and they calculate the cell and how much it grew. The other technique, which is paramagnetic rim enhancing lesion, also referred to a combined active lesion, where the center of the lesion is empty, but then you have microglia. But the difference here, it's paramagnetic because it has iron. And pearl means higher level of severity than cells. So a pearl is a cell, but a cell is not a pearl. I hope I'm not confusing you. So cells are very common. People can have them. Those potentially with very aggressive disease can have more pearl. So basically, your pearl is a cell plus iron, okay? And the way you look at a pearl is you do this technique, susceptibility weighted imaging. It's an iron study. At the Med Center, we have it too. And I think several places do it. It's used for stroke and it's used for hemorrhage. You can see iron in it. And we call that technique T2 star GRE and a flare. So what you see in a pearl, you see the center of the lesion. It's a white lesion. It's hyper intense lesion on T2. But then the rim that has iron is hypo-intense. So basically, a white lesion, the way we know it on T2, is surrounded by a hypo-intense, i.e. dark rim. All right. So the question is, okay, so now we have all these fancy drugs. We shut down inflammation. Can we intervene? Can we intervene? So this is a paper that Dr. Arcot and myself wrote 3 years ago about promising treatment called Bruton tyrosine kinase. And as I was looking at the paper this morning, I thought we put the missing link for treatment optimization. And I had to think, was I optimistic or was I cynical? And truly, I don't know the answer, but I really thought in retrospect, I do that exercise quite a bit. I do it in the clinic when I treat my patient. I always look back. Did I do it the correct way? Did I do it the wrong way? Same thing. I had to ask myself, what did I have in my mind? And was I correct to make it like a question? It didn't matter if it is Cartesian, doubt, or it was cynicism, or it was a rhetorical question. But I think where we are here 3 years later, we definitely have reason to keep that as a question mark. Stay tuned. So, as you know, there have been several Bruton tyrosine kinase molecule being tested. Bruton tyrosine kinase are small molecule. A lot of them were designed to cross the blood-brain barrier. They are small molecule, unlike what you call unlike monoclonal antibody. So a lot of them were done to also be highly concentrated in the CSF. So the first trial was evobrutinib in the relapsing remitting study, Evolution 1 and 2, following a phase 2 that showed some encouraging result with fewer MRI lesions at higher doses and signal of activity on MRI by showing less cells volume. The sponsor took it to phase 3, where it was tested in a non-inferiority trial against teriflunomide, an FDA-approved medication under the brand name Obaju. And unfortunately, there was no superiority between teriflunomide and evobrutinib in both trials, and there was no meaningful benefit on secondary outcome. At the same time, safety was an issue. Liver enzymes elevation were more frequent, 5% in evobrutinib versus 1%, which is known to be hepatotoxic. Like, teriflunomide is known to be hepatotoxic, at least per FDA label, but clearly evobrutinib caused more toxicity. And what happened is FDA had to pause enrollment in 2023 over liver concerns, but this was lifted later, about a year later. However, with the recent phase 3 results, Merck Serono terminated development of evobrutinib of MS. And maybe one of these days, I will give you a lecture about the tale of the tale of a failed disease-modifying therapy in multiple sclerosis and what we have learned from it, because it will be a very, very interesting topic to talk about. Now, tolebrutinib is another Bruton tyrosine kinase inhibitor. This one was actually designed on purpose to have the highest concentration in the CSF. So in two phase 3 trial, Gemini 1 and Gemini 2, relapse rate against teriflunomide, there was no difference, didn't show any difference. So this is something where they kind of meet with evobrutinib. And 6 months disability progression, there was a trend toward improvement. But a lot of the newer trial, the way they do the statistical analysis, it's called hierarchical, meaning if your primary endpoint fail, it doesn't matter what you find with secondary and tertiary and so many endpoints. It failed. We call it hierarchical. You need to have the primary endpoint successful, and then you can do the analysis. And then safety, again, 4% had elevated LFT. Hepatotoxicity was the main risk. And then, interestingly, GAD lesions were higher. And the new or enlarging T2 lesion, they were similar. Brain volume inconsistent. And then they did an exploratory finding. And exploratory finding could be good science. And I think it's useful science too, because it might tell you something about behavior. It might help you to tweak your next clinical trial. possible benefit in certain lesion subgroup. So again, the conclusion was no clear clinical superiority in relapsing MS. Main concern is liver toxicity. But tolebrutinib has showed some positive result in a stubborn disease to treat. It's non-relapsing, non-active secondary progressive multiple sclerosis. Again, it was a phase 3 study, double-blind, placebo-controlled, 1,200 non-relapsing secondary progressive MS, 60 milligram daily versus placebo for about 2.5 years, 2-to-1 randomization. So 2 people get the real drug and 1 get placebo. Clinical result, there were 31% lower risk of 6 months confirmed disability progression, 44% risk of 3 months confirmed disability progression, and that benefit was consistent across age, baseline EDSS, and prior treatment group. Overall, however, there were lower relapse rate in both groups. MRI results, 60% reduction in new enlarging T2 versus placebo, fewer new GAT1 lesion and less brain atrophy, stable lesion volume, possibly slowing of chronic active lesion. Safety was similar, and there was 1 fatal hepatic failure that a transplant related, and again, routine monitoring reduced later this issue. And then most recently, this is not a paper, this was press release by Genentech, fenebrutinib in MS, the key finding. The fenebrutinib was tested in FENtrepid, primary progressive MS, against an FDA-approved disease-modifying therapy, which is ocrelizumab. And the study showed that fenebrutinib was not less inferior than ocrelizumab over 120 weeks or more. And the separation, mean the benefit starts around 6 months, which is quite impressive, I have to say, in a chronic disease to try to separate these 2 curves around 6 months. Relapsing MS, there was the FENhance study, again, significantly lowered relapse rate versus teriflunomide. This was something observed in a phase 2 trial, and safety, early liver safety assessment consistent with prior study. So right now, the verdict is out when it comes to BTKI. So clearly, we need to do a little bit more. And that brings us to what we call the chimeric antigen receptor, CAR-T in autoimmune diseases. And you know that over the last couple of years, UNMC has been involved in 2 different allogeneic CAR-T trials, one sponsored by Fate Therapeutics in lupus, and the other one sponsored by TG Therapeutics for progressive form of multiple sclerosis. And both are phase 1 trials, so we're still very early here. Just a little bit of information about what's autologous versus allogeneic. Currently, what we use in the field of lymphoma and cancer is autologous CAR-T. And autologous CAR-T, in autologous CAR-T, you have the T cells that are made from the patient's own T cell, and therefore there is a limited patient access. It's highly personalized, and sometimes you try to expand these T cells, but because the patient has some disease, you might not be able to expand these T cells. So that's a hurdle. That's an obstacle. Long and complex manufacturing process and wait time. It required leukapheresis, means separation of white blood cell, and often extra chemotherapy treatment until the cells are ready. And then high manufacturing cost. Of course, you have to also to bring the patient and do all these procedures. And variable potency due to the health of patient-owned T cells, as I explained before. Allogeneic T cell, allo mean foreign. Allo CAR-T are made from a universal donor who is healthy, broad patient access, so multiple patients, you can treat multiple patients from a single batch, can be mass-produced, available on demand, and off the shelf. This is what we have been doing with our 2 patients. On the day of the transfer, we just bring the drug from the pharmacy, we give it in the infusion center, and then we send the patient for observation for a week on the inpatient oncology, hematology service. They are ready when you need them. They are more efficient and cost-effective, and healthy donors cell are engineered for potency and persistence. It's important to do persistence because you want the T cell to stay, right? And you're using allo CAR T, so sometimes you have the host attacking these cells because the host recognizes, oh, these are not my T cells, I'm going to attack them. So it's important that these T cells persist to do what they are supposed to be doing. This is what this is what is done with the T cell. The CAR, which is the chimeric antigen receptor, in our patient, it's a CD19. In our trial, it's a CD19. Basically, it target B cell that have a CD19 tag on their surface. So the T cell has an antigen receptor manufactured, engineered, that is going to attack the CD19 on the B cell. But I said it's allo, that means there is still the possibility of these T cells not liking the host, and they will also attack the host. So you have graft versus host, but you also have host versus graft. So to minimize the risk of graft versus host disease, what they did, they actually disrupted the TCR by CAR insertion, so that this locus, which is responsible for GVHD, is kind of muted to minimize the graft versus host disease. So let's look at the data about what we have on CAR T, and these are coming from autologous CAR T. So far there have been 2 cases, case report, and now there is an ongoing phase 1b to 2b trial in myasthenia. You have MS. There are 3 phase 1 MS trial. 2 are autologous by Kyverna Therapeutics, and our is the first one in kind with allogeneic CAR T. And I put here the clinical trial number from clinicaltrial.gov. And then it has been tested in a single patient in CIDP and neuromyelitis optica spectrum disorder. And there are talks even about autoimmune encephalitis. And I'm going to quickly go over the finding. Basically, the common theme between, or the common result between all of that yes, there is benefit, that the patient is depleted, that there is a prolonged depletion of the B cell. And I think the most impressive improvement is actually in myasthenia gravis. And this is a picture of Jan, our first patient. And there is also similar encouraging results from other autoimmune diseases, including lupus with lupus nephritis, systemic sclerosis or scleroderma, idiopathic inflammatory myopathy, ANCA-associated vasculitis, and rheumatoid arthritis. And again, these are all autologous except the lupus trial that is done by my colleagues, Dr. Lonning and Jennifer Medlin in rheumatology. And again, you're seeing some drug-free remission, minimal toxicity of the brain. And again, it's overall signal that there's safety and there is a durable benefit. So this is all very encouraging. So in summary, MS is not just a relapse. Stop chasing relapses. It doesn't mean that you shouldn't be treating them, but please stop chasing them. I'm going to do an MRI to see if you're relapsing when you are on highly effective medication. You know damn well that this is not true. Okay? Gray matter is heavily involved. Cortical demyelination underlies cognitive decline, seizure, and progression, and it's involved very early. Inflammation becomes trapped in the CNS. That's your challenge. That's what's happening above water level. Okay? Meningeal follicles and activated microglia sustain damage even without blood-brain barrier leakage. And then we end up having the slowly expanding lesion, showing slow smoldering injury, and PRL, so cells and pearls. And these chronic edge lesions reflect ongoing low-grade inflammation with gradual worsening. And therefore, MS now understood as a blend of inflammation and neurodegeneration with chronic inflammation trapped inside the brain. And we know that a lot of the progression associated with MS is more pyra than relapse associated worsening or progression. So please keep that in mind. You might want to read the article by Tur. Last author is Javier Montalban that looked at how frequent was pyra in a population of people who were just diagnosed with MS. And they also looked at how many of the progression was due to what we call raw relapse associated worsening versus pyra. Definitely, it's a very hard to digest paper, but very, very, very interesting. All right, so the question is, what do I do with all this information? I have one clinical trial that is negative, another clinical trial negative in relapsing remitting. We have one positive in primary progressive and relapsing remitting. And then we have tolebrutinib, which is positive in non-relapsing secondary progressive MS. So if you're thinking too much, I think this is the MS community between patients and the science. And then you have that person here saying, okay, am I going to get my answer with Perseus? I really think there will be a lot of pressure or a lot of great information coming from Perseus, because it will actually tell us is what we're seeing in Heracles, which is non-active secondary progressive. Is this by chance, or this is real biological improvement? Time will tell. And then is CAR-T is our next destination for precision medicine. While it might be too early to really know, and while it might be too early to know the safety, however, looking only at the science, how you can use CAR-T to treat patients, I think it is definitely, I can say it is a promising approach. This is just some of the things that the future we can do. We have the autologous CAR-T using the patient immune cell, and then we have the allogeneic CAR-T against CD19 B cell. But there are also other ways. They are now trying to do constructs, CAR-T construct against Tregs. You know, Tregs, usually we think that Tregs are deficient in multiple sclerosis. And here, you know, we're going to do something for Tregs, or what we call a smart B cell targeting. So we're going to do a CAR-T that has an antigen rather than an antigen receptor that is going to attack an antibody on the surface of the B cell. Okay. And then there's also talk about in vivo CAR-T, one-step therapy, where you put CAR genes delivered directly into the body to program T cells inside the patient. And this is a scalable outpatient option according to experts. And then, believe it or not, I did not know that, there are also something called a safety switch or suicide switch, where you can inject this type of thing, caspase-9 and EGFR-T switches, where you can halt the effect of the CAR-T if you start seeing very bad undesirable thing. Like, let's say the CAR-T start expanding so much that now you have a tumor. So really, really, really very interesting. And I think in medicine, in addition to gene therapy, this is as close as it can get to precision medicine. So CAR-T cells in autoimmunity, game changer or stepping stone? I think the verdict is out. Stay tuned. Thank you for your attention. Oh, there is none, but already at the Med Center, we're gonna start them in myasthenia gravis and the CIDP, and I highly expect that we're gonna move into what we call, they are called basket trials, where you do a trial and you say, okay, I'm gonna have some relapsing remitting, I'm gonna have some progressive in phase 2, and we're going to start moving into different neurological diseases, because TJ right now is looking into the possibility of NMOSD. So basically, you're going to move from one trial at a time. You will have like a master agreement with the company and you start doing different diseases, and you have all these neurologists who have interest in PNS or CNS working all together on different patient population, which is very exciting. So I think relapsing remitting is going to be the next step for sure if there is no safety signal.
I know, like,
Don't ask me tough questions, Dr. Gupta.
I won't. So, from cognitive neurology, like people are using now, their main problem is the antibodies, Leqembi is not able to cross the blood-brain barrier as effectively. So they're using ultrasound, high-frequency ultrasound to like open up the spaces to deliver the medicine. Is there something like that in MS?
Not to my knowledge. But the nice thing about CAR T, that we know that T cells cross the blood-brain barrier all the time. And not necessarily, one of the misconception we have always thought, like a lot of other misconceptions that we know right now is just not accurate. We used to think that the blood-brain barrier in healthy state is very impermeable and that the brain is shielded and it's a noble organ. And we know damn well that this is not true. T cells, even in a healthy brain, as I'm talking right now, presumably I don't have a neurological disease, T cells are circulating in my brain. They have a patrolling role, right? So to my knowledge, I don't know if that's available in MS, but T cell do get inside across the blood-brain barrier.
Couple of questions.
That was the first one.
One at a time. One at a time. Are there actual secondary outcome measures in these trials that measure the pearls and the cells? It looks like it's just expanding lesions. I assume those are, or not expanding lesions, but enlarging lesions is one of the secondary outcomes. And that's probably just like gross analysis rather than pearls and cells. Is that?
Yeah, I don't think there is more. So the phase one, I think it's important to highlight that. Phase one are safety, right? Is this safe in a disease like multiple sclerosis? And in the AlloCAR T trial, we also have another goal. What's the correct dosing? So we're starting with a dose of 20 million cells or 30 million. And by the end of the trial, I think we might be getting to 300 million. But this is still way less than what is used in cancer. In cancer, the number of cell is function of weight. What's the weight of the person and you give them. But this is also interesting because I really think that burden of inflammation in MS, if you compare it to burden of disease in cancer, is way less. And therefore, the toxicity of these molecule or CAR T might be way less than we might be seeing in cancer. In cancer, in cancer literature, usually they avoid giving CAR T to those patients who had lymphoma affecting the central nervous system out of concern for neurotoxicity, cytokine release syndrome, and immune cell effector neurotoxicity. Here, you're taking somebody with a neurologic disease and you're giving them the medication with the potential for neurotoxicity. But the overall thinking, and if we are right about our observation, and if we trust what other hematology colleagues who have a lot of experience are telling us, there is a potential that we're going to see less toxicity. But to go back, the third outcome is actually a little bit of clinical outcome. And this clinical outcome in this phase one is not to show that CAR T works, is actually to show the opposite. We want to show that we did not make the person worse because it's a safety trial.
And I asked mainly because of the BTKIs claiming or suggesting that they're controlling this smoldering inflammation that we can't easily see except by your suggested MRI.
But in the trial, they are doing it. It's actually McGill, and they are the one who use this Jacobian method, looking at how much of this lesion, when it's getting bigger, how much it's distorting the parenchyma around it.
And then is there a concern with CAR T that it sounds like it's just a fancier way of permanently suppressing B cell lymphocytes?
It's not actually permanently suppressing me, because if you look at the CD19, like the way we do it with, monoclonal antibody, you suppress the cell between 4 to 18 weeks, and you say, huh? What are we doing? But where what CAR T does better than our fancy monoclonal antibody, it goes to the organ, and there is a profound depletion inside the organ, right? It's like those of us who take care of neuromyelitis optica spectrum disorder, right? We have seen people relapsing with one cell, one CD20 cell. Why? One cell. Because inside the organ, you're not having deep depletion versus with CAR T, you have deep depletion in the organ.
Does that raise concern about immunosuppression and
Oh yeah, the verdict is out and malignancy, absolutely. Yes, yes.
infections? Because
Oh.
we're already concerned about B cell suppression and
The same,
bodies.
the same
Body.
thing. And I expect that if neurotoxicity or other types of unexpected toxicity don't turn to be a big issue with CAR T, I expect that a phase 3 trial probably will be comparing against a monoclonal antibody like B cell depleter. And it makes perfect sense to do this type of trial. What else?
I'll stop for you. Thank you very much.
No problem. Thank you. All right.
Everyone, there's cookies and you can refresh your beverages in the room next door, and encourage you to please interact with our wonderful exhibitors whose help allows us to be here today. Thank you.
All right. I think it's time to reconnect and continue with our symposium. And I'm going to invite Dr. Dan Crespo to give his presentation. He has a bio, a bio sketch in the folder outside, but I'm glad and proud to tell you that Dr. Crespo is one of our trainees who completed his residency at UNMC and then went to Wisconsin to get trained by one of my very good colleague, an expert, Dr. Obeidat. We're happy to have him back in Nebraska, in Lincoln, taking care of patients with MS. And maybe one of these days, I'm gonna use a Cassie's one. You know what using Cassie Healy's one is when you steal somebody. Anyway, Dr. Crespo, please.
Thank you, everyone, for being here, and thank you, Elizabeth, for that wonderful introduction. So today I have a little bit of a difficult topic, which is going to be touching a lot of basic immunology. I'm going to try to keep it very clinically relevant and not bore you with very small details, but it is important to touch on some of those basic immunology details to understand why we use these medications called the B cell modulators or depleting therapies and how to use them properly. So historically, multiple sclerosis has been understood as a disease basically caused by T cell pathology and mediated by T cells. But we've come to understand that it's not only mediated by T cells, but it's also mediated by B cells who act as antigen-presenting cells and promote a pro-inflammatory environment. And this is part of the adaptive immune system, but also the innate immune system mediates that smoldering inflammation that Dr. Zabad was talking about. And so it's a complex interplay between innate adaptive immune systems that end up causing multiple sclerosis. The smoldering MS is, very talked about in the later years, and this is basically what is a very chronic compartmentalized inflammation in the central nervous system that, as Dr. Zabad discussed, is causing neurodegeneration and progression independent of relapse activity. We see inflammation here in the small lesions in the rim of the lesions with microglial involvement. We see also the B cell follicles in the meninges. All of this is very, very chronic and difficult to treat inflammation with the current medications we have. And all of these cause chronic axonal loss and chronic demyelination in the central nervous system. And we see these lesions as the ones that are leading the progression of MS. And we see them as Dr. Zabad also illustrated as these this SWI image that shows these chronic active lesions, as we've seen already. But where do B cell therapies come into play here? Well, B cells have an important function in causing multiple sclerosis. They cause a pro-inflammatory environment. They produce antibodies, including those oligoclonal bands that we talk about in multiple sclerosis. They act as antigen-presenting cells to T lymphocytes. They induce proliferation of inflammatory cytokines, TNF, interleukin-6, interleukin-10, and activate, in that instance, the innate immune system and the microglial environment. So we have a school of B cell agents now, many of them FDA approved for multiple sclerosis, many of them FDA approved for other conditions. I'm just going to quickly list them, right? Ocrelizumab, ofatumumab, obituximab are the ones that have been approved by the FDA for multiple sclerosis. Rituximab is widely used in the whole world for MS as well, although not FDA approved for MS. And then we have other medications that act in the B cells. One of them, the obinutuzumab, that's indicated for lupus nephritis and CLL. And then we have the inebilizumab, CD19, which is different than the other ones, which is indicated for aquaporin 4 positive NMOSD. All of them have their different mechanism of action, they're different antibody types, and they act slightly differently, and therefore they deserve their own special considerations when talking about the treatment of multiple sclerosis with these medications. So what do these medications do in the immune system of patients with multiple sclerosis? Well, the basic thing that we have to know is naive B cells are IgM positive, IgD positive. And then upon exposure, they may class switch to being IgG positive, IgA positive, Ig positive. And these are becoming memory cells of plasma cells. And then the important thing to take into consideration is that patients with multiple sclerosis have a higher rate of class switch memory B cells than healthy populations. Meaning, in patients with MS, we see more active and memory B cells than in patients with normal or no MS or normal health, right? And the B cells, basically, they decrease the circulating lymphocytes, B lymphocytes, which eventually may recover. They take different amount of time depending on each agent. And they have effect in decreasing the active inflammation, not so the smoldering inflammation that we see in multiple sclerosis. The downside of these medications is that they may indirectly decrease the immunoglobulins, even though the plasmablasts are known to be CD19 positive, and these medications are CD20 targeting medications. Well, the CD20 B cells are the ones that are going to become eventually plasmablasts for CD19 and indirectly, therefore, decrease the antibody production and cause hypogammaglobulinemia. And when we're talking about B cell therapies, we also have to talk about B cell reconstitution or immune reconstitution, which is what happens when the B cells recover from being depleted or from their lower numbers being lower. We know that these medications basically turn the B lymphocytes down to zero, close to zero in the circulation. And when we're talking about B cell reconstitution is when those numbers come up. The interesting thing about these medications is that their action is not solely on decreasing the B lymphocytes and suppressing them. They actually modulate the immune system by promoting a class or decreasing the memory B cells that are class switch. As we mentioned earlier, the patients with multiple sclerosis have a higher number of memory cells that are class switch. And by long-term exposure, even 6 months to 12 months exposure of ocrelizumab, we have seen that these patients reverse to their pre-MS state and have a less or lower number of memory cells. So basically, they're to some sort resetting their immune system or resetting the B cells and having a modulating effect rather than a solely depleting effect. And this is why we have long-term data, especially in the time of COVID, uh, long-term efficacy and sustained efficacy of these B cell depleting therapies beyond the time of immunodepletion. That means even if patients have received B cell therapies, maybe a year or 2 years of B cell therapies, and they stop receiving B cell therapies, we continue to see a benefit in decreased inflammation and decreased relapses. And that the explanation from that comes from that modulation that we see and that resetting, to say so, of the B lymphocytes. And we know for this reason and the impact that B cells have in immunoglobulins that the antibody response is decreased in our patients with exposure to B cell therapies. There's, especially in the time of COVID, we've studied this, there's significantly decreased response to, where's this? Antibodies formation for COVID. Here we see healthy controls, and then with patients, here it is, healthy controls and decreased response in patients with MS treatment with ocrelizumab. So from a healthy response to vaccination to a significantly decreased IgG levels in response to vaccination after ocrelizumab. However, this response is still preserved in the setting of T cell. We see here healthy controls with T cell response, and we see the same response basically with patients with multiple sclerosis and exposed to ocrelizumab. Let's talk about the adverse immune consequences of B cell exposure. I think we all have to take into consideration whenever we're choosing a disease-modifying treatment for our patients, are they, first of all, very active in their relapsing state, what age they are at, and also what are their underlying risk factors and comorbidities. And this is going to help us choose a very adequate medication for them. But let's start with a clinical case and illustrating how difficult things can get when we're dealing with patients with multiple sclerosis. This is about a 35-year-old female with highly active MS. She was diagnosed 2 years ago after multiple relapses and conscious-enhancing lesions in periventricular, juxtacortical lesions, and spinal cord. She was started on ocrelizumab from the time of diagnosis, and so she's received already more than a cumulative dose of 1,200 milligrams. In the past 6 months, however, she has had 2 episodes of UTIs and 1 episode of bacterial pneumonia. Her B cells remain 0%, so she remains adequately depleted, and her MRIs have remained stable. Therefore, she remains adequately controlled despite the highly active MS diagnosis. Her serum IgM is low normal, and we have seen that the serum IgM does not tend to correlate with infection as much as the serum IgG. The Ig is normal, and the IgG is on the lower side at 420. She is positive to JC virus in a high titer. And I'm going to put someone on the spot over here, but I'm going to ask, what would you do in this setting? There's a few options here, but Dr. Arcot, sorry that I'm putting you on the spot, but what would you do in this patient?
Highly effective therapy would be my option.
So the patient already is on ocrelizumab, and she's having issues with infections. Would you just continue the ocrelizumab, or?
I would probably continue to monitor on IV the immunoglobulins and check the immunoglobulins and see that and see what it looks like. I missed that part.
I think there's no good answer for this. I think my point here was going to be if I had Dr. Bernitsas, if I had Dr. Arcot, Dr. Zabad, or Dr. McLaughlin, I think everyone's going to have kind of a different, way of proceeding. And then we're going to talk about what we can do in the setting of, hypogammaglobulinemia and recurring infections with patients with multiple sclerosis treated with B cell therapies. in the past 6 months. So she's been treated for 2 years, and she began having recurring infections in the past 2 months.
Other types of infection beside UTI.
She had 2 UTIs and 1 episode of pneumonia, bacterial pneumonia. So when we're talking about the typical side effects of B-cell depleting therapies, we have upper respiratory infection, lower respiratory infections, we have UTIs, we have possibility of skin cancer, breast cancer, cough, diarrhea, herpes virus resurgence and reinfection. But the biggest concerning ones are the ones on the right, hypogammaglobulinemia. And the way different authors define hypogammaglobulinemia differs a little bit. Some people say less than 700, some people say less than 600, and therefore clinical trials have sometimes a different threshold for this. We know that hypogammaglobulinemia will increase predominantly with rituximab and ocrelizumab cumulative exposure. So that means the longer time you've been on the medication, the higher likelihood you are to have hypogammaglobulinemia. We see that the rates differ between trials, and the trial design differs too, and therefore even the long-term data from the clinical trials is not necessarily reflective of real data. For rituximab, we see about 18% of hypogammaglobulinemia for any indication. As remember, this is not an FDA-approved medication for MS. This is seen in and used in rheumatology a lot as well, and also oncology. And remember that in oncology and rheumatology, we have patients that are using other immunotherapies as well, oral immunotherapies in rheumatology and other chemotherapeutic agents in oncology. Ocrelizumab has data ranging from 4 to 11%, more so in that 10, 11% incidence of hypogammaglobulinemia. Ofatumumab has reported incidence of about 2%. The clinical trial data for both ocrelizumab and ofatumumab are a little bit restrictive in that they did not enroll patients that had a lower, a lower than normal baseline IgG, and therefore patients had a lower likelihood of having hypogammaglobulinemia. In addition, they discontinued the medication early in patients who suffer hypogammaglobulinemia, and therefore the long-term data only includes patients who have been exposed to these medications, but already had a good level of high immunoglobulin G. Risk factors for immunodepletion and hypogammaglobulinemia are any, underlying immunodeficiency state, prior exposure to any oral immunosuppressive therapy, and any prior depletion with any other agent as well. As we've discussed before, the low IgG is the one that is associated with higher risk of infection. Low IgM is not associated with high risk of infection in most studies. And this is a side-to-side comparison of first ocrelizumab. In the middle, we have ofatumumab, and on the right, we have obinutuzumab. And what I want to show you here, this is the IgM data. Long-term with ocrelizumab drops considerably, but this is, remember, not associated with high risk of infection. We have the IgG data. This is 7 years, and consistently drops lower, 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 meaning there's a risk that increases with cumulative exposure in time. Here we have the ofatumumab data. We have the IgM that drops, but then we have the IgG that remains overall stable over here. And the obinutuzumab data that's just presented, and we show here IgM that continuously drops, and then we show IgG that remains stable. So there's some intrinsic differences between these agents, and therefore there's a reason to also rely on this data when we're trying to select a CD20 monoclonal antibody for our patients. Well, what is there to do to decrease the risk of our patients having hypogammaglobulinemia? Well, we had to measure a baseline IgG. If we have already a low IgA, a low IgM to begin with, or a low IgG to begin with, we can suspect an underlying immunodeficiency and maybe consider immunology evaluation, and maybe consider another medication that would not put the patient at risk of hypogammaglobulinemia. We have to try to vaccinate our patients before starting a CD20 antibody, and this is of course difficult to do, sometimes delays care. What I try to do in my practice is when I have a high suspicion of a patient having multiple sclerosis, and I have a high suspicion of this patient needing a CD20 medication, while I'm completing the workup for multiple sclerosis, I start the vaccination as well. Because remember, when we're talking about vaccinations like flu is a single shot, it's pretty easy to do. COVID is a single shot, it's pretty easy to do. Prevnar 20 for pneumonia is a single shot, it's easy to do. But the one that delays the care the most is when we're trying to vaccinate patients for shingles. The shingles vaccination, the Shingrix, takes at minimum 2 months to complete. If we use an accelerated protocol, typically the protocol is vaccinate day 1 and day 60 at minimum, but we can use an accelerated protocol vaccination with vaccinating at day 1 and at day 30 as well. And therefore, patients with, after the very first injection or vaccine for Shingrix, they would be able to start immunotherapy 2 weeks after the last shot, which is about 6 weeks from the first vaccine. And those 6 weeks are 6 weeks that patient could be at risk of relapse or could be at risk of inflammation and inactivity. And so optimizing and minimizing the vaccination times is ideal in these patients. We have to choose patients well. We know that non-ambulatory patients, despite stability of IgG, are high risk of infection. And then if infections occur, we have to check a B-cell panel and the immunoglobulin panel. Of course, we have to be checking the immunoglobulin every 6 months and make sure that we always follow a trend, not just the number, but also follow the trend and decrease. Also, we have to consider if the IgG levels drop below 500, which is not necessarily a data-driven number, but I always try to keep an eye on this. If it drops below 500, I keep a closer eye on the patient and maybe consider switching if that continues to drop. Definitely, if it drops below 400, I'm concerned, even in the absence of infections, that this is having a too strong effect on the patient's immune system. And of course, if it's dropping below 400, already suspecting a primary immunodeficiency is reasonable. In some patients who may need, for example, may have very highly active multiple sclerosis, may not be good candidates for other therapies that are highly efficacious, such as alemtuzumab, cladribine, or natalizumab. Immunoglobulin maintenance repletion may be considered at a dose of 400 milligrams per kilogram once a month. This is not the approach that I believe most people take, especially in this era where we have many more available therapies that we can switch to. But definitely there are circumstances where a patient may not benefit from other highly efficacious therapies as much as they benefit from CD20s, and they may be well served with immunoglobulin maintenance therapy. This is a small just diagram on how to approach patients who have hypogammaglobulinemia. If they, of course, have no issues and have normal immunoglobulins, there's nothing to do. If they have hypogammaglobulinemia with infections, then we can reconsider disease-modifying therapy options, consider supplemental IVIG, and also check for B-cell immune competence with vaccination and suspecting, of course, primary immunodeficiency disorder. And then we have hypogammaglobulinemia without infections. We just monitor closely and make sure that we follow the trend as well. There's also the concept of extended interval dosing, which also kind of came about in the era of COVID when these infusions were not being used as often as they are supposed to be used, or at least for label. Retrospective studies have shown no significantly increase of relapse with extended infusion intervals. Depending on the medication, depending on the physician's approach, the method of extending the intervals may vary. Some people may decide to extend intervals by a fixed amount of weeks or months, depending on the therapy. Instead of doing every 6 months, maybe doing every 7, maybe 8 months. Some people opt for a more personalized approach. And this approach may be by either using just a simple B cell panel indicating more than 1% of B cells. People may decide to reinfuse at that time. Sometimes people may opt for just a randomly selected amount of time. Some studies have shown, it's just one study that has shows that we could guide B cell reinfusion or retreatment by measuring the B memory cells, CD19, CD27 positive. The way they did it in the study, they basically counted one cell as repletion and they reinfused the basal lipid therapy. And this led to a significant stability for most patients, but they had about 3% of relapses with this method. This was with ocrelizumab, and the reinfusion interval was about what the normal and other studies data says. About 10 months is what the reinfusion interval will be for repletion of lymphocytes after ocrelizumab. Now, the important thing of this is that this method of extending the interval leads to lower infection risk and lower cost in healthcare. This study showed that the patients extended interval dosing improved the healthcare cost by about, or decreased the healthcare cost by about 40%, despite the 3% relapse rate. So even though the data mainly comes from rituximab and ocrelizumab, the data can also be applied, and we can also think about obinutuzumab with extended infusion intervals. I know that some people also are doing ofatumumab extended interval dosing. This may also be guided by repopulation, or some people have used a 7 to 8 week random timeline for re-injection. Colitis has been long talked about with B-cell depleting therapies. There's some early reports with rituximab that associated colitis to rituximab. We know that none of the B-cell depleting therapies have a very direct action on plasma cells in the gut. They don't decrease immunoglobulin A in the gut, and therefore there's only theoretical, mechanisms that we think that may increase the inflammatory, profile in the gut by increasing Th1, Th17. Really, we have to be careful with these patients that develop colitis. There's a few things to consider. If a patient has a first-degree family member with inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, you have to be cautious about starting this patient on a basal lipid therapy. If a patient has already a diagnosis established of Crohn's disease or ulcerative colitis, patient likely would benefit from something else if they can tolerate, especially something like natalizumab, which in some instances has shown to be effective for some of these inflammatory bowel diseases. Other patients who may be at risk of having colitis is patients who have already lymphopenia from other conditions or other therapies, or may have had exposure to oral immunosuppressive therapies. And the way to diagnose colitis from a B-cell depleting therapy is by a biopsy. Patient has to have a biopsy showing a pattern typical for colitis associated with CD20. And the resolution of the findings with another biopsy after cessation of the treatment is also the diagnostic, within diagnostic criteria for colitis associated with CD20 medications. PML, we all talk about PML when we're talking about natalizumab. I think it's important to inform our patients of the risk of PML with any of the CD20 medications. It's likely there's more data on ocrelizumab, but it's likely a probably class risk more than anything. There's some data with rituximab as well, but the rituximab data is very difficult to interpret because rituximab, remember, is being used with many other oral immunosuppressive therapies in rheumatology and other chemotherapeutic agents in oncology. So the data for rituximab and PML in the setting of MS is not very clear. For ocrelizumab, however, we have about 18 cases that I could find of PML, 12 of which had other carryover risk from other medication, either some other oral medication, some other therapy for MS like natalizumab or something else, meaning the risk is not isolated to ocrelizumab in 12 of those cases. It appears to be isolated to ocrelizumab in 6 of those cases. This makes the rate about 4.3 per 100,000 cases or 100,000 patients exposed to ocrelizumab. For ofatumumab, to the best of my knowledge, there's no single case of PML reported. And for obituximab, there's one case that hasn't been completely verified, but is pending investigation as of now. So how to decrease the risk of PML? There's no good way of decreasing the risk of PML other than considering the baseline immunosuppression, the baseline prior exposure of the patient. If a patient has been exposed to natalizumab in the past, the patient has a higher risk of developing PML. But I think counseling is very important with these patients, and a lot of counseling and reassurance that most likely they're going to be okay and the risk is very, very low. And we do need that yearly MRI for monitoring whenever someone is exposed to B-cell therapies. Of course, this is just for monitoring and diagnosing once the PML is already in place, not something that would prevent the PML from developing. Pyoderma gangrenosum has been reported in some cases to be associated with CD20 therapies. This is a neutrophilic skin condition, inflammatory skin condition, very painful. There's link with rituximab, ocrelizumab, ofatumumab. Nothing with obituximab so far. The treatment is going to be corticosteroid, CD20 monoclonal antibody cessation, and then cyclosporine as well. There's some link, but the causal relationship is still uncertain. So there's something to keep just an eye on. In terms of psoriasis, I've seen a handful of these cases myself that were not, fully linked to these development of psoriasis. There's no significant data associated with rituximab, so I highly doubt that there's a clear association. But if a patient has baseline psoriasis, probably keep a close eye on those lesions and close eye on the development of worsening psoriasis in this patient. And in terms of malignancy, this has been a long-standing discussion, a long-standing fear for most of my patients. When I mentioned the word malignancy and with the CD20s, they all seem very scared. The truth is, long-term data has been very reassuring. Long-term data seems to show that the risk is not different than with any other any other disease-modifying therapy for multiple sclerosis. There's ongoing studies in 2025, a meta-analysis showed 3% cancer risk in patients with MS on any DMT without any particular increased risk on CD20s. A 2021 World Health Organization studies show no cancer risk increase with ocrelizumab, and the 2020 Swedish registry show no increased risk of cancer with rituximab. However, I still counsel with my patients, about cancer risk, predominantly breast cancer, skin cancer. You have to take into consideration the patient and baseline risk factors. Always ask a good medical history. Always ask a good family history. If a patient has, first-degree relatives with early onset breast cancer, early onset ovarian cancer, think about maybe they may have BRCA1 gene mutations, BRCA2 gene mutations, and they may not be ideal candidates for these medications. Other than that, just regular monitoring is ideal. They don't need any more monitoring than any other patient, just a regular monitoring for the cancer screening that is age indicated. And in my practice, at least, I feel like usually the colonoscopy, the prostate, the breast, all of that is followed, but I don't see the cancer screening guidelines being followed very closely. So always ask about smoking history and always make sure that your patients have been adequately screened with a low-dose yearly CT scan for their tobacco use. So I'm going to go back here and just touch on this clinical case. It's a patient with highly active multiple sclerosis who's been exposed to ocrelizumab for 2 years, has had 6 months of 3 bacterial infections, 2 UTIs, 1 pneumonia, has clearly low IgM, which isn't associated with higher risk of infection, but has a low IgG. So I think there's many routes we could take. We can just say, well, this patient has already highly active MS. they need a highly effective medication, and likely they're not a good candidate for natalizumab because they already have a JC virus that is high titer. So in this case, maybe considering immunoglobulin replacement therapy would be adequate. Someone else might say, well, why don't we try, before doing immunoglobulin replacement therapy, why don't we try doing a B cell guided extended interval infusion, right? Maybe switching to, when the lymphocytes go up 1% or above, then reinfuse the ocrelizumab. Someone might say, well, yeah, but ocrelizumab has longer term data showing that they have maybe a higher risk of hypogammaglobulinemia compared to the other agents. Of course, no head-to-head comparison is here. So why don't we try switching to something like ofatumumab or obinutuzumab, which long-term seem to show a better, at least better numbers for immunoglobulin G. And someone might say, well, yes, they cannot do natalizumab, and I wouldn't want to continue a CD20 therapy, so maybe switching to a different class. And we're talking about, we can consider alemtuzumab, which in a 35-year-old female may not necessarily be the ideal, but certainly if a patient can consider alemtuzumab or even cladribine tablets, that would be a very reasonable switch, I feel. Still a moderate to high efficacy medication such as cladribine tablets that carry a risk of immunosuppression, certainly. We're talking about cladribine tablets, they would carry a risk of immunosuppression and lymphopenia for 3-6 months of lymphopenia. But I feel like 3-6 months of lymphopenia sometimes is better than a long sustained immunodepletion of B lymphocytes. So to be honest, I think some days I would choose one, some days I would choose the other one. It's all about a patient personalized decision making. There's no good choice in this. I think all of them are good options. I think we just have to take every patient in their very individualized care and discuss with them what they would like to do. And of course, if one of those measures fails, you can go and do the next one. In my experience, this is a very personal experience, and class switching for hypogammaglobulinemia has not panned out to be successful. This is just my personal experience. I was, especially with the early ofatumumab, I was hoping that class switching would help with hypogammaglobulinemia. And in my center experience, we didn't have good data, good numbers with that. Didn't show any numbers improving. Actually worsen. IgG levels worsen when we switched to ofatumumab. And this is, just a dozen of patients. So, I think one of the important things that I want to, talk about today is that you used to tell people that, well, CD20 depleting agents, right? The role of CD20 monoclonal antibodies is not only of depletion; they have a role in modulation, and they may have a long-term or at least moderate-term or medium-term benefit in patients with multiple sclerosis. So they're not only a depletion at the moment; they're actually modulating the immune system. They continue to be a very high benefit and low risk. We talked about a lot of things, but all those are low risk, and the risks are manageable with proper monitoring. So there's still great medications to choose. Risk mitigation doesn't have to come from when patient has an issue. Risk mitigation has to come from day zero. Day zero is pre-treatment vaccination is the number one risk mitigation measure you should take. Sometimes checking patients' baseline immunity, sometimes just vaccinating, and making sure the patient has access to proper information and they know how to call you and how to reach you when they have infections and they begin having issues with these medications. Even with mild side effects, there's no clinical harm in doing extended interval dosing. A lot of people hesitate the same way we hesitated, in the past with natalizumab extended interval dosing. A lot of people have done, research in extended interval dosing, and it seems to be successful in decreasing the hypogammaglobulinemia in these patients. And then, of course, we have the unmet needs of these B-cell depleting therapies, which are what Dr. Zabat talked about. These medications work for relapses, work for active inflammations, but they still do not meet the needs of our patients completely. And they still do not control the smoldering inflammation in the central nervous system. And of course, we have the potential of the BTK inhibitors. that is maybe promising to fulfill that need. Very good. Thank you.
Dr. Crespo, for this very interesting presentation and, my opinion, very useful in day-to-day practice. Any question? If there is none, I have actually a few. Regarding the case specifically, but that's actually the beauty of having a case, because this is when you start thinking a little bit more about how you do things. To UTI, by definition, our patients have an intrinsic risk of increased UTI because of their neurogenic bladder. So I would not think necessarily about UTI and pneumonia the same way. That's number one. Number two, about the hypogammaglobulinemia. I want to know if it is a persistent hypogammaglobulinemia or it is transient. So one of the beauty for extended interval dosing is that it allows you to appreciate that. I stop somebody with, immunoglobulin level of 500, and then 3 months later, I check it, they are at 400, and I have not given them any drug. They are probably heading for persistent hypogammaglobulinemia. And in my experience, when I send these to Dr. May, whom I have her at Epic and text message all day long, some of these patients are actually CVID, common variable immunodeficiency, that is undiagnosed. And what's interesting about CVID, I was told, and by looking at the literature, is that you can do baseline immunoglobulin before treating the patient, and you can find them in the normal range. However, these people might be low normal. And if you look at the literature, Dr. May actually educated us that there is some literature out there about immunoglobulin, IgG being low normal in so many patients, and potentially that some of our patients can have undiagnosed common variable immunodeficiency, which is actually, I think, is extremely fascinating, because my time when I started fellowship, we used to think MS is the opposite of infection, right? You have low immune system, you get infection, you have hyperactive immune system, and you fight infection, but you get MS. And now we know that it's probably not true. Those people who are at risk for autoimmunity, they are also inherently at risk of hypogammaglobulinemia and infection, and they are also at risk for malignancy. And therefore, people with CTLA4 deficiency, which is one of the molecules that is involved in antigen-presenting cell, T cell activation, and in common variable immunodeficiency, you can have the triad of infection, autoimmunity, and malignancy. And in my practice, I have not seen a lot of these, but I have seen one where she had the 3 complications and she was still on rituximab. It all speaks to what Dr. Crespo elegantly said, that it's a very, very, very individualized decision. And that I think the more you're knowledgeable and you have a lot of experience, the less likely you're going to be able to standardize the answer to this question. And of course, you have to take into consideration what's the patient liking. Thank you.
Thank you, Elizabeth.
All right, it's my pleasure to introduce to you Dr. Bernitsas. For a detailed information about Dr. Bernitsas, I also refer you to the document we already have. But Dr. Bernitsas is currently the chairwoman in the Department of Neurology at CUMC CHI. Some of you already know that Dr. Bernitsas and we have known each other for a few years, and it's really a pleasure having her in Omaha, also leading the Department of Neurological Sciences at CUMC. Without further ado, Dr. Bernitsas.
Thank you. Thank you so much, Dr. Zabad, for this very kind introduction. Hello, everyone. I'll present today aging in multiple sclerosis. And we'll start with some general knowledge about MS. As we know, multiple sclerosis is a chronic disease, affects the CNS, is inflammatory and neurodegenerative and demyelinating disease. Of course, it's an autoimmune disease and is the most common cause of non-traumatic disability in the young population. Some demographics here. We know the peak age is 20 to 45, the peak age of diagnosis. However, 2 to 5% is pediatric MS, and 8 to 10% is late onset or very late onset MS. And how do we define that? Late onset is more than 50 years old when the MS is diagnosed, and very late onset is more than 60 years old. The women to men ratio is 3 to 1, 2 to 3 over 1. And there is geographic variation. So more common is farther from the equator and less common close to the equator. So it's more common in northern areas like Canada, Northern Europe, Northern US. The prevalence in the US is 0.1%. There are approximately 900,000 people with MS in the US, and all over the world, it's more than 2 million people. The life expectancy is normal. However, MS affects the life quality. We have excessive morbidity and caregiver burden. It's an expensive disease. The lifetime cost is more than $5 million. We recently observed some shifting demographics in MS. So the peak prevalence in 2010 was in the 55 to 64-year-old group, followed by the 65 to 74-year-old group. So the peak prevalence is shifting. Similar results are in Europe, actually, were observed in Europe, Denmark. In Denmark, the peak prevalence was in the 55 to 59 group in women, and a little bit later in men, 60 to 64 in men. In Canada, 1980, the peak prevalence was in the 50 to 54 years old group, and 2000 shifted to between 55 to 59-year-old group. So we see that, the peak prevalence is in the older groups now. And between 1972 and 1980, 8.1% of people were diagnosed with late onset MS, which is really significant. Between 1992 and 2008, the mean age of MS cohort increased by 10 years, again, a significant increase. And in 2010, a little bit less than 1/3 of people with MS were older than 65-year-old. We can see the age distribution of MS. These are data from the MS base registry. This is really international registry, a big one, and they have about 100,000 cases. So the first column is age of onset, the second column is age at diagnosis, and the third one is the current age. So we can see the age of diagnosis actually is really high in midlife. The groups, we can see 4 to 49 and 50 to 59 and 60 to 69. We can see how high the column is. Now, a couple of things about late onset MS. Again, is the MS diagnosed at 50-year-old is increasingly recognized. We need to monitor closely those patients because there is a rapid progression to disability and there is higher likelihood of progressive forms. If someone is diagnosed at 50-year-old, it's more likely to have a progressive form of MS rather than relapsing remitting. Also, we see a higher percentage with motor onset symptoms and spinal cord pathology. So that also correlates with a high disability. The immunopathogenesis of MS, we all know it's both inflammatory and neurodegenerative. Early the disease, we do see the inflammation, and the body itself is trying to repair the damage. So we do have regeneration or remyelination. At some point, the regeneration capacity is getting less and less and less. And we do have degeneration. Degeneration actually is going up and up and up, is getting higher. Now, some interesting findings here in new research shows that actually there is no a cutoff for remyelination. So it's really some people can remyelinate even later in life, but not to that high degree as in the beginning, earlier, as the young people. And now we do have more research data and more research is ongoing. The natural history of MS, everything starts with genetic predisposition, goes to prodromal stage, goes to environment and then prodromal stage. And relapses are coming, followed by progression, independent of relapses, again relapses. And as we get older, we can see more progression. What is aging? How do we define aging? It's a functional decline, progressive functional decline that leads to impaired biological functions. Actually, it's a decline. Who is old? Well, yeah, we can define the age of old, 55, 60, 65. Is the old age a final stage of life? Per United Nations, old is someone older than 60-year-old. So they put the cutoff 60-year-old. Medicare benefits, they say 65. So we pay everybody else older than 65-year-old. I look at the literature, I found that interesting. Between 65 to 74, they consider young old. So some people work at that age and are very functional. 75 to 84 is the middle old, and more than 84 is the very old. However, people in mid-80s, some of them are very, very functional. So, but that's the literature, what literature says. In 2050, so 25 years from now, 22% of people will be older than 50-year-old. So the population is aging and life expectancy is getting higher. Chronological age, what is chronological age? From the time we are born until now. However, biological age also is very important, and biological age is modified by other factors like obesity, like smoking, exercise. So maybe somebody is like 50 years old chronologically, it's 40-year-old biologically, or even 60-year-old biologically. Immunosenescence, what is immunosenescence? It's the aging, there are different definitions. It's the aging of the immune system, it's a gradual decline of the function of the immune system, age-related reduction of immune functionality. And actually what is happening during immunosenescence is remodeling of the immune system. Things change, and we'll discuss about that. And actually there is a complex interaction, very, very complex, between immunosenescence and multiple sclerosis. Here, I like this slide because we can see the interaction between MS, aging, and brain. And actually, if we go to the right, we can see aging. Aging can affect the brain. We all know that can cause atrophy, brain atrophy, especially after 50-year-old. The rate is 0.2% every year. Also, MS can cause more accelerated brain loss. So MS can cause 1% brain loss per year. So we can calculate, we can imagine the volume brain loss in aging people with MS. It's a lot. And it's more complex than we think, actually. It's not only additive, it's more complex. Many factors are involved. In MS, the immunosenescence affects both the innate and adaptive immunity. There is a high rate of immunosuppressant cells, so we have more immunosuppression. It impairs natural killer cell function. There is mitochondrial dysfunction. The telomeres are getting shorter and shorter, so that means increasing morbidity. The remyelination is reduced, the remyelinating mechanisms are exhausted, and the tissue repair capacity is getting lower and lower. And also the other interesting thing, and this is recent, is there is gut dysbiosis. So that means there is imbalance in the gut, and that can trigger inflammatory responses. What is the effect of immunosenescence in the innate immunity? Affects every component. We know innate immunity is the very first line of defense. So it affects all cells in that system. It affects the neutrophils, the macrophages, the dendritic cells, natural killer cells. What it does, some highlights here. It's much more complex than that. It can alter phagocytosis of neutrophils, can impair migration and chemotaxis of macrophages, reduces the cytotoxic activity of natural killer cells, impairs the phagocytic capacity and also antigen-presenting capacity of the dendritic cells. And also, we all know type 1 interferons are very important to clear the pathogens, so it reduces that production of type 1 and type 2 interferons and enhance the pro-inflammatory cytokine secretion. So we have a pro-inflammatory component rather than anti-inflammatory. This is the impact of immunosenescence on adaptive immunity, so affects both T and B cells. In T cells, we have the number of T cells is getting lower, of naive T cells. Everything starts with thymic involution, thymus atrophy. So that results in lower numbers of naive T cells, increased numbers of memory T cells. The receptors also, the diversity is going down. We have some changes in the co-stimulatory molecules. CD8 goes down and CD57 goes up. All those changes lead to a specific phenotype, the SASP, senescence-associated secretory phenotype, that secretes pro-inflammatory cytokines and like tumor necrosis factor, like interleukin-6. And there is a shift towards cytotoxicity mediated by natural killer receptors. In B cells, the changes are not that prominent, however, they're similar. So the number of naive B cells is going down. The memory B cells are going up. There is a reduction in the diversity of receptors, of B cell receptors. We have increase in the population of age-associated B cells, and there is increased autoimmune activity. Now, clinically, and this is very important, what are the clinical impact? What is the clinical impact of immunosenescence in older people overall and in MS, in aging MS population? In older individuals, as we know, there is a high rate of infection, malignancy, also neurodegenerative diseases like Parkinson, ALS. There is a decreased response to vaccination, so no effective vaccination response in older people. And also there is a higher comorbidity burden. As we get older, we are diagnosed with different kinds of diseases, hypertension, diabetes. So there is a higher burden here. MS specific, the relapses go down, there is progression, there is permanent disability. The response to disease-modifying treatment is not as good as in younger population. We'll discuss more about that. There is a high risk of side effects in older population. comorbidities, especially cardiovascular comorbidity, has really poor prognosis in the MS population. Also osteoporosis, osteoarthritis, some of them are the side effects of medications. People with MS have been on steroids treatment, so they're more prone to osteoporosis. There is a higher number in the MRI of chronic active MRI lesions, that means inflammation, low grade of inflammation. And here, the immunosenescence changes lead to inflammaging. What is inflammaging? It's a low-grade inflammation, persistent, systemic, low-grade inflammation. We have accumulation of senescent immune cells, and as I mentioned, we have the senescence-associated secretory phenotype, shift in cytokine profile, so more pro-inflammatory rather than anti-inflammatory, compromised immune surveillance, and this inflammaging is the main driver of disability and progression in MS and correlates with higher mortality and higher morbidity in the elderly population. In this figure, there is the interaction between multiple sclerosis and aging. And briefly, aging of the glial cells and age-associated helper cells creates a pro-inflammatory environment that might cause the progression in MS and the late onset MS. Here is a summary of all the changes we discussed. So again, immunosenescence, we have high number of memory T and B cells, lower naive T and B cells, the specific secretory phenotype, microglial activation, and all those changes actually are getting more prominent in the older population, and especially also under hormonal influence. At that age, we see the menopause, we see andropause. So all these hormonal changes may boost the effect of immunosenescence. This is a very interesting field of research if we can reduce aging, or if we can reduce or even reverse aging. And this is very, very interesting. There is some evidence that exercise, especially intense exercise, can help reducing aging, can slow down the aging process. Low-calorie diet or calorie restriction. That's another field, intermittent fasting. So they have some results that 72 hours very intense caloric restriction can actually regenerate people, make people a little bit younger. They monitor the cells, the B and T cells, and they found we have some recovery. So that's a message here, calorie restriction diet. We have the senolytic drugs that interfere with the apoptosis, that actually increase the apoptosis of senescent cells, and the xenomorphic drugs that target this SASP phenotype. There are different drugs, actually drugs we use commonly, like metformin. Metformin mimics the calorie restriction factor. Drugs under investigation like navitoclax, rapamycin, simvastatin also. Simvastatin shows some evidence that can slow down the progression of the disease, of the MS. So there is a lot of research in this field, how we can reduce or reverse aging. Now, the older patients in clinical trials, unfortunately, their participation is very, very, very limited. For relapsing remitting trials, the cutoff was 55-year-old. Even younger than that, there were some trials, the cutoff was 50 or even 45. There was one or two with 45, older studies. Now, even in studies for progressive MS, again, the cutoff was a little bit higher, maybe 60-year-old, but nothing really high. In this slide, we can see the 4 studies. In those studies, the cutoff was 60 years old, or a little bit higher, or 65. The first one is the EXPAND, is the Symposium trial, included patients 18 to 60-year-old. The other one was the EVOLVE MS, that was for Vumerity, diroxyl methyl fumarate, and it was about safety profile, tolerability. They included patients 18 to 65-year-olds, so cutoff was 65 here. And the last 2 studies are about Ocrevus, Consonas and Liberto. Those studies are ongoing, and those studies have upper cutoff 65 years old. So we have some improvement here. Patients 60 or 65-year-old were included. But those are only 4 studies, 4 clinical trials. What does affect the drug efficacy and safety? There are different factors. The metabolism, the drug metabolism, the excretion, the sensitivity, receptor sensitivity. All this profile also is influenced by age, so it shifts with age. And also comorbidities and polypharmacy are other factors that can affect the drug efficacy and safety. Polypharmacy drug interactions certainly can affect the efficacy of the drug. DMT, NMS, and of course aging. We'll start with a large meta-analysis of MS clinical trials, and it shows in people less than 53-year-old there is some benefit in terms of disability progression, but no older than that. And actually, this is a really comprehensive slide about the effectiveness. The trial I talked to you about is the first one by Wildman. They examined 13 categories of disease-modifying therapies. Almost everything was included here. And they found a strong correlation between between disability progression and age. And the cutoff was 53-year-old. So less than 53, they have some benefit. Older than 53, no benefit. Signori and Knoll. This is a meta-analysis of 6 randomized control trials. The medications here are basically platform therapy, interferons, dimethyl fumarate, and also natalizumab. And they found some benefit in less than 40-year-old, younger people than 40-year-old. Vollmer et al. From Colorado. This is a single-center study. Again, fingolimod, dimethyl fumarate, natalizumab, and rituximab. They found the higher efficacy medications outperform the lower efficacy medications here for patients who were less than 54-year-old. So the cutoff is between 53, 54, no benefit after that. This is, again, retrospective meta-analysis for different DMT modifying treatments. For teriflunomide, the cutoff was 38. So, and we have the relapse rate and the disability progression. So in people more than 38 years old, there is no impact in disability progression. So no impact of teriflunomide on disability progression in people who are more than 38-year-old. Dimethyl fumarate, both groups can decrease the annual relapse rate. However, there is no impact on disability progression in people more than 40 years old. Fingolimod is a medication for the young. There was no impact on disability progression in either group, no matter what. And there was no impact in relapse rate in people more than 40 years old. So the impact of fingolimod was on relapse rate in people younger than 40-year-old because of high anti-inflammatory activity. Siponimod, we know, is approved for active secondary progressive MS. There are no available data in terms of relapse rate. However, in both groups, decreases the progression, the disability progression. Cladribine, No problems with that, either young or old people will have an effect. Same with Ocrevus, no age cutoff. But still, those are small trials, retrospective trials. Before we decide to discontinue the disease-modifying therapies, look at the Vienna DMT discontinuation score. This is from 1 to 6. And we get 2 points for people who are less than 45-year-olds, so young people. People who have more than 3 new or enlarged T2 lesions, 2 points here. And people who have less than 4 years, stable disease, 2 points. So all the high-risk modifiers are given 2 points, 2, 2, 2, so it's 6. And the bottom is 1. 1 is given for non-gadolinium-enhancing lesions and 0, 0 for age more than 50 years old and stability more than 8 years old. So here it has proven for people who have 4 or above, the reactivation of the disease is going higher. It's about 80 to 90%. So that's, a good advice, actually, to go with the Vienna DMT discontinuation score in order to decide if we're going to discontinue disease-modifying therapies or not. How about safety? Safety is very important in older population because of other comorbidities and polypharmacy. As we can see, most of the medications, most of the DMT, can increase the reactivation of herpes virus in older population. So the common thing here can increase the herpes or zoster virus reactivation, can increase the risk of PML. PML is more common. One risk factor for PML is age. Figolimod can also increase the risk for hypertension and bradycardia in older population and the risk for malignancies, especially skin cancer. Natalizumab, I mentioned the PML and the herpes vaccination. Cladribine, again, malignancy, there is high risk in older population. Ocrelizumab, high risk of hypogammaglobulinemia in older population, high risk of malignancy, especially breast cancer. Siponimod, same category as figolimod, can increase the risk for hypertension, can increase the risk for macular edema, and also diabetes. Dimethyl fumarate can increase the risk for lymphopenia, and we know that lymphopenia is a risk factor for PML. So both increase for lymphopenia and PML. So there are really safety concerns for patients who are older and are on disease-modifying therapies. There are no clear guidelines. American Academy of Neurology Practice Guidelines 2018, very weak recommendation, consider discontinuation of disease-modifying therapy in patients with secondary progressive MS and EDSS more than 7. That means in wheelchair-bound people who have secondary progressive MS, consider discontinuation of disease-modifying therapies. European guidelines, they say the opposite. Same here. So they say consider continuing disease-modifying therapies in a stable patient if there are no safety or tolerability concerns. So you decide. MS treatment de-escalation, that's, I like that actually. That goes slowly down. Switch from high efficacy to moderate or lower efficacy, disease-modifying therapy, so go with injectables or teriflunomide platform therapies. Extended dose interval, like we do with Tysabri, instead of 4 weeks, we can go with 6 weeks. There is a study about Ocrevus, a small study, they give Ocrevus for 1 year instead of every 6 months, and they say the relapse rate was similar, no significant difference, so consider that. Lower dosing is not always available. Sometimes there is. For example, we can go with figolimod every other day or teriflunomide 7 milligrams, but it's not always available. Exit strategy, cladribine. It is recommended because it can cause stability for years after the last dose, or alemtuzumab. The de-escalation, as I mentioned, high efficacy to moderate to lower efficacy. Switching from higher efficacy to lower efficacy is not that common. Usually we switch to moderate efficacy. The exit strategy, cladribine or alemtuzumab. Those are the de-escalation methods. First one, figure A, is stop cold turkey, the medications. Figure B, it's lower the dose and the interval, increase the interval. Number three is induction first and then go down, de-escalate. And number D is lower efficacy and then cause induction and then stop the medication. So those are the 4 different de-escalation methods. There are some retrospective studies of DMT discontinuation. Beth and al. Show in people 55 years old or older with less than 3 T2 lesions, no gadolinium-enhancing lesions, 8 years of stabilities, there is 0 probability for reactivation. Another retrospective study, meta-analysis actually, of 22 discontinuation studies, 10 years of treatment exposure, 8 years of stability. In people 60 years old or older, there is negligible risk of reactivation. But again, those were retrospective studies. So we go with a prospective study, DISCO-MS, and this is very, very famous study. Study phase 4 prospective non-inferiority trial. The question they pose is, can we identify a population in whom discontinuation of disease-modifying therapies is safe? So that study was multi-center, 20 centers in the US from 2017 to 2021, so we have the results now. The mean age was 63. They included patients 55 years old or older. 259 participants, 2 groups, continue or discontinue the disease-modifying treatment. They included any clinical phenotype, relapsing, progressive. The inclusion criteria were no relapses over the last 5 years and no MRI activity over the last 3 years. So they tried to include a stable population. They randomized 1-to-1, 2 groups, DMT or no DMT. The follow-up period was 2 years. Again, it was a non-inferiority design. So the question was, is stopping DMT no worse, no inferior than continuing DMT? And the primary outcome was the disease activity, relapses or MRI activity. Well, the results were not very definite, not very clear. It shows some slight higher risk of new MRI activity. And actually, it was between 8 to 10% of participants, so slight higher risk of new MRI activity. However, there was no difference in disability, no difference in quality of life. A similar study, prospective randomized, the DOT-MS. They included people 18 years old or older, 5 years of stability, and those people were on platform therapies. Copaxone, interferon, teriflunomide. These people, the participants here, were younger than the previous study, the DISCO-MS. The median age was 54 versus 63 in the previous one. The median follow-up was supposed to be 2 years. However, the study was discontinued in 12 months. Why? Because it shows premature discontinuation was associated with higher risk of relapses. Actually, 8 out of 45 participants were relapsed. There are 3 ongoing studies. One is STOP-ISCP for secondary progressive MS, more than 50-year-old. Completion is expected in 2028. Disco-MS extension, and Ocrevus discontinuation study. This is an algorithm that can guide us what to do in older people with MS. First question, is the patient on cell trafficking therapy like natalizumab or fingolimod? If the answer is yes, be careful. There is the rebound activity. So recommend switching to similar or higher efficacy therapy. If the answer is no, look at patient age. Patient 60-year-old. No, if the patient is younger. So again, be careful. There is increased risk of disease activity after discontinuation in young people, less than 45-year-old, or disease stability less than 4 years. Switch to similar or higher efficacy of disease-modifying therapy, or consider extending dose interval. If the age is between 45 to 59, stability between 4 to 8 years, and MRI with more than 3 new lesions. Consider similar or higher efficacy disease-modifying treatment, and only in older patients if the age is 45 to 59, disease stability between 4 to 8 years, and MRI with less than 3 new lesions, or no gadolinium enhancement, consider de-escalation to a lower efficacy disease-modifying therapy. So if the patient is older than 60-year-old and there is disease stability, if they actually ask the question, is there a disease stability? That means MRI less than 3 new T2 lesions or no gadolinium enhancing lesions and clinically stable for 8 years or more. If there is no disease stability, again, the risk of disease reactivation is higher. So with similar efficacy, go with similar efficacy medication. If there is disease stability, and the patient is on DMT for more than 10 years, yes, you can discontinue. Yeah, eventually we can discontinue medications. However, if the patient is on DMT for less than 3 years, again, consider de-escalation to a lower efficacy disease-modifying therapy, but do not discontinue. There is a survey called Delphi survey. They ask physicians, would you feel comfortable to discontinue medication? So physicians hesitate and patients hesitate. Is the level of comfort, they feel comfortable, they feel safe on being on treatment. And actually, it has to be a shared decision between the physician and the patient. It has to be a mutual agreement. There is no firm age cutoff. And after discontinue, we need to monitor close those patients for the risk of reactivation of the disease. So overall, there are no established guidelines for DMT initiation, de-escalation, or discontinuation in older adults, and this is an individualized decision or a mutual decision between patient and physician. Some take-home messages: aging is associated with changes in immune system. There is not enough data for people with MS older than 55-year-old. De-escalation of the disease-modifying therapy may provide some advantages in terms of safety in older people with MS, and these older people with MS who have been stable for a number of years might discontinue disease-modifying treatment. We do need large prospective studies, and we need to include different types of MS and different patients with different comorbidities as well. Thank you. Any questions?
Thank you, Dr. Bernitsas, for this very, very thought-provoking presentation on how we practice medicine in our time and location versus what do other people do. I think this difference in the way we manage patients is very striking on both sides of the Atlantic if we live in Europe versus here. But it's definitely a lot of food for thoughts because people in Europe, particularly those who come from a subsidized or a single payer type of medicine, they have a tendency to start the drug a little bit maybe later or within very strict criteria, similar to the time I was in Canada. There should be criteria for starting. But then it was interesting that once you go on it, we don't encourage you to get off the drug, which I thought is very, very interesting. And I have to say, I agree with that approach because as physician, I'm probably shaped by the 3 or 4 cases who didn't do well when I stopped the medication and then they relapse. We all share these patients and we talk about them, including patients who did not relapse for 20 years. And then once I stopped the drug, they relapsed.
Exactly, yeah. That's why we need very close follow-up, very close monitoring for at least 2 years after discontinuation of the medication. Yeah, and in my experience, it's very individualized. I had a patient late 60s with gadolinium enhancing lesions. I cannot stop medications for that patient, but I had patients like mid-50s who have been stable for years and years. So we went with extending dosing or every other day oral medication, and they did well. They do well. So
Which actually also you raise a very good point that in my practice, sometimes I see somebody with active disease repetitively in their 60s, right? And that's in a way a transgression to what we think, oh, you're too old to have inflammatory disease. But then I don't think we understand what are the biological underpinning of this patient specifically going through a relapse. But it could be what you call the biological age. In the future, like I was asked by the A&M last year to review some abstract, and there was actually one very interesting abstract looking at chronological versus biological age by looking at proteomics. What kind of protein, people with biological age, like younger versus their chronological age. And there is a set of protein that people who have maybe lower biological age than chronological age will express. And that potentially one of these days, it will be one of the things that we might use in practice. Biologically, your body is like, you're not 60, you're 45 or you're 40, you need to be treated.
absolutely, yeah. And now they say 70 is the new 60. So, I mean, yeah.
I'm still waiting for that. On 70. One more question. Who was the author who suggested Lemtrada as a de-escalation? I thought this was quite bold.
It's quite aggressive, yes. I agree it's quite aggressive because it's a medication with many side effects. I can find the author. I can find the reference.
Please do.
Yeah.
Thank you.
Yeah.
Any question?
I have one question, Dr. Benitez. Thank you so much for your presentation. It was very informative and wonderful. What is the role that you see for neurofilament light chain in monitoring patients in older patients upon discontinuation? I know we monitor with MRIs, but with the growing incidence of CKD, older age, and the changes in the NFL levels, how do you see this as a tool?
The NFL, there is no much research in older people. It's non-specific. That's the problem for NFL. I mean, we can see increase, decreases. Sometimes it goes with relapses, go up in relapses. This is modifying lower the NFL. But I don't use the NFL much in my practice because it's non-specific. It's a biomarker, I agree, it can be helpful for some people. But I agree that there is a more need for research for biomarkers, aging biomarkers overall.
Thank you. If you still have any question for Dr. Benitez, I hope she's staying with us and you can ask her that question, your question. All right. So now it's the turn for Dr. Ayush Gupta to present his case. Dr. Gupta is our multiple sclerosis, one of the 2 multiple sclerosis fellow. He's actually on our 5th year of taking fellow in the Department of Neurological Sciences at UNMC. And Dr. Gupta is going to showcase an interesting case that we see in one of the very interesting cases that we see in a multiple sclerosis program. So, Dr. Gupta.
Thank you, Dr. Zabat, for kind introduction. And I'm just going to present this case, which is called "What's the Matter with the White Matter?" And I promise I'll be quick because I know people are waiting for lunch. Let's see how it works. So as far as learning objectives are concerned, by the end of the presentation, the audience should be able to appreciate workup of some unusual causes of CNS demyelination. Compare clinical course in patients who have autoimmune demyelination versus some atypical cause, and suggest a treatment plan for lymphoproliferative diseases. The case is a 75-year-old female who presented around Christmas 2023 with new onset transient left hand weakness, which progressed to involve the entire left side of the body over next 5 days. She went to the emergency department where she was found to have left-sided hemiparesis without facial involvement. Her past medical history is significant for the diagnosis of limited scleroderma, which was detected way back in 1990s, and she was exposed to multiple immunosuppressive medications. Notably, she was taking mycophenolate for last 12 years or so. There was also a history of multiple skin cancers, which were squamous cell carcinomas requiring excision. When she came to the emergency department, of course, we all want to look at the imaging. So she had both CT as well as MRI of the brain. I'm going to present the CT first, which is on the left pane here. It's the axial CT, which shows hypodensity involving mostly the right side, but also some left posterior white matter. And then in the middle and the right pane, I have the MRIs here. The MRI flare is on the middle pane, while MRI with contrast is on the right pane. So the MRIs show white matter lesion with pressure effect. These white matter lesions were mostly located on the right side and with ring enhancing nature, but there were some lesions on the left as well. So, okay. This patient underwent a very thorough evaluation, including CSF analysis, brain, and which showed white counts of 7, which was slightly raised than normal, with 91% lymphocytes. Protein and glucose were normal, but there was evidence of intrathecal inflammation with raised IgG synthesis rate index and positive oligoclonal bands. She had 17 bands, which were limited to blood, to CSF and not blood. A decision was made to do a stereotactic brain biopsy because of concern for possible malignancy, which did not show any positive findings, just mixed T and B cell infiltrates. A PET scan was also done for the same reason, which showed some lesions concerning for example, lesion in the hip for insufficiency fracture and a soft tissue mass posterior to the left hip, which was suspicious for a nerve sheath tumor, but no direct concern for a cancer-like process. So primary differential diagnoses in this case were considered to be primary malignancy or metastatic disease given her age of 75 years and presence of chronic immunosuppression. I know we have had a long discussion about risk of malignancy in our aging population. Autoimmune demyelination was also considered given as we discussed previously, multiple sclerosis, the age group is kind of going towards the older group. However, the edema was much more than you will expect for, and the ring enhancement was complete. Vasculitis related to scleroderma was also suspected because of this known entity, and infection and septic emboli was another consideration. So at this point, the plan was to monitor clinically, do serial CSF analysis to look for CNS malignancy. A black blood protocol was done to make sure there is no large vessel vasculitis. Our past review of multiple skin lesions that she had removed was done, which showed that this was all non-neoplastic, and a repeat PET-CT was planned. Unfortunately, this patient had new clinical symptoms about 5 months down the line, where she was found down at home and had retrograde amnesia for about 2 days. In the emergency department, she tested positive for possible UTI on preliminary urine analysis, so she was treated with antibiotics. However, because of the neurological history, she was admitted to the med center. Her neurological examination initially showed global encephalopathy and memory deficits. The MRI, which I will show in the next slide, was performed, which showed interval progression. Plasma exchange was decided to be as a treatment line given concern for autoimmunity in the CNS. As we've discussed before, plasma exchange is a relatively safer option when you are considering other differentials, particularly malignancies, in terms of acute treatment. Rheumatology consult was also done to see if there would be a chance of coming off some of the immunosuppression and then the rheumatologist recommended to discontinue mycophenolate mofetil. Neurosurgery consult was again placed because of concern for an unidentified diagnosis, and case was made for open biopsy. So here I'm going to show you the MRIs. Again, the axial MRIs both are FLAIR, and on the right pane is the new MRI. On the left pane, it's the old MRI. And as you can see, the lesion on the left is new and much more edematous as compared to the right previously. So on the left pane, you see the previous MRI, which had some lesions on the left side of the right side. But then on the right pane, you can see the lesions and the edema was much more on the left side now. So based off that, we also did some additional workup. MRI of the cervical and thoracic spine was done, which did not show any cord lesions, except for hemangioma T9. Vascular imaging was repeated. EEG was done, which showed global encephalopathy. And a lumbar puncture was done, which showed the same findings essentially as before, except for mild leukocytosis. PET scan did not identify any major lesions, again, comparing to the before PET scan. However, the hypermetabolic skin lesion that was noted before was biopsied this time, and it showed schwannoma, which is a benign tumor. In between these two hospitalizations, the patient also had a lumbar puncture. So I have put the comparison of the three lumbar punctures. The first one is a baseline around Christmas of 2023, and then the last one is during the second hospitalization. All three of them showed sustained concern for intrathecal active inflammation. So to summarize, this is a 75-year-old female who has history of prolonged immunosuppression. She presented with multiple ring enhancing lesions on MRI initially, which is now progressively worsening. She had negative stereotactic brain biopsy. She had a PET, which was negative. CSF times 3 was negative for cancer and infection, but showing evidence of intrathecal inflammation. So I want to pick some of yours heads to see what are the thought processes that are going through your minds and what would you like to do in this case.
And can I add one more thing? You can see that chronologically, every time the inflammation intrathecally is getting worse. You know, she started with few oligoclonal and she ended up with 27, which is quite high.
Yes.
Anybody would like to volunteer? Well, they are in the MS clinic. It should be MS, right?
Can it be MS or not?
Nobody would like to volunteer? Test more? Send home, hospice?
How many times was the JC virus tested?
It was tested once initially and it was negative. And I think we also did JC PCR in the CSF too, which was negative.
Okay.
Good thought. Immunosuppressed chronically on mycophenolate for 10 years and previously other. I think she might have been on Imuran.
He was on
Methotrexate.
methotrexate,
Yeah.
azathioprine before.
But her lesions were very periventricular, you agree? You know, and typically with periventricular, one of the diseases that look like MS in terms of location is lymphoma. In my experience, anytime I've seen huge periventricular, I thought of a lymphoma. But I'm not saying this is what she has. But it was definitely periventricular. But cord is negative, and there was nothing infratentorial.
Okay. So I'll go ahead next. So finally, we decided to do open brain biopsy due to diagnostic uncertainty and because of the following reasons. When we compare stereotactic and open brain biopsy in case of malignancies involving CNS, they are similar in efficacy, but when it comes to a concern for autoimmune disease, open brain biopsy could have a slightly higher diagnostic yield. When compared to stereotactic brain biopsy. And the lesions in this patient's case were superficial enough, so we were not as concerned as far as complication rate was concerned. And again, we were going to get larger sample size, which will reduce the chances of sampling error and missing a segmental or local focal disease. So the brain biopsy was done and it was resulted. This result is courtesy Dr. Shane, who is one of our neuropathologists. It showed a prominent necrotizing granulomatous inflammation with angiodestructive and angioinvasive pattern. The biopsy also was positive for EBV RNA by in situ hybridization. So a diagnosis of polymorphic lymphoproliferative disease, EBV positive, was made. These are some of the slides that we were able to procure from Dr. Shi, which show extensive central necrosis and activated atypical cells, including what is known as Hodgkin cell. And on the left lower corner, you can see the EBR, which is the Epstein-Barr virus RNA, and that was positive by in situ hybridization. A lot of these cells were chronic lymphohistiocytic infiltrates. So this patient had EBV-driven lymphoproliferation. There is a lot of talk in MS world about EBV, and we all know that it's a very ubiquitous virus. About 95% of our population has EBV positivity through serology or other means, compared to about 99% people in MS who have EBV positivity. That is to say that EBV may slightly increase your risk of MS, but it's not causal by itself. EBV lymphoproliferative disease is one of the few diseases that are linked to effect of EBV on our immune system, particularly the lymphocytes. The virus typically enters through our buccal cavity and through salivary epithelial cells, and then it infects the mucosal cells. And then it's able to penetrate into our lymph nodes and produce proliferative phase, where the virus replicates. And as time passes, the immune system is able to get hold of the active viral replication, but EBV has found a way to escape that risk of avoiding persistence and proliferation by going into what is called as latency phase. And then it can persist in the peripheral circulation as well as lymph nodes afterwards. So there are different latency phases of Epstein-Barr virus, and I have put 3 of them here because they are relevant in our case and in MS as well. So type 3 is the phase where it's pursuing rapid activity and multiplication, and there are certain viral proteins that are expressed during that phase. And this is where the post-transplant lymphoproliferative disease or lymphoproliferative diseases happen when there is an uncontrolled replication of the virus-laden B cells. In type 2, the expression of proteins reduces. Many of the proteins of EBV are turned off, and the B cells, as they migrate to the germinal center, it becomes quiescent. And this is thought to play a role in Hodgkin's diseases and some of the other cancerous conditions. Type 1 latency is even rarer, where almost all the proteins except EBNA1 is lost in translation. And it is the way how this virus persists for a really long time in dividing memory cells. This has been implicated in gastric carcinomas and some B-cell lymphomas. In this slide, I wanted to just differentiate the pathogenesis of EBV role in MS versus in lymphoproliferative disease. When EBV enters B cells through the CD21 receptors, it starts a proliferative phase for the B cells initially. And that is what is driving the pathology in Epstein-Barr virus-related lymphoproliferative disorders. Again, when comparing it to MS, where there is some molecular mimicry and antigen representation by the B cells to the T cells that causes cross-reactivity or bystander activation, and there is subsequent autoimmunity attacking the myelin sheath in multiple sclerosis. So in that way, these two processes are somewhat different. Lymphoproliferative disorders are a spectrum all the way from non-destructive lymphoproliferative disorder to Hodgkin's lymphoma. And again, it depends on the clonality of the B cells that are proliferating and the degree of immune response that is mounted against them. So for example, non-destructive lymphoproliferative diseases, they have almost 100% EBV association, and they are early type of lesions. And some of them can progress into a polymorphic PTLD where a few B cells gain advantage of proliferation against others, and they can acquire some somatic hypermutations. Next phase could be a monomorphic PTLD, which again occurs in a subset of people where there are more somatic hypermutations, and then there is expression of certain markers for lymphomas, like for diffuse large B-cell lymphomas. And finally, there's a Hodgkin's disease type of lymphoproliferative disease. These vary with genetic findings and genetic markers, and there is a possibility that the lesions can progress from one type to another over time. So lymphoproliferative diseases are a spectrum from a benign entity of some clonal proliferation of B cells to a frank lymphoma. These diseases are also graded on biopsy according to the EBV density and how much of angiocentric infiltration is there and how many reactive T cells are there. The higher the grade, the higher is the chance of conversion to lymphoma and higher the risk of aggressiveness of the disease. Most of the times, the lymphoproliferative diseases are detected in peripheral lymphoreticular system. CNS lymphoproliferative disease is seen in about 30% of the patients, particularly increased risk in patients who are post-transplant, also in cases of chronic immunosuppression like HIV and post-hematopoietic stem cell transplant. And these are associated with higher risk of mortality and morbidity. On the right pane, you can see some of the MRI findings in these axial cuts showing a central area of necrotizing lesion and then surrounded by edema. Most of the cases that are reported in literature have this ring enhancing process, and that correlates with the degree of immunological infiltration that's going on around the central area of necrosis. There are several case reports in series on CNS-related lymphoproliferative diseases, which are reported across from post-transplant to HIV and sometimes even in immunocompetent patients. The treatment guidelines are not very well set because this is a relatively rare condition, but withdrawal of immunosuppression is usually considered as the first step, followed by treatment according to the underlying diagnosis. If it's HIV, then treatment with antiretroviral therapy. If the lesions are still progressing and new symptoms are developing, then consideration is given to therapies like rituximab and chemotherapy. The treatment response is variable, but usually if the disease is caught early in the course, the morbidity and mortality is less. So, like I said, reduced immunosuppression can lead to regression in this lymphoproliferative diseases in about 20 to 80% of the cases of polyclonal or monoclonal types. If a patient is very critically ill, stop all non-glucocorticoid treatments and reassess staging in 2 to 4 weeks via PET scan is recommended. Rituximab has become a standard treatment in patients who have non-destructive post-transplant lymphoproliferative diseases or even with monomorphic diffuse large B-cell lymphomas. And then several therapies are under consideration and development, including chemotherapeutic regimens and adoptive donor T-cell technology. Coming back to our case was considered as a locally destructive type of lymphoproliferative disease involving the CNS only. And the patient was administered rituximab 4 cycles, 1 week apart of 375 milligrams per meter square. MMF was stopped during the second hospitalization, and serial MRIs were done to monitor for clinical and for radiological activity, which have shown stability over follow-up of 11 months. Patient is thankfully clinically back to baseline, is able to carry out most of her activities of daily living on her own. These are the MRIs on the follow-up, and which show just the residual gliosis in the white matter, but no contrast enhancement. So to summarize and conclude, CNS lymphoproliferative diseases can be seen in both transplant and non-transplant context and can present as ring-enhancing lesions. Diagnosis requires biopsy demonstration of lymphocytes as well as active EBV activity in the cells or a CSF EBV PCR positivity. Early treatment with targeted therapies can or reducing the risk, the immunosuppression can help prevent transition to lymphoma and clinical worsening. High suspicion should be there in cases with prolonged immunosuppression or defective acquired immunity. Especially in connection to our patient, the patient was already having chronic immunosuppression with multiple immunosuppressive agents and had some form of defective T-cell immunity as well, which was manifesting in terms of squamous cell carcinomas before. So that's why this process was probably happening in her CNS. I think this is all I have. Wait for questions. I really want to thank Dr. Zabat for her mentoring and for letting me present this case.
Thank you, Dr. Gupta, and thank you for changing the background because this was empathetic to Dr. Zabad, whose eyes are not good. Anyway, do you have any questions? It was all clear? Clear as mud? Or maybe we're hungry. Anyway, so Dr. Gupta is here. If you have any question for him, please feel free. Thanks again, and we'll see you in 45 minutes.
Lunch is being served buffet style just next door, and then you can come here and have your meal.
Thank you. All right. I hope everybody had a great lunch. Thank you, Carmen and NNS people for very nice organization and great food. I'm still waiting for my, what's called chimichurri? Anyway, so this afternoon starts with our multiple sclerosis fellow, Dr. Safarini. Where is Dr. Safarini? Oh, sorry. So Dr. Safarini is our second multiple sclerosis fellow. She trained where I was before once upon a time, where I trained, Wayne State University. So Dr. Safarini is also going to share another interesting case that we see in the multiple sclerosis neuroimmunology clinic. And Dr. Arcot is going to be the moderator. Dr. Arcot?
All right. Hello, everyone. Thank you for being here. Brain on Fire is the case that I'll be presenting today. So let's start. A 69-year-old right-handed man with history of prostate cancer, post-prostatectomy in 2013. He had a recent sinus infection in March of 2021 and presented with a one-week history of recurrent brief episodes of left arm jerking and spasms, followed by transient left arm weakness without any sensory loss. He had twitching and contortion of the left face, lips, and mouth. These episodes lasted for 1 to 2 seconds and clustered daily without loss of awareness. Review of systems was notable for lightheadedness, intermittent confusion, and increasing forgetfulness. We initially worked him up as a stroke. We did an NIHSS, and it was a 0. The patient was alert, oriented, following commands. His speech was clear and fluent. His cranial nerves, motor, sensory, and coordination were normal. During exam, we did notice these brief episodes of left arm jerking and left hemifacial twitching lasting for seconds. Any thoughts?
So we have a patient here who has these episodes of involuntary contractions. Any thoughts on what it could be? You guys think it's
If he's admitted to inpatient, it should be stroke.
I think we
And I won't
mentioned
believe it
this.
unless you show me the images.
Okay,
Uh,
let's go to
Because
the
it's the most common, one of the top 3 diagnoses on inpatient neurology in the United States of America. Encephalopathy, right? Mental state, seizure, and stroke.
Absolutely.
Any particular tests that you would like to order? Okay, so we did get an MRI. This is his axial T1 without contrast. And then here we notice a T1 hyperintensity within the basal ganglia on the right. And there was a mild hyperintensity in the basal ganglia on the left. And that was it. And this is his T1 post-contrast axial imaging. So there is some like smudginess around the area of T1 hyperintensity within the basal ganglia. So it's taking up some contrast. And that was it. And then next we obtained the T2 flare sequence, and this is his axial T2 flare. As you can see, he had bilateral T2 flare hyperintensities within the basal ganglia. Yeah. The other area. Oh, it's gonna show up on the other image. Mm-hmm. And this is his diffusion weighted images. This is the DWI and ADC, and we note some diffusion restriction within the bilateral basal ganglia.
Okay. So we've seen the MRIs of the T1, T2, and the diffusion images. Any thoughts on differentials on bilateral basal ganglia hyperintensities with diffusion restriction?
Anacortical hyperintensity as well.
Yes. Yep. Said viral encephalitis.
Mm-hmm.
Yes, arbovirus and any of those viral Eastern equine, Western equine, all of those, Powassan virus, all these are more common in certain parts of the Northeast. Anything else? So you have viral and infectious encephalitis, intoxication, yes, carbon monoxide. Usually not with much enhancement, but could happen. And which metabolic condition? Oh, yeah.
Yeah.
And then there's also this non-ketotic hyperosmolar coma. Okay, I'll let her
Okay.
present the differences.
So, based on the basal ganglia involvement, we were thinking some sort of autoimmune or post-infectious encephalitis, some form of viral encephalitis, a metabolic or toxic encephalopathy, an ischemic or hypoxic injury, venous infarcts, Wilson's disease, and non-ketotic hyperglycemic hemichuria. Based on the cortical involvement, this narrowed down our differential to autoimmune or post-infectious encephalitis, viral encephalitis, venous infarcts. We did obtain labs. His CBC was benign. His CMP showed hyponatremia with a sodium of 130. We did other diagnostics to rule out a stroke. We did MRA of the head, which was negative for any large vessel occlusion, and a CT of the venous sinuses, which was negative for venous sinus thrombosis. And we did obtain an EEG to characterize these twitching movements he's having, and it showed the right-sided twitching without any correlate on EEG. We did a lumbar puncture, and then his lumbar puncture showed less than 3 nucleated cells. Protein was mildly elevated at 53. IgG synthesis rate was normal, IgG index was normal, and oligoclonal bands were normal. We did the entire infectious workup looking for viral or bacterial causes, and everything was negative. We did HIV, VDRL, West Nile, Borrelia, Toxo, Crypto, tick-borne disease antibody panel, and everything was negative. We did anti-MOG, ANA, ENA panels, copper and ceruloplasmin and Turulot Wilson's, and those were negative as well. Any thoughts? All right. At this point, we were thinking this is some form of autoimmune encephalitis. The fact that he had confusion, encephalopathy, movement disorder, and bilateral basal ganglia lesions. Our top considerations were dopamine 2 receptor, LGI1, NMDA, and CRIMP5. And we were thinking about paraneoplastic syndromes associated with prostate cancer, despite him having a prostatectomy back in 2013. But ANA1 and CRIMP5 are usually associated with prostate cancer. We did obtain the autoimmune encephalopathy panel, and it came positive for leucine-rich glioma inactivated 1 protein IgG antibody, LGI1, and the patient was diagnosed with LGI1 antibody encephalitis. Because this type of encephalitis can be paraneoplastic, we did obtain CT of the abdomen and pelvis, a whole body PET scan, and a testicular ultrasound looking for malignancy, and everything came back negative. We did obtain a second EEG, and this time it showed an electrographic seizure originating from the right temporofrontal area lasting for 30 seconds, consistent with fatiobrachial dystonic seizures. And this is what fatiobrachial dystonic seizures look like on a video. And these are pathognomonic of LGI1 encephalitis. You notice the twitching? Okay. Now, a few notes on anti-LGI1 antibody and autoimmune encephalitis. LGI1 is a secreted neuronal protein. So this is LGI1. It binds to the presynaptic ADAM23 and the postsynaptic ADAM22, and it forms a complex. This complex regulates glutamate release and prevents excitotoxicity. So in case of antibodies against LGI1, we have increased glutamate release and excitotoxicity, leading to the characteristic seizures and cognitive changes. Most of these LGI1 antibodies are of the IgG4 subclass, which makes them hard to treat. And then on another note, I've listed some other autoimmune antibodies like that cause encephalitis that are of the IgG4 subclass, including Casper2, Eglon5, and DPPX. Clinical features of anti-LGI1 antibody encephalitis. Onset is subacute. It can take days to weeks, sometimes longer. Seizures are very frequent. And then, as we said, fatiobrachial dystonic seizures are pathognomonic. Patients can present with cognitive side effects, such as cognitive complaints, such as short-term memory loss, executive dysfunction, confusion, behavioral changes, and psychosis. Hyponatremia is very common, as was the case with our patient. That's because LGI1 affects the hypothalamus that is involved in ADH secretion. And also LGI1 is expressed in the kidneys, which increases renal sensitivity to ADH, which further exacerbates SIADH. Sleep disturbances are very common because there's limbic dysfunction and hypothalamic involvement, and because they have frequent seizures which disrupts their sleep. What do we know about the treatment of LGI1 encephalitis? First-line therapy is high-dose IV steroids, IV immunoglobulins, plasma exchange. When we initiate those treatments early, it is associated with a faster seizure control and better cognitive outcome. For steroid-sparing agents for refractory disease or steroid-dependent disease or relapsing disease, we use rituximab and cyclophosphamide. Anti-seizure drugs are used, but they're often they're insufficient alone for fatiobrachial dystonic seizures, and we should be using immunotherapy. Back to our patient, we initiated him on 1 gram IV solumedrol for 3 days. He was given 5 sessions of Plex and started on Keppra, 1 gram twice daily. On outpatient follow-up, there was persistence of his fatiobrachial dystonic seizures. He received weekly IV steroids for 12 weeks, and then later we started him on IVIG, followed by a taper over a year. And then he was still having seizures, so we started him on rituximab over a duration of a year. And with all these treatments, the patient's condition improved both clinically and radiographically. And finally, his seizures were controlled with Keppra and trileptal. How do we diagnose LGI1 encephalitis? We use MRI. Usually, it typically shows mesial temporal T2 flare hyperintensity, but these can be absent. And in our patient's case, he had basal ganglia involvement. EEG often shows temporal slowing or epileptiform changes, and then routine labs typically show hyponatremia, and we should always be on the lookout for malignancy. And then for antibody testing, we do serum testing by a cell-based assay, which is more sensitive than CSF testing. However, we should report both whenever possible. Now, a common question, should we do serum testing or CSF testing? I've listed some serum predominant antibodies, including LGI1, aquaporin-4, MOG, paraneoplastic antibodies, and GAD65. These are serum predominant. And the CSF predominant ones are NMDA and AMPA. Prognosis for LGI1 encephalitis, many patients improve with prompt immunotherapy, but many of them have persistent cognitive impairment, which is common. and then a minority of them will have relapses. Francis, and thank you. Any questions?
This case, I have a quick question. So is there do you use acute treatment in a certain chronology? Like you try steroid, and if it doesn't work, you do plasma exchange, or you just go directly to a plasma exchange and alternate with steroids?
I think the first approach is it's pretty steroid sensitive at times. So you start off with steroids, and then if it's refractory, you go on to the other immunotherapies. The fascia breaker dystonic seizures are pretty responsive to immunotherapy. In this case, a little bit different because the patient needed to be on anti-seizure medications for complete resolution. So he was having more than 100 seizures in a day, and that reduced to more than 25, but still needed the two anti-seizure medications. So there is a role of these anti-seizure medications on top of the immunotherapy. I have several LGI1 patients who need chronic anti-seizure medications as well, because there is a chance that after the initial inflammation has resolved, it leads into this chronic epilepsy due to the scarring on the brain.
And typically, even if there is no relapse, and let's say you couldn't control them from the first event, do you treat for 2 or 5 years with?
Yeah, I usually do for steroid sparing agent for around 2 to 3 years, and then if the relapse rate is around 25% in LGI1, and then you stop the immunosuppression, and then you may have to just keep them on anti-seizure medications, but you continue to follow them after that.
I have one more question, but I'm going to let other people if they have their own.
The other thing that I wanted to point out is the facial breaker dystonic seizures are very clinically diagnosed. It's a clinical diagnosis. So EEGs often are negative. So if you have surface negative EEGs, do not get swayed by that and think that you're still going to think that this could be facial breaker dystonic seizures. So EEGs often do not have a correlate. This patient had electrographic seizures on top of the facial breaker dystonic seizures. So that's something that was a little different here, but often you're going to say, could it be, if there's no correlate, you want to call it non-epileptic, because the clinical diagnosis is important in this case.
Well, it's interesting because I'm glad you find a nice video, Dr. Safarini. It's very unimpressive. You would think that somebody has a tic.
Yeah.
You know?
It's,
So for somebody who really does not think about the entity, it can go by like, especially if somebody has a psychiatric disease, let's say they are on something like Abilify or something, it can easily pass as if it's a tic, which I thought was quite interesting. My last question is, for how long do you continue to monitor them, not neurologically, but from a cancer perspective? Do you do a PET scan every year? Do you do a CT scan of the chest from time to time?
I don't think there's any clear guidelines, and that's a great question, but I do it at least a CAT scan if insurance lets me do a PET scan at least for the first 2 to 3 years, and then I recommend appropriate cancer screening with colonoscopies, and if it's a male and female, mammograms and so forth. So regular cancer screening after 3 years, but at least for the first 3 years, either CT or at least a PET, if not a PET.
So, Dr. Safarini, I noted that you were doing ultrasound of the testes. Why do an ultrasound of the testes when you did your PET scan? Isn't it a waste of resources?
Because testicular ultrasound is more sensitive for testicular tumors than PET scan. So that's often why we do it.
So a PET scan covers everything except the breast, where you have to do a mammogram, a testicular ultrasound for the testes, and the colonoscopy. So everything else is covered, and you do a PET scan, whole body, if you want to look at the long bones, which is important in certain kinds of autoimmune diseases like Erdheim-Chester. And then the CAT scans of the most common tumor associated with LGI1 is not often associated with the tumor because it's very responsive to immunotherapy. It's not like a paraneoplastic etiology, but the most common was a thymoma, and very rarely small cell cancer.
And it was like a neuromuscular junction type of antigen, right? It's an antibody against something in the neuromuscular junction.
So another thing to note is you often may get a positive result of voltage-gated potassium channel. So that is a non-specific finding. Voltage-gated potassium channel that used to be reported in a lot of labs. I get these referrals for positive voltage-gated potassium channel, but you're looking for specific antigens on that voltage-gated potassium channel. That is LGI1 and Casper2. So if those are the two ones which have neurological phenotypes. So any voltage-gated positive channel is not clearly consistent with the neurological phenotype. It's either LGI1 or Casper2, which are proteins on that channel.
Any question?
Yeah.
Thank you. Thank you for the great case and discussion.
There's a question.
Oh, I'm
Yeah,
sorry.
no.
Thank you for your very good presentation. I have a question in this specific patient. As you said, this is a very steroid-responsive condition. Why did you decide to do the more short-term steroid and then IVIG bridge and then rituximab rather than just a steroid taper and then just going with rituximab alone?
Yeah, so this patient was treated in Bryan. So initially, they started with steroids and they put them on I think he was on a taper, it didn't respond to seizures, and then he already had received IVIG. He came to me, and then we did this long IVIG steroid and IVIG trial, and then with IV steroids, it's a weekly trial which Mayo people have recommended as something to do after the initial relapse treatment. And then the rituximab was the steroid sparing agent. But yes, the steroid taper, he was on a steroid taper when he left the hospital, but that he was still having the facial brachydystonic seizures.
And if you're gonna keep it on a maintenance, what is the usual level of minimum prednisone dose that you'd like to have him?
So you want to keep up to 20 milligrams until the rituximab has full effect, and then you can start tapering. But this was, he was still having seizures on these immunotherapies. So until we started him on the sodium channel blocker, for some reason worked, because he had tried a few other anti-seizure medications, had significantly reduced the seizures, but only after we started the sodium channel blocker, and then we tapered off the steroids.
All right. Thank you, Dr. Safarini. Thank you, Dr. Arcot. And now it's my pleasure to ask Dr. Arcot to talk about the chameleon of demyelinating disease, myelin oligodendrocyte-associated glycoprotein. It's one of the diseases that I find always very interesting. And Dr. Arcot is also one of the UNMC trainee. Dr. Arcot.
Okay, so welcome to this talk on MOGAD. It's a large topic, which I'm trying to cover in 40 minutes or less. And so we'll start off with the objectives. We're going to review briefly on the epidemiology and demographics of MOGAD. And then we're going to discuss on the clinical phenotypes and how MOGAD is diagnosed in clinical practice, and review some current and emerging therapeutic options in MOGAD. So what is the epidemiology of MOGAD? So we have a few population-based studies of MOGAD in different parts of the world, in Asia, Europe, and Americas. And it's a pretty rare disease. The prevalence of MOGAD is around 1.3 to 2.5 per 100,000. And the incidence is around 3 to 4 per million. So it's much less common than MS. So with age, sex, and ethnicity, you could see that we know that MS occurs in young adults, but MOGAD can occur any part of the age group from childhood onset to older age. And you can see in the, trying to see. Okay, so in this graph, you see the clinical phenotypes which are more prevalent in certain age groups, and you could see that the optic ADEM and optic neuritis is more common in the younger age group, and as we grow into adult onset, it's going to be more transverse myelitis as well as optic neuritis, or a combination of the two. Okay, the clinical spectrum. So there are different phenotypes, and we're going to go over each of them. So the main clinical phenotypes are ADEM, optic neuritis, myelitis, brainstem syndrome, and overlap syndrome. And coming to this graph, it kind of tells us how the phenotypes are differentiated in age groups. So less than 18, we see that it's more a split between optic neuritis and ADEM, and a less brainstem and transverse myelitis. And after age of 18, you're going to see more of optic neuritis and a small proportion of transverse myelitis and less ADEM involvement. So optic neuritis. So the most common features of the optic neuritis is an anterior segment involvement. It has bilateral optic neuritis in 40 to 80% of patients, and you have a moderate to severe optic nerve head swelling with hemorrhage. And the visual acuity at peak goes down to 20 by 200 or even counting fingers. But the good feature of this disease is that majority of the visual outcome is good. You can also have a cryon phenotype with steroid responsiveness, and that was seen in around 25% of the MOGAD patients. And MOG antibodies are clearly associated with recurrent attacks, and at least 50% of them having a relapse. So what are the MRI findings in optic neuritis? The most common features would be a longitudinally extensive optic neuritis. We talked about the anterior segment being involvement. Enhancement of the optic nerve is almost always seen with anterior segment involvement as well as perineural sheath that is on the covering of the optic nerve. And there can also be tortuosity and swelling of the optic nerve. So how do you differentiate between aquaporin 4 and MOG optic neuritis? And I'll go over this in detail. But the main thing is that when you had recurrent optic neuritis, 1/3 of these patients had either a MOG antibody or an aquaporin 4 antibody. The difference is that there's worse visual outcome with aquaporin 4 optic neuritis compared to MOG optic neuritis or even MS or double seronegative. So MOG antibody optic neuritis is associated with a greater relapse rate but better visual outcomes. So this this table kind of tells us the differences between MS optic neuritis, aquaporin 4, and MOG optic neuritis. So you see that the age group is pretty much a wide varied age group in MOG optic neuritis and in their 20s in MS and 40s in aquaporin 4. And there's a more female to male ratio in both MS and aquaporin 4 antibody disease, but it's pretty similar, no sex predilection in MOG antibody disease. With regards to the optic neuritis, we talked about the bilateral optic neuritis being more common both in aquaporin 4 as well as in MOG antibody optic neuritis. There's severe vision loss in both conditions. The risk of recurrence is there in both aquaporin 4 and MOG. But MOG is very steroid dependent, and the visual outcomes are better. Regarding the MRI features, we talked about this. The difference is short segment optic neuritis with MS, a long and posterior segment optic neuritis with aquaporin 4, and a long and anterior segment optic neuritis with MOG. Perineural sheath enhancement seen mostly in MOG, and optic chiasm involvement. So you could have that both in aquaporin 4 as well as in MOG antibody optic neuritis. But if you have pure optic chiasm involvement, you're thinking more of aquaporin 4 antibody disease or NMO compared to MOG. So this is a picture of a MOG optic neuritis. You see that enhancement of the optic nerve in both these pictures. You also see this perineural sheath enhancement. This is the covering of the optic nerve on the coronal sequences. So this is a picture of an optic disc edema and hemorrhages, which is seen on the fundus exam. And here you see bilateral optic neuritis. There's anterior segment involvement. And you see, again, a perineural sheath enhancement as well. So this is what we talked about. So perineural sheath enhancement, this is also this tortuosity or this kind of bent appearance of the optic nerve. So what's the difference on this particular MRI? You're going to see it's not just anterior, it's extending down to the chiasm. And there's also on the coronal sequence optic chiasm involvement. So this is more consistent with NMOSD and involvement of the posterior segment of the optic chiasm. So let's look at the prevalence in the optic neuritis treatment trial. So the group from Mayo looked at this prevalence of these antibodies in the ONTT, and they saw that 177 patients were studied, and only three patients were positive for MOG antibodies, and none were positive for the aquaporin 4. And all these three patients had optic disc edema, and two of them actually had recurrent optic neuritis. But all of them did have good visual recovery on follow-up, and surprisingly or unsurprisingly, none of them developed MS at the 15-year follow-up. So the prevalence is not as prevalent as we thought it was. MOG spectrum in the Australian cohort, this is just again kind of reemphasize that bilateral optic neuritis is kind of a common presentation, followed by unilateral optic neuritis in children. It's more adults, children with ADEM is the most common presentation. Relapsing MOG is more very steroid sensitive, and usually frequency of the relapses are seen at doses less than 10 milligram of prednisone. So coming to myelitis, so that's our second most common phenotype in young adults or adult age group for MOG. You have myelitis attacks, which are pretty severe, can get to the point where they have a disability, which is very similar to what we would see with NMOSD, reaching an EDSS, which is our functional disability score of greater than 7 in around 30% of cases. You're going to have motor and sensory involvement in bilateral extremities, and then you're going to have bladder dysfunction. So this is an important feature, bladder dysfunction and sphincter dysfunction, and that is really a more frequent finding you see in MOG because of the lower thoracic cord involvement compared to NMOSD. And a minority of patients, 3%, need mechanical ventilation. What do we not see with MOG? We don't see much neuropathic pain, tonic spasms, or area postrema syndrome. That's more common with NMOSD. So what are the MRI features? I have some pictures, but for the main thing is longitudinal extensive optic neuritis, longitudinal extensive transverse myelitis. 80% of patients have a longitudinally extensive lesion. You could have short segment lesions. They are less common, but they can coexist. You have something called a H sign, which is seen on the axial sequences. Again, I have a picture of that. You don't see hypointensities on T1 compared to what we see in MS. Those are your black holes. And when enhancement is variable. So this is a little bit unusual. You see a lot of enhancement of the optic nerves. Don't see much. Enhancement is variable with regards to myelitis. Only 50% of patients can sometimes enhance. And as I talked to you about the conus involvement, thereby the sphincter and bladder dysfunction. And surprising 50 to 80% of these MRI lesions could resolve on follow-up scans, which is different from what we would see with MS and NMOSD. So this is a picture of the myelitis. You see a longitudinal extensive lesion, involvement of the conus. And there's some enhancement on these T1 sagittal sequences. Again, another picture of MOG myelitis. So you're going to see a longitudinal extensive lesion here as well as anterior segment. And this is what does this letter look like? A H sign. That's one of the signs which has been coined for this. So kind of obvious on the axial sequences. So what's the difference on these scans? This looks bright. I don't know what this is, bright, spotty lesion. You see a ring enhancing lesions which are pretty elongated. And then you have contrast enhancement, which is pretty patchy. So this is long, a longitudinal extensive with a bright spotty lesion. This is a short segment. And then you have a circular enhancing lesion compared to an elongated enhancing lesion. So this is the difference between NMO and this is MS. What about neurosarcoid? So again, a longitudinal extensive lesion. So this looks very suspiciously similar to MOG. But here you see dorsal subpial enhancement, a little different from what we saw. Enhancement is variable in MOG, but this is more dorsal subpial. And we saw a H sign. This is another looking sign here. This resembles a trident. And that's common what we see in neurosarcoidosis, but it's not pathognomonic, but it can be seen in a lot of cases with neurosarcoid. The main difference is clinical. You're never going to see a progressive myelopathy. Say never, but very, very rare to see that in MOGAD. That's going to be more common in sarcoid. Other thing to be thinking of lymphoma. You see that subpial enhancement, which I talked about. And then any enhancement lasting more than 2 to 3 months, you're going to think sarcoid, lymphoma, something other than MOG. So brain MRIs are often normal because if it's just affecting the optic nerve and the spinal cord, and we talked about the lower thoracic cord being involved, and oligoclonal bands are often negative, so that's kind of a differentiating feature for us when comparing to MS. Again, we talked about the conus and the ADEM-like presentations which are seen in MOG compared to aquaporin 4. So coming to some general clues on the two major phenotypes we talked about, it's a unusually high optic neuritis compared to other brain lesions. You can have recurrent optic neuritis and pretty severe visual deficit on one or both eyes during after optic neuritis, frequent episodes of myelitis as well. You can have permanent sphincter dysfunction. And anyone who comes in with into your clinic who's had these recurrent ADEM or multiple attacks of ADEM, you're going to raise the red flag for because MOG was available only since 2017, but these people have had ADEM for years or recurrent ADEM. Then you're going to check for MOG antibodies, and usually the disease starts within 4 days to 4 weeks after vaccination. What are the red flags? Any chronic progressive course, think may not be MOG or unlikely to be MOG. An acute or a hyperacute presentation, less than 4 days, you think more vascular than any kind of inflammation. An MRI showing MS lesions, obviously that's going to raise a red flag. If the MOG is positive in the CSF but not in the serum, Dr. Safran talked about these antibodies which are more positive in the serum, and MOG is one of them, and so is NMO. So if you have a positive antibody just in CSF but not in serum, you want to make sure that the clinical presentation fits. Any low titer MOG antibody, this is kind of a issue in our clinical practice when we see the MOG antibody, if lower titers, if the clinical presentation doesn't completely fit, you want to make sure that you're not misdiagnosing MOG. And whenever there's a double seropositivity of both aquaporin and MOG antibodies. So we talked about a few phenotypes. Another phenotype which is interesting and recently it's in the clinical diagnostic criteria for MOGAD is the meningocortical manifestations. And it first got reported in 2017 by Ogawa and colleagues, where they described MOG antibodies in patients who had this unilateral cortical encephalitis, and they also had epilepsy. So all of them had seizures and cortical hyperintensities on MRI flare sequences. And in 2019, Dr. Budram and colleagues coined the term FLAMES, which is this unilateral cortical flare hyperintense lesions. It's a mouthful, associated with encephalitis with seizures. Basically, whatever we talked about with seizures, it's called FLAMES. And the seizures are the most common clinical manifestation. You can see headache, fever, cortical signs like aphasia and hemiparesis. It can affect any lobe of the brain, most commonly the frontal and temporal lobes, but also can have the occipital lobes. You see sometimes a corresponding hyperintensity on T2 weighted images, but sometimes it can be absent. The pleocytosis and plus or minus on the oligoclonal bands, a small minority of patients will have NMDA or coexisting other autoimmune antibodies, usually most commonly NMDA receptor. It has a very excellent response to corticosteroids, similar to all the other MOG phenotypes, usually very steroid sensitive, and there's typically a resolution of clinical symptoms and neuroimaging. Now we see seizures, and there's still a question whether these patients need AEDs long-term because this is leaving a scar on the brain, so it could be chronic epilepsy. So this is a picture of the cortical hyperintensity on the flare sequences, and you see some contrast enhancement in the sulcal and gyri of the same area. The T2 sequences don't have a significant flare change compared to the flare, and then you see some diffusion changes as well. Similar, another picture showing the same thing. You're going to see this flare sequence showing this cortical T2 hyperintensity, as well as this flare change in the sulci and the gyri here. Again, seen on this bilateral involvement actually, and then some contrast enhancement leptomeningally. So they did more studies on this, or kind of a retrospective study out of Mayo on the same condition, cerebral cortical encephalitis by Dr. Sanchez. And they found that out of their entire cohort of MOG patients, only a small minority of patients have this phenotype, 6.7. And more children than adults were affected. And we talked about the clinical manifestations of headache, seizures, and other focal features. And you're going to see an encephalitis, you see this flare change, you see this enhancement. Sometimes they diagnose as something else, or infectious encephalitis. So there was a high percentage of initial misdiagnosis. And it's not a most commonly reported phenotype of MOG. and 1/3 have bilateral involvement. We saw a picture of someone having both hemispheres involved. You can have leptomeningeal enhancement, so just the meninges of the brain. And we talked about the coexisting NMDA receptor antibodies. And a couple of these patients did have a pathology, a brain biopsy or meningeal biopsy, which showed meningeal inflammation, microglial infiltration with subpial demyelination. So there are different variants of the same phenotype. So we talked about flames. So that's our most common phenotype. That's the unilateral cortical cerebral encephalitis. And then you have something bilateral. So that's BFCC-E. And then if you have leptomeningeal enhancement and cortical enhancement, then you're going to call it BPCLI. So these are just long abbreviations. And then something which just has the leptomeningeal enhancement without the flare hyperintensity, that's called FUEL. And then the last one is just an aseptic meningitis associated with MOG, which is called MOGAM. So what about tumefactive demyelinating lesions? So tumefactive means tumoral or more than 1 centimeter in size. You see that a lot in MS, but you could see that in other conditions like NMO and aquaporin as well. And in MOG, so here you see these larger lesions in the bilateral cerebral hemispheres, here involving the basal ganglia and the thalamus, here in the brainstem. You don't see diffusion restriction as much on MOG related tumefactive demyelinating lesions. And you see that this was seen bilateral cerebellar hemispheres or peduncles, and you see on the follow-up scan, there's resolution. So that's kind of the differentiating feature. Whereas with MS, this is a similar tumefactive lesion. You see a T1 hypointense spot here, a darker spot within this white matter. And you see a Balo-like lesion here. So this is layers of concentric myelination and demyelination. Diffusion restriction is present in MS tumefactive lesions compared to MOG. And here you see that there's no real resolution of the lesions compared to, there's definite involution of the lesion, but not complete resolution. So this is a study where they compared both MS, MOGAD, and NMO tumefactive lesions. And they found that the MRI features we talked about, Balo-like lesions, periventricular lesions, that T2 hypointense rim, diffusion restriction, and ring enhancement. And what does MOG have? Deep gray matter involvement, infratentorial involvement, and complete resolution of the lesion on follow-up. So that's how you kind of differentiate it just by MRI. Okay, so we talked about all the phenotypes. And so there was this explosion of phenotypes after the MOG antibody came out in 2017. And so we are discovering more and more phenotypes associated with MOG. And as Dr. Zabaz said, a chameleon of disease. So we're going to discover more and more phenotypes as we go along. But this is the diagnostic criteria which came out in 2023. And they put forth this main criteria to show that we need a core clinical demyelinating event. So we talked about some of these demyelinating events, either a optic neuritis, a myelitis, an ADEM presentation, a cerebral or brainstem presentation, or that cortical encephalitis we talked about. So you have either one of these core events plus a positive MOG test. And when you say a positive MOG test in the serum, it needs to be a cell-based assay showing a positivity with a titer. Now, what if you have these three? A low positive, we talked about that, low positive, positive, but they didn't report the titer for some reason, negative in the serum, but positive in the CSF. So you still need one of these clinical presentations. But if you have one of these three that is not a clear positive test, you need some supporting features, and that's what we talked about, these longitudinal extensive involvement, the MRI features. So you need some supporting feature to go along with your flimsy positive test. Okay. So we talked about some red flags which MOG have, so I didn't want to repeat it, but mainly the things that if you have oligoclonal bands or a progressive or a hyperacute course or MS lesions on the brain MRI, you want to be suspicious that it may not be MOG. And then you have any persistence lesions over time and central vein sign and these borderline MOG titers. Okay, let's go to a case. So this is a 23-year-old female, and she was 38 when she was first seen in my clinic. with a long history of what she called recurrent, what she was told she had recurrent papilledema. This was starting back in 2006. When she was 6 weeks postpartum, she developed retroorbital pain, worse with extraocular movements and blurry vision. She was diagnosed have pseudotumor cerebri based on optic disc edema and had LPs which showed opening pressures greater than 55 millimeter mercury. It started on Dimox and modest improvement. The CSF was done, which showed pleocytosis with lymphocytic predominance and white counts ranging from 280 to 360, as well as elevated protein. So that itself tells you what is pseudotumor cerebri, idiopathic intracranial hypertension. And one of the diagnostic criteria is that the CSF should be normal. So we have abnormal CSF already. So visual acuity was pretty poor in the left eye, 20 by 70 on the right eye. There was papilledema on the fundus exam and a partial third. She had several lumbar punctures during that hospitalization. And after that initial high pressure, all the other pressures were normal. So Dimox was stopped. Then MRI brain and orbits was done in 2006, which showed this was subsequent MRIs, which showed enhancement of the optic nerve. And they said it could represent a left optic neuritis. They were given a tentative diagnosis of aseptic meningitis of unknown etiology, given a steroid taper. She did have improvement of her visual acuity and she was discharged. Follow-up MRI showed complete resolution of the scan and all the flare abnormalities had resolved. Then she had a few more attacks of vision loss in 2009 and 2012. And again, she was treated for recurrent attacks of pseudotumor, treated with a combination of topiramate and acetazolamide. And then for a while, she was treated as chronic migraines as well. And then fast forward to April 2020, she had another attack, this time left-sided vision loss, accompanied by headache, some pain. An MRI brain and orbit showed left optic neuritis. She had another CSF which showed negative oligoclonal bands. They did the anti-brain MRI, the spinal cord MRI, no demyelinating lesions. The NMO was negative. So what do you guys think? I mean, this is a MOG talk, I guess. So, but anyway, so the the brain MRI showed optic neuritis. You see that enhancement. We already looked at multiple pictures of optic neuritis. And there's the arrow pointing it for us. And here we have OCT showing, you see that yellow symbol here, yellow shade. So that shows this thinning of the RNFL on the left side of the optic nerve. And so she's had thinning over years. You shouldn't have that with this pseudotumor. So to recap, so she had this 8M presentation, optic neuritis and question mark aseptic meningitis 2006. Then she had potentially optic neuritis in 2009 and 12. And then she also had another optic neuritis in 2020, but she was diagnosed as papilledema because of disc edema. But it's not consistent with pseudotumor cerebri. And the MOG antibody was finally checked in 2021 and positive with a titer of 1:100. Okay, so the reason I was trying to show this case is that there's different phenotypes, and this is one such phenotype where you can have an anti-MOG syndrome with aseptic meningitis as well as pseudotumor cerebri presentations. This is another study showing the same thing, masquerading as a pseudotumor cerebri. So just keep your antennas up for anyone who has a abnormal CSF and diagnosed to have pseudotumor cerebri. 58 to 70% of patients have lymphocytic pleocytosis in the CSF. And then there's also sometimes a neutrophilic pleocytosis and eosinophils as well. Now, you could have disc edema in another condition, so I want you to keep that in mind as well. GFAP can cause a similar aseptic meningitis or meningoencephalitis, but then also has optic disc edema. So you check for that in the CSF more than the serum. That's another antibody. So we talked about the phenotypes. Now let's go to the test itself. What's the positive predictive value of the MOG antibody? And in this study from Mayo, they looked at the positive predictive value of the MOG antibody, and they found that overall in their cohort, it was 72% as a positive predictive value, and it was titer dependent. And we had if it was 1:1,000, it had 100% positive predictive value. But if it was 1:100, it was 82%. and 1:20 to 40 is only 50%. So you do want to make sure that you're not missing something else and kind of overdiagnosing MOG with these low positive titers. I have patients who have clear MS or MS on the MRI brains who have a titer 1:100. So it's still something that we have to keep in mind when we see these tests, positive titers. So some of the practical considerations, you want to think that this is a clinical and radiological spectrum which is unique from aquaporin 4. We talked about a cell-based assay in the serum. You want to recheck the antibody at 6 months in certain patients who have a high suspicion. Monophasic patients can have disappearance of titers, especially in the case of ADEM. And if you have persistence of MOG antibody titers, it's often associated with a relapsing disease. MOG titers may fall temporarily after giving immunosuppressants, so I recommend checking it before you start them on steroids or immunotherapy. And relapses are known to occur during the steroid taper, so slow taper is recommended. When you have a single attack and there's seroconversion to MOG negativity, you don't usually recommend any long-term immunosuppressants and just recommend clinical follow-up. But if they have persistence of MOG titers and they have clear more than one relapse, then you do recommend immunotherapy, and I'm going to go over that. But it's not clear for how long we do these immunosuppressants. So another case here, a 27-year-old female presented with painful eye movements in her left eye. And on January 18, 2024, around 9 days later, she had some blurry vision and some fuzzy vision in her left eye. And almost a week or so later, she had painful eye movements in her right eye. She came to the UNMC ER, and she had this pretty robust enhancement of both the bilateral optic nerves, very anterior segment, and the MRI brain was unremarkable. Her cervical and thoracic spine showed no cord lesions, and CSF showed negative oligoclonal bands, but elevated CSF IgG index and synthesis rate. So what's your guys' thinking? The titer was MOG, positivity with 1:10,000. That's a really high titer. And the diagnosis is obvious. But 5 days of high-dose steroids was given, and she was released on a 3-month-long oral steroid taper. She had a good clinical recovery in 2 to 3 weeks, and she was back to her baseline with visual acuity. And we decided to hold off on any immunotherapy because this was only a first clinical attack, even though it was bilateral, but sequential optic neuritis. Now, I did check her MOG antibody at 6 months, and she did have persistence of MOG titer, but much lower than what she had back then. It was 1:10,000 to 1:1,000. And then she had it a year later, and again, it was 1:1,000. And the question here is, like, would you start them? This persistence of MOG antibody titers at the 6-month and the 1-year mark, do you start them on immunotherapy? Because she's had only one clinical attack. We decided to just continue to monitor. She's not had any further clinical relapses. It's been 22 months. But that's something to think about when you have persistence of MOG antibody titers even with one clinical attack. So what are the factors that we associate with relapse and treatment of MOG and this UK study showed a kind of a multi-center study on a wide age group, and they found that 30% of people relapse within 4 years, and there's a 36% chance of relapse in 8 years, and the risk is more with young adults. So the relapse and disability outcomes in incident MOG patients undergoing watchful waiting after onset. So basically, this was a study out of Mayo which showed who are looked at patients who were just watching and this clinical surveillance. And they found that 80% of the cohort were monitored off steroid therapy, and out of that, 60% had relapses. So it's a little bit higher than what we were used to, like 22 to 37% in the initial studies. And almost 40% out of that 60% ended up being on immunotherapy in the long run. And this kind of tells us, this picture tells us that you do have relapses as we go along on monitoring them over the years. But the time to EDSS, the EDSS is more severe with that first attack, and after that, it kind of stabilizes. So the predictors of relapses, if you have optic neuritis at onset and a young age and lower risk of relapse, transverse myelitis was found as not a condition which relapses as much as optic neuritis. And if you steroid taper them pretty quickly, or you do early immunotherapy, then they have a lower risk of relapse. And MOG titers, whether they persist or not, is not a huge predictor of relapses. So coming to treatment options, This is a kind of a good flow chart to tell us on how we treat MOG. So if you have an initial MOG attack, we talked about steroids or plasma exchange IVIG if they're very severe attacks. And if they have a single attack with full recovery, you just observe. But if they have recurrent attacks and they are steroid dependent or incomplete recovery even after the first attack, you could think about starting them on a steroid taper and then putting them these chronic immunotherapy options like rituximab and the oral options or IVIG. So acute treatment of MOG attacks, we do steroids, IVIG or Plex. And I thought this study was pretty interesting on how we look at, they looked at outcomes after Plex, after an initial attack of MOG, and they found that the delays in Plex significantly reduced the likelihood of both clinical significant improvement or complete recovery. So basically, they recommend treating any severe attack with Plex pretty soon, so not to wait around. So, but if they did Plex pretty soon after, they achieved CSI or clinical significant improvement in almost 90% of the patients, and in complete recovery in around 44, but still a significant amount. But bowel and bladder function dysfunction was still noted in a lot of these patients, but they all had better visual recovery than from an optic neuritis standpoint. Almost only 3% had less than 20 by 200 at follow-up on visual acuity. And these are better numbers compared to NMOSD. That's because of the pathogenesis, astrocyte injury versus inflammation of the oligodendrocytes. And as we talked about, a huge percentage of these patients have resolution of their lesions on follow-up scans. So this is just basically going over the same thing. So maintenance treatment, 50% of patients do have relapsing course. Some studies show 30%, ranging to 60%. And you kind of offer maintenance treatment when they have 2 or more relapses or 2 relapses or more. And then case-by-case basis when they have severe residual deficits when presenting attack. And this was a very important study which showed kind of a comparison of the steroid-sparing maintenance immunotherapy from Dr. Chen and colleagues. And they included a wide 70 patients in their cohort of both adult and pediatric patients. And they looked at CNS demyelinating attacks before and during long-term immunotherapy. And coming to this, so they looked at the 4 main medications we use, and we saw that the relapse rate was 74% in mycophenolate mofetil, 59% in azathioprine, 61% of patients on rituximab, which is not what we see with NMOSD, relapsed, and only 20%, but this was a lower number of patients with IVIG. So IVIG had better numbers on this study, and MS modifying therapies had almost all of them relapsed. So from this study, we kind of concluded that maintenance IVIG was associated with the greatest reduction in relapse rate. And the IVIG in the Australian cohort had a higher relapse rate, but the pretreatment annualized relapse rate was 0. And IVIG was the better medication according to this study. Cyclophosphamide numbers were low, but they are reserved for more severe cases. In our institution, we kind of use IVIG as first line, but we can add on RTX and mycophenolate as well. A few points on tocilizumab. It's a humanized monoclonal antibody receptor antibody that attacks the IL-6 receptor, which is informed in pro-inflammatory cytokines. And they looked, this paper from Ellsbury and colleagues looked at 10 cases with 0 relapses in 10 patients over a follow-up of 28 months. And these are the new studies which this is a meteoroid study looking at satralizumab, which is kind of like a cousin of tocilizumab. And I have a patient who's going to be enrolling in the study who has refractory MOG. This is Mayo is one of the recruiting sites for this particular study. This is a double-blinded control study with satralizumab versus placebo and then an open label extension. And so the differences, just briefly on tocilizumab and satralizumab, the main thing is that it's more repeated binding to the IL-6 receptor compared to tocilizumab. Both are IL-6 binders, but this one has improved pharmacokinetics. So it has definitely longer half-life, and so therefore can be lasting longer. We know that tocilizumab has been used off-label in NMOSD. We also has been used in MOG as well, but it has FDA approval in other autoimmune conditions, and satralizumab has an FDA approval in NMOSD. And the differences here, as I want to mainly highlight the half-life, which is 30 days compared to 8 to 14 days, has a better tolerance as well compared to tocilizumab. And other ongoing clinical trials, just wanted to highlight, we talked about the meteoroid study. There's also this long name, rosanolixizumab, which basically blocks the neonatal FC receptor, and that's also recruiting patients for MOG. And we talked about the meteoroid study, and there's also another study on tocilizumab as well. So conclusions, it's a very distinct demyelinating disorder with unique clinical, radiological, and immunological features. And early detection is important, and timely initiation of appropriate treatment, especially if it turns out to be a relapsing disease. And long-term prognosis is better than, say, aquaporin 4 antibody disease, but you still need to do ongoing clinical monitoring with some individual treatment plans and patient education. And that is it, and I'll take any questions.
Thank you, Dr. Arcot, for a very wonderful presentation. I have a question, and this is an issue that comes sometimes with underinsured or uninsured patients. Of course, it's difficult for them to access any sort of, what the usual maintenance therapy, maybe tocilizumab free drug therapy, maybe sometimes that's a possibility. But what is your experience with just steroids in the pocket?
Yeah, so I do have that's a good point. So I do this rescue pocket steroids for some of my patients who have recurrent optic neuritis, and this is not, I don't think it's a substitution for our long-term immunotherapies, especially if these are relapsing optic neuritis. But I have had good benefit, especially for uninsured patients. He uses the steroids whenever he has first sign of eye pain. So I've had good benefit of using these 3-day high-dose oral steroids as pocket steroids. But again, I think it's a tricky situation, but you need a long-term immunosuppressant ideally in those kind of cases.
Thank you, Dr. Arcot. I always have a question. It's actually, I instruct patients to call immediately if they have eye pain, but sometimes there is some fear that's set all the time that even any eye pain, they call you. Do you usually wait? Do you wait for a few hours, 24 hours? Or we don't take any chance? Ideally, it will be nice to have some tool at home that allows us to know if this is really optic neuritis or not, but that does not exist. And sometimes it takes a while to see an ophthalmologist.
Yeah, and I think it's, especially if they live, out in Western Nebraska, it's going to be hard to coordinate an MRI, coordinate ophthalmology. So I think it is tricky. I think it's these patients know how they initially presented, and I take them at their word. But it's hard to say that you don't overtreat with these rescue steroids or treating with steroids in general every time they have some sort of eye pain. I think there's how much we wait is a little bit debatable because we don't want to get behind it. But yeah, I agree the concern there when you want to overtreat.
Thank you.
Could you remind me how there's a difference in how optic neuritis tends to recover? You recover from that, but not as well. Is that what I'm understanding from transverse myelitis episodes from MOGAD? And what kinds of disability? You said urinary tract and bowel. Are there, like, why not like mobility problems and others and spasticity?
So there is a small percentage who have wheelchair dependence as well, but in leading with some EDSS scores above 6. But I think the visual acuity recovery in optic neuritis is better with MOG compared to the transverse myelitis, at least in it's less common, but there's less recovery or less or more significant disability in transverse myelitis come to optic neuritis. Now, there's going to be thinning on the optic nerve regardless in both. Your visual acuity may recover, but you are going to have OCT changes. So long term, if you have repeated attacks, we don't know how this has been out. We don't have enough data for 20 years to see how this affects them. But at least the initial visual acuity after at least a few clinical attacks has better recovery than an initial transverse myelitis.
I can share my experience because I've had patients with optic neuritis and transverse myelitis. At first, when you asked the question, I said, yeah, that's probably true. Optic neuritis do better than transverse myelitis. But then when I was recapitulating the history of the patient, I think what I have seen is what has been reported in the literature. Deficit or residual deficit is function of how early you treat. So prior to knowing, MOGAD, if you look at the literature, like the 50 patient reported from the European people, was the first author, Jarvis,
Jarius.
Jarvis?
Jarius.
Jarius. They usually tell you that recovery is function of how soon you treat. If you don't treat with steroids quickly, they actually will be left with bad deficit. So in the old time, the overall thinking is that the optic neuritis is as bad as aquaporin 4 associated NMOSD. To realize later that this is probably not true, when you treat very quickly, outcome usually is closer to MS than to aquaporin 4 and MOSD. And I have to say, with transverse myelitis, when I think about my second patient who was treated immediately, who had simultaneous optic neuritis and transverse myelitis, and some of the younger people whom I treated immediately for their transverse myelitis, they have not kept any deficit, versus the patient who came to me, has been my patient for the last 4 or 5 years, but have been having recurrent issue for the last 10 years. She has been left with very bad gait impairment. She still ambulates with a walker, but her gait is terrible, very stiff, and a lot of neuropathic pain. So I think it's how fast you might treat. But then if you think about it independent of experience, you have a disease that is affecting more the gray matter, and you would expect that somebody's going to be left with more deficit. And yes, what Dr. Arcot has been observed too, when we used to deal with Dr. Vopala all the time, she would call and say, their retinal nerve fiber layer is really, really low. That is, now if they have another hit, it can go lower. So you have to be very careful and treat them immediately. Any other question? Dr. Gupta.
I pass on the genetics.
No, it's not genetics. Well, it's about some people advocate for like repeating MRIs in MOG very soon, like after like some 5 days or 7 days, and that could be a way to tell in case you don't have antibody testing available readily to say if it's MOG or not, because the lesions can disappear or change very dramatically. Is that something that you see? And then second is when you stop maintenance treatment for
Can you
MOG.
clarify the repeat MRI for brain or orbit or both?
Depending which side is involved.
Say repeated the MRI in 5 to 7 days.
Mm-hmm.
Because you want to see the extent of the disease, or
it improves very rapidly.
Oh yeah. I mean, I think you could do that. I don't know if we have enough data on how fast these lesions resolve. It's usually a scan, which is a few months out. But so I think the enhancement resolves pretty quickly, but I think you're going to see, sometimes that's why you want to do the MRIs pretty quickly, even before you start steroids, to see that enhancement. But I think if you don't have MOG testing commercially available, or you not have reliable MOG testing, I think that's a useful way of seeing how the lesions, if they completely respond. I think this is more better with brain lesions and spinal cord lesions, less than you're going to see optic atrophy. Doesn't give us any clue either way. I think the initial MRI is important because you're going to see enhancement and how the segments are involved, a short segment, long segment. Follow-up scans are more with the spinal cord or the brain. And then the question on maintenance therapy, I think we don't have enough data on how long we drew it. I think it's everyone's a little different on how they practice, but I think, and we still don't have exact guidelines. I have been keeping them at least indefinitely, especially if I know these are people who are relapsing. But the question always comes up is, and I have patients who have relapsed 6 years in between. So the question is like, are you treating for that 1 in 6 year attack, or are you? I mean, if it's more frequent, it's pretty obvious that you keep them on. But I think it's just tricky when it's so far between. I don't know what your experience is with.
Well, I think about my first patient who was diagnosed with MOGAD, right? She had a recurrent history since the age of 9. The first attack was bilateral optic neuritis. And then after that, she had 3 attacks of cerebritis with MRI changes, cortical T2 hyperintensity and contrast enhancement, very small area. And then one of them, she had a low titer NMDA receptor in the CSF. And these happened between the age of 9 and until she started seeing me, 18. And recently, actually, I was cleaning her note because she's been my patient for such a long time. And I noted that up to a year before she started seeing me, she had these poor events. But then once I put her on rituximab, you know, that information on IVIG in 2017 was not known. She stopped relapsing. And then I switched her to IVIG and she's not relapsing. And now she has been my patient. She's 25. She's been my patient for 8 years, and she's not relapsing at all. She has been able to get pregnant. The first time she got pregnant, her CD19 was all along 0 during the whole pregnancy, and up to 3 months postpartum when she started having 1 cell. And then in the second pregnancy, I just maintained her on IVIG. And now she's doing very well. So the question to myself is, what do I do it, right? Because we have a tendency, it's like, am I over-treating? I stopped the rituximab. She's only on IVIG. But then I had to remind myself that prior to seeing me, she had relapses. Between the age of 9 and the age of 18, she had 4 relapses. So I think sometimes you have to believe in what you see and stop doubting yourself, because it is the nature of relapsing remitting disease that they will remit on you and make you doubt that you're treating something. And that's well known with MS and patients, right? How many times in your life you have seen somebody saying, oh, I think I'm doing very well, I'm gonna quit because I don't believe I have MS. And here we go, they relapse on you. So I think you have really, really, really to be very cautious what you're doing. And before I end today on my closure, I'm gonna tell you something. In our field, change is the rule. If you have a problem with that concept, I think you need to be out of MS neuroimmunology. It doesn't matter if you are staff people, if you are neurologists, etc. There is no one size fits all. Treatment is nuanced. And you know, you would like for patient to be animal, mouse, and rat, but they are not. And basically, you have to believe what you're seeing and individualize treatment.
Yeah, coming to another point, like the patient who had the repeated attacks of, thought to be pseudotumor, she went so many years without treatment, and so long between attacks, but she doesn't want to go off IVIG now. She's been on it for 4 years because she's worried about the next optic neuritis leaving her with permanent visual disability. So even though it's far between, I think patients are aware of how bad it gets when they do have a relapse. So some of them do want to stay on the treatment, even though we don't have a lot of data on how long we treat these people.
I think one of the main issue also with these diseases, they are costly, right? So sometimes continuing somebody on IVIG, which is costly, and sometimes they might not be able to find it. Seems like as physicians, we're nonchalant about cost. We do care about that. But I think would we be having that discussion if I had a drug, generic, cheap, that I can fill from Mark Cuban? Would you be having the discussion of drug discontinuation, right? Even in MS, we won't. And I think I've decided that all the science conundrum, I'm not gonna take them personally. I'm gonna do my best in view of what I know. And then once I know, I can, modify my way of taking care of the patient. Any other question? Thank you, Dr. Arcot. I love MOGAD. It's a very interesting disease. Anyway, so I think it's time to have a little bit of fun and relaxed atmosphere. And I'm going to call the Maha Angels, this is what I call them in day-to-day, Maha Angels, to come and to go over their very interesting and practical presentation. It's actually more like a roundtable discussion. I know that the providers are going to clarify the myth. But can you please tell us how about the mocktails? What's the way to serve the mocktails?
Well, the mocktails are because for the second year in a row, I've realized I'm presenting last. And last year, I thought for sure it was because they saved the best for last. But now I'm getting a complex, so I figured we'd serve some mocktails with our discussion. And I'd also tell you that we're going to catch up on time, but we're presenting with Neil, so we'll see you guys at 5 o'clock.
3 hours.
So how this mocktail is going to be done is you'll see as our waitresses over here, Whitney and Kristen and Mary, are going to bring around the mocktail menu. Each of them, the title or the name of each of them is surrounding an MS symptom. And so you'll just select your mocktail. Please feel free to get refills. And a huge round of applause to Aubrey Linner, who spent over 2 hours mixing mocktails earlier this morning. So thanks, Ab. Appreciate you.
Mind the seeds.
Did you spike them like we talked about? Just think.
So my name is Renee Stewart. I'm one of the nurse practitioners on the MS team. And I just want to take this opportunity to welcome you all to the roundtable on MS symptom management, real world strategies for complex challenges. Today's goal is not to talk about data or guidelines, so we will use some evidence-based practice in how we practice personally, but really to share what works in practical practice. We'll keep it informal and interactive, focusing on everyday approaches to managing the symptoms that our patients struggle with most. We'll address misconceptions that limit care and identify strategies that improve quality of life across all stages of MS. I'm fortunate to be joined today by Aubrey Lindner. She's the program coordinator for the Multiple Sclerosis at Home Access or MAHA program, and Neil Juvena, a PA on the MS team. So symptom management, no disclosures specifically related to our talk, by the way. MS symptom management is holistic, it's proactive, it's personalized, and improving quality of life across physical, cognitive, emotional, and functional domains. So really the goals of MS symptom management are to improve quality of life across the disease spectrum, to address both physical and cognitive as well as emotional symptoms, to tailor strategies to disease stage and individual needs, and then to balance the pharmacological and non-pharmacological interventions supporting independence, participation, dignity, and well-being. So really, what the symptoms that our patients suffer from most are really what we're going to talk about today. So some very quick talking points. If MS, or if you can have it, MS can have it, right? MS symptoms are highly individualized. They are unpredictable. Each person's symptoms may change and fluctuate over time. So it's very fluid. Another thing that I want to highlight that we are all very aware of is that MS symptoms are both visible and invisible. And there's a list of them behind me. And I think it's so important as clinicians that we remember that the unseen symptoms are just as impactful on people's lives as those that we can physically see. So the first myth that we're going to bust today is that every worsening symptom is a relapse. And so the reality is that many are pseudo relapses triggered by various things like heat, infection, stress, pain, travel, procedures. So Neil, can you kind of walk us through in your practice how you differentiate between a pseudo relapse, an actual relapse, and then the treatment of that?
Oh boy.
Putting him on the spot.
Well, I think the first thing is every relapse is worth listening to. You know, every attack, whatever you call it, like a relapse, an inflammatory attack, whatever you want to call it, the patient's complaining of something. So they're worth listening to. And thank God we have those awesome case managers who are just happen to be sitting in the middle of the room, kind of the center hub of our clinic to take and field questions and to listen to them and look for patterns that might help point to likelihood of inflammatory attacks that might be concerning for a relapse, that might be treatable by steroids or some other process. But you know, steroids, excuse me, relapses and exacerbations exacerbations of old symptoms, I think, is the big dead giveaway. If something comes back, haunts them, and then identifying underlying underlying causes, um, noxious stimuli, pain, infections, anything that increases core body temperatures, heat, humidity, temperature changes. If my hip is flaring up with the weather, probably my MS patient's symptoms might be flaring up because of the weather changes. Um, Sources of pain, anything that might be driving some uh, revisitation. I think Dr. McLaughlin, I like everyone has a little bit different terminology, revisitation phenomenon, pseudo exacerbations. I think our positions, you and me and all of us, just talking with the patients and providing some reassurance that there's going to be some improvement, no matter what happens, and educating our patients, talking with our patients, trying to get to the bottom of what types of symptoms that are bothering them, and trying to connect the dots, and giving it the benefit of the doubt, and pursuing some neuroimaging or some other, making sure we examine the patient if there's a physical uh, symptom manifestation, and then having a low threshold for considering imaging if there's any doubt for relapses. Talking too long, everyone.
I think one of the biggest things too is anytime anybody calls in with a new symptom, it's really that identification of is it new or is it
Yeah.
resurgence of old symptoms, and certainly one of the first things to do is to me. One of the first things that we do is to always do that infectious workup, checking the urine or blood counts, looking for infections. And then if deemed a true relapse based on clinical presentation and or by imaging, certainly high dose steroids are an option for individuals. And so I think the big takeaway in this discussion is to treat the cause. Not every quote unquote flare or exacerbation needs steroids. And I think that, a lot of education can be done to ERs, across our state and rural communities, just to inform individuals that those pseudo relapses, you treat the underlying infection or what have you, and symptoms will improve. The next myth I think that we want to talk about is the one that I feel like is a patient at first time of diagnosis, or one that oftentimes the general public thinks about when they hear a person has MS, and that's misconceptions related to mobility. The myth or the misconception that everyone with MS will eventually lose their ability to walk. And while we all know that that's not true, certainly when an individual gets the diagnosis, this is something that's at the forefront of their mind. I think they so just inherently think of themselves and or see themselves in a wheelchair. Another one is that mobility aids equal giving up. And Tammy, a physical therapist that we work with very, very often, can certainly speak to those challenges of those transitional phases for people. They go from being fully ambulatory to maybe now we need to start having discussions about canes and walkers, and then how challenging that transition can be to needing a wheelchair. And then that exercise worsens mobility. And so mobility loss is not inevitable. And we as clinicians, we know that. But Neil, if you'd speak to just a little bit about, optimizing mobility in individuals and kind of helping to bust that myth, right? That everyone's going to end up.
I think
in a
mobility is
wheelchair.
interesting because we all have our patients who complain of immobility or trouble moving, and they're not using any canes, walkers, or chairs. And then you have patients in chairs, walkers, and canes who don't complain of immobility at all. It's kind of I think all symptoms too are like that. Interestingly, that one person's disabling symptom is another person's, no problem. But
If somebody comes into the clinic and is complaining about mobility challenges, what would be the first thing you'd recommend to them?
well, I mean, therapy. Without therapy is the best medicine. Laughter, number one, and then physical therapy is number two. You definitely want to find out what's going on with her immobility. What kind of immobility? Is it related to muscle spasticity? Is it a pain? Is it something even related to multiple sclerosis? Is it back or a hip or something that can be treatable more easily? But physical therapy is usually the mainstay that I think of if we can get our patients, depending on where they're at in their life, to get to physical therapy. You know, I think that's a challenge for many of our patients trying to treat the underlying cause if it is spasticity or pain. I love that our therapists have different ways of treating that I don't ever think of, like, vertigo or imbalance. There are treatments for that. And just because they don't have a clear and present weakness on examination doesn't mean that our therapists can't find a way to help them mobilize better. Um, what else do I think of?
How about a little bit of dalfampridine, maybe?
Oh yeah, let's just throw a drug at them. There's always a drug for that. Anything you got, I got a drug for it. Especially if it's not labeled for the indication that we're treating. We like to do everything off label in symptom management. I feel like no, Ampera I think is a great option for patients who are struggling in so many different ways. And you see dalfampridine or Ampera listed throughout our lecture today. It has so many different benefits and definitely has its place for a minority, but not an insignificant number of patients feel like they do well if it's in the right patient, you know?
Yeah, and I'm sure, I mean, everyone's aware that dalfampridine, the 1 in 3 people will respond to dalfampridine. And so when you look at the efficacy of that, it's not great, but for the 1 in 3 people that it helps significantly. And
Yeah.
people who it does help, they feel they are responders. They notice benefit even in things which we'll talk about later too. But with fatigue and their memory, they just feel like it can help in those ways too. I think we have to be cautious though about utilization of dalfampridine and people who maybe suffer more with like perhaps the mobility piece of things, where like a cerebellar ataxia is what's driving a lot of their challenges with mobility. So we have to use caution in those patients with using Ampera because it can worsen their mobility. Another thing about dalfampridine is we know that it improves walking speed, but it doesn't improve strength. So people feel like it can help their endurance or their stamina, but doesn't improve strength. So I think that that's something that we have to keep in mind too. And then when we're talking about mobility and challenges with mobility, like with imbalance, you think about all the medications many of the medications that we use to treat other symptoms like spasticity, like neuropathic pain. And so many of them independently can impact people's balance, which I'm sure you see too. Yeah.
Polypharmacy, I think, is also another theme in here for
Yep.
number one thing to kind of look for, even with exacerbations. It's like, did you just start a medication? Did your doctor give you some sort of medication for whatever purpose? Are you taking Benadryl? It's making you cognitively impaired and trouble with balance or energy. And so it's good point.
Yep. So I think the key takeaway really about mobility in MS is that movement is medicine. And the National MS Society published exercise guidelines for individuals throughout the whole spectrum of the disease. So EDSS from 0 all the way to EDSS of 10. So I think that that's so important. And even that movement is merely range of motion. It is movement and it is helpful. So that's something to keep in mind.
How do you you have quite a few patients with assisted devices. The transition I find difficult for our patients. Sorry to distract.
No.
You were going to move ahead.
No.
But going from one thing to another, moving up the ranks of the assisted mobility, it's like, I don't know when to really identify perfectly well when the patient is ready to move on and depend on something for safety, and then kind of own it and appreciate its benefit.
I think one of the biggest things is early identification. As you see things changing, that's when you start to introduce the idea. Like it's very hard for people to just you suggest it to them and they're like, oh yeah, that's great. I'm happy to start using a walker, right? So it's the introduction of that concept, that idea or that thought early. And then I oftentimes will have conversations with them about, like, I see that you're utilizing a cane, but you're less ambulatory or less active than you were, say, even 6 months ago because of the challenges that you're having with falls or what have you. So it's like that discussion about how can we optimize your independent and keep you more ambulatory doing the things that you want to do by using an alternative assistive device. And if you kind of reframe that, and another thing that patients have told me that's very helpful is they name their assistive devices. So it becomes
great.
part of them, which sounds kind of wild, right? But it's very helpful for them to then accept, like an individual has roly-poly, that's her walker. And I can't think of that. It's so people, they name their assistive devices and then it's like, okay, I can accept that I need this as part of my life. So that's another thing that I've adapted into my own discussions with people, and it has been helpful. So yeah. The next one, fatigue. So understanding the invisible symptom, which is fatigue, as we all know, the number one presenting symptom of multiple sclerosis. And common misconceptions about fatigue are that it's just being tired. Rest always helps, and nothing can be done to help with fatigue. So
just get some sleep. You're
yeah,
fine.
right. Yeah.
You're okay.
So how about like a clinical approach for you, Neil, to someone who comes into the clinic complaining of increasing challenges with fatigue?
Polypharmacy comes to mind, or just drugs, medications. I always want to find and identify something that we can treat. MS fatigue is so common, and not easy treatments for it. It's something to live with and learn to live with. I think more than we can improve a lot with stimulants and other drugs. But identifying underlying causes is most important, I think, thing we need to do first, looking for thyroid disease and others, anemias, looking for other causes of the fatigue. And then like anything, throw a drug at it and see what happens. Cautiously, of course. But I think in our field, we don't shy away from trying medications that are off-label, and I think we have a little bit more courage. And I think it's reasonable if you can rule out other underlying causes of fatigue. But most importantly, we need to identify what that fatigue is causing in their lives. Is it contributing to depression? Is depression feeding into that sense of fatigue? The silent triad of cognition and depression and fatigue. I think those are the real disabling characteristics of multiple sclerosis. If we can try to find a way to address all those three things at the same time is really important. And it's challenging, of course, and finding ways to address, like treating depression might also treat fatigue. So I think that would be helpful. Or
And just like mobility related issues, the number one treatment recommendation for fatigue is
exercise.
you got it.
Yep, that's the treatment too. I guess laughter, therapy, and then exercise will be our main treatments for today.
Yeah. Optimizing sleep, like what's contributing to the challenges with sleep? Is it falling asleep? Is it staying asleep? It's because you're getting up 7 times a night because your bladder is overactive. All those sorts of things. It's really diving into what are the things that are contributing to your fatigue that we can treat before we talk more about, medications.
I think many of us are suffering from sleep deprivation
Yeah,
in our
probably a
life.
few people sleeping at this point in time.
I know. But I had a patient last week who chooses to go to sleep in the morning and stay up at night playing video games and just not doing any social interaction. I think getting our patients for cognition and fatigue and for mood, getting our patients not only physically active, but socially engaged and building some structure into their lives so that they feel like they have purpose and a reason to be awake rather than hide away.
Yeah, and I think medication wise, we briefly talked about that, but the wakefulness promoters can be helpful to people if some people really say that those are like their lifeline. That's how they get through their days. Amantadine can be helpful. Probably not my personal favorite, but can be helpful. And then again, for those individuals that are responders to delphamidine, you'll find oftentimes that people also find that to be very helpful for their fatigue as well. So I think just to remember that fatigue is manageable with comprehensive and individualized care for everybody is important.
Yeah, I think, again, we keep coming to this idea that we can try to treat multiple problems with one drug or
Yeah.
one action, and explaining to our patients that things like exercise are going to be not only beneficial for one thing, but it's also going to help them in many other ways. And then medications can be geared the same way, amantadine, if maybe there's some underlying, I don't know, movement disorders or
Yeah.
tremors, which we can't treat anyway. So yeah.
Very good. Cognitive dysfunction.
I have that.
Yeah. Yeah, we know. I'm just kidding. I'm just kidding. So common misconceptions about cognitive dysfunction are that cognition only declines late in MS. And I am honestly a big believer in that. Not uncommonly, more challenges with cognitive dysfunction can be more disabling than the physical disability. And certainly I have a handful of younger patients who have had to leave the workforce because of their cognitive impairment solely. They're fully ambulatory from the outside looking in. They look like, people will look at them and say, I can't believe you have MS. But it's these invisible, unseen symptoms that can pose so many challenges for people. And also the misconception that cognitive dysfunction in MS means that they have dementia. We hear that. And then that nothing helps. And so kind of from a clinical, again, perspective, Neil, what would you mentioned that triad of symptoms about depression and fatigue and sleep, polypharmacy. I feel like that's where we start with evaluation of cognitive
with all
dysfunction
those,
too. Yeah.
Yeah, I think the cognition is just so common that we need to educate our patients that it is common, even before they develop physical manifestations of MS, or if they will, and to reassure them that's it's not likely to be, an Alzheimer's form. We're doing MRIs all the time, so we might identify like vascular forms of dementia. And then I think as soon as they make the complaint, I think it's our responsibility to start testing. And I think a MoCA is really reassuring to patients when you do a MoCA test in clinic, to say, yeah, this is just like I thought. This is not looking, it's terrible and scary. This is, your MS processing speed is primarily the main problem in MS. It's not a, cortical destruction of, progressive Alzheimer's. Though if it ever turns that way, then we can start testing for that and monitoring you. And if we have any doubts, we can get neuropsychology to do additional testing. I think reassurance, number one, and then really going back to our treatment of exercise, social engagement, structural involvement, optimizing sleep and optimizing, work-life balance, things like that are so vital, that improve patients' outlook on the subject. So
Yeah, and I think like formal neurocognitive testing with our neuropsychologist is something that I historically hadn't done a lot of, but I'm less hesitant to do it earlier on. And part of that too is because it's fascinating in that testing, they can help pick up on various underlying causes like sleep disorders, like mood disorders. And it's interesting too, because like patients will deny being depressed or anxious, but then you do formal neurocognitive testing, and that's really what's kind of shining through. And so you almost have this objective data to help say like, well, let's at least try to treat, an underlying mood disorder, and then it can help their memory. So I think that that's something too that we could, it's a long battery of tests, which, understandably people don't love, but I think it's a very useful tool for us, even early on when people start having complaints about cognitive dysfunction.
It's such an intense test that it almost scares them off. They never want to do it again. And maybe that's good to just scare it out of them with a 6-hour neuropsych testing.
And like Neil mentioned, like as we go through this discussion, every single intervention strategy start like exercise, I don't think isn't in one of them, right? So it's exercise. And another thing with cognitive dysfunction and a good useful or utilization of AI is there's some good AI apps now that can serve as reminders for people. So it's setting those alarms on your phones based on what time you need to take your medications or pick up a child from school or whatever those reminders might be. So good utilization of AI apps to help with those sorts of things too. So much of it, while we don't have a medication to treat the cognitive dysfunction specifically, a lot of it is compensatory mechanisms, reminders, calendars, those sorts of things.
think
And
it's also-
also,
go ahead.
yeah, I was going to say another big thing about cognitive dysfunction in MS is we'll talk more about caregiver burden, but like helping the spouse or the children understand the degree to how significant the cognitive dysfunction can be in MS and helping them to understand that too, because that's really an area where I feel like caregivers or family friends, they really struggle to recognize or acknowledge that cognitive dysfunction can be so impactful for people.
That's exactly what I was going to say. You took the words right out of my mouth. We got to educate their family members who are interacting with them can be so frustrating when you're trying to interact with an MS patient who suffers from cognitive troubles, not maybe, not severe, but just enough to make interactions difficult and can really drive a wedge between spouses and family members. So getting their family involved early on and educating them, reassuring them just as much, and then teaching them how to communicate again, active listening skills and others, so important.
Okay.
Did we say therapy?
Oh, we did.
Did you
Yeah,
say
we
speech
did.
therapy?
Got it. Yep.
Speech therapy.
Okay, so mood disorders, common misconceptions about mood disorders in MS are that they are rare, that they're just emotional reactions to the diagnosis, that they don't affect physical functioning. And so we know that up to 50% of individuals experience major depression or anxiety, both in relation to neurological and psychosocial contributors. And we know that mood also affects mobility, it affects cognition, and can also affect adherence to medication regimens. So, shockingly, exercise is again number 1 on the list when we talk about depression and anxiety. Tammy's over here just clapping her hands. She's like, yes. But I think, similar, so much of symptom management really is just that, right? It's the balance of pharmacological and non-pharmacological. When someone comes in with depression or anxiety, is there a certain class of medications that you prefer to start with in MS or those that maybe you steer away from?
Risperidone, maybe. No. I think, you want to target it if they've got some fatigue too, or if they're having trouble sleeping, then I can guide you in some options. I think, I don't know who taught me, probably Dr. Zabaj taught me everything I know. Maybe using Prozac might be more stimulating. I'm not sure why that is from a mechanism of action standpoint, given that all SSRIs are doing the same type of thing in my own puny brain. But Wellbutrin, of course, for fatigue being stimulating. A lot of the dopaminergic medications, why amantadine helps with the fatigue, but amitriptyline or you prefer nortriptyline, TCAs at night for people disturbed by sleep, chronic headaches, pain. Pain's a part of it. Maybe turning to the the SNRIs, and so it's trying to kill a couple to 3 birds with one stone if you can. In terms of treatment, but I treat early and right away. And I think, again, it's communicating with our patients, asking them questions, the tough, scary questions like suicidality, I think is really important. I've been trying to ask that question in some ways. It's kind of an awkward thing to throw in there after you talked about their erectile dysfunction. But then, you have that conversation and you connect with your patient and identify underlying risk because there is an increased risk for suicidality, I think today anyway, but in our MS patients as well. So doing simple bedside tests, I think are important. And maybe
and I think cognitive therapy, obviously talk therapy is so important as part of the treatment too.
Don't we do that? Isn't that our job in the clinic?
For sure.
Therapy. My patients therapize me and I therapize them.
So just to say that mental health treatment improves the overall MS outcomes, we do know that. And then we're going to move on to pain. MS doesn't cause pain, which we know is not the truth. Pain is only from spasticity. Rest is the best treatment. Pain must be tolerated. The reality is we know that pain is common, it is multifactorial, and it is treatable. Various types of pain exist in individuals living with MS, both neuropathic and sensory. We can see migraines, trigeminal neuralgia. I have always been told that there are no emergencies in MS. I've learned this from my mentor, Dr. Kathy Healy, the only being trigeminal neuralgia. So that is one that you want to treat and treat quickly. And then, of course, spasms and spasticity. So I think the most important thing when we talk about pain is what's the underlying pain, right? Like what's it coming from, and then targeting that pain. I know I have patients who have expressed frustration because they don't understand why we don't utilize narcotics, and so it's educating like if we get you on the correct medication to target the type of pain that you're having, then we will have good outcomes.
Mhm.
I mean, you see the same thing?
Yeah. Um, yeah. Talking about pain, I mean, they come to us with pain usually, even if we're not asking. It's usually, I think, pain and fatigue are some of the most common problems I find, and they are challenging, and it's the biggest impact on their quality of life, I think. They're trying to live with pain and trying to work with pain. Um, I missed your question. I don't know where
Oh, no, it's
my
fine.
brain
You were
got
sleeping.
distracted, but identifying the pain's obviously very important so you can target the treatment. I think headaches are, I think we've boiled them down into everything's a migraine now. And because there's such great treatments available pharmacologically. And I think muscle spasticity is kind of in a different class of its own.
Yeah, talk a little bit about like when somebody comes in with increasing muscle spasticity or complaints about about spasms. What's your kind of approach to starting treatment? Like we've done physical therapy, we're stretching regularly. What about medications?
Um, I always turn to baclofen. I guess that's just the way I've been trained in some ways. Worth a start. It's pretty well tolerated, pretty clean side effects, lots of fatigue and weakness potentially, but I don't see a lot of the cognitive side effects, which I think can be more disturbing for some patients when they try something like tizanidine.
And then can you walk me through when like Botox or a baclofen pump might be a good option for someone with spasticity?
For Botox, I think more focally involved dystonias or spasticity, I think would be more appropriate rather than generalized spasticity where you're seeing lower limb, large muscle group spasticity. Um, for baclofen pumps are great for augmenting um, antispasticity treatment of lower limb spasticity. It only really helps there, help to minimize the overload of drugs. Many of our patients who are turning to baclofen pumps are on, 3 or 4 different neuroleptic drugs, baclofen, tizanidine, gabapentin usually, and then some other anti-seizure medication for treatment of other pains, neuropathic pains and others. So if we can relieve that burden on them, then we might be able to get some brain power back into their head and maybe reduce the number of pills they're taking. Um, so that's
And I think when we talk about just managing pain, whether it's neuropathic or spasticity, it's just to make sure that the multimodal pain management is improves function and then allows them to live a good quality life. That's I think
Yeah.
the biggest thing with that and what that combination might look like for people. Yep.
And again, you don't have to throw a drug at anybody just because they have a symptom. And I think that's we have a knee-jerk reaction to want to do something like that.
Yeah. Yep. We all know how much we love to talk about the bladder and the bowel, but they are super important in MS care. And I'm not sure people recognize how prominent or predominant it is. So people often think that bladder and bowel dysfunction in MS is rare. Incontinence, some people think that that's inevitable in their MS journey, or they're too private to talk about it. And it's interesting because is it the provider that's too private to talk about it, or is it the patient that's too private to talk about it? So these, when we talk about bladder, bowel, sexual dysfunction, they kind of are all kind of lumped together. 75 to 80% of individuals living with MS will suffer from bladder dysfunction, and we know that bowel dysfunction is very common and underreported. And that's one thing, like when you're assessing bowel dysfunction specifically in somebody, or say someone comes in with increased urgency frequency, the first question I ask people is, how are your bowels working? And when I ask that is specifically, how many bowel movements are you having a week? Because they can say, my bowels are working well. And then you say, how often do you have a bowel movement? Once a week. Like that's their normal, right? That's not normal. That's not healthy. It's also not good for the bladder. So, you want to, when you're addressing these symptoms specifically, you really want to ask the details.
Yeah, you do.
Yeah. So
Tell me about your poops.
Yep. I think too about both for bladder and bowel, back to the therapy. Again, someone mentioned it earlier. Dr. Hartman mentioned pelvic floor therapy, and that is too something that I think we wait too long to recommend and wait too long to start. And I think realistically could be or should be recommended before we even start talking about medications to manage the bladder dysfunction and see how they can respond. What do you think about that?
Sounds like a good protocol to follow. I probably don't do it enough. And, I tend to turn to urology first before I do things like that and have them do it. Perhaps I need to do a little bit more on my own side. And pretty lax with trying to treat urgencies and frequencies with women, and really reluctant to do anything with men. So
That's a good thing because men, we worry about prostate
Right.
issues, and that's kind of the standard. That's standard. Men, when they start reporting urological problems, they do need to go see a urologist for
Mhm.
the prostate specifically, really. But
And I think pelvic floor therapies, like many times, you can send one patient to Tammy and get like incredible results. Then you send them to somebody else you've never heard of, a physical therapist, and they're basically trying to treat them for back pain, for muscle spasticity, which isn't right. And I don't know if maybe you can share with me your favorite pelvic floor therapists, so the successful experiences that you've had. Like any therapy, if you don't use it, it's not going to work. Tammy can tell somebody how to do it, but that patient has to go home and be able to do it. And so I think sometimes that's challenging with therapy. That's the one challenge with therapy, is getting patients to continue through. Tammy's husband treated my shoulder. Do I do the therapy he gave me? No. Do I still have shoulder pain? Yes. So would I still have pelvic dysfunction? Probably, because I'm not receptive to the therapies that are given. So I think therapy is a part of it, and then quick referral if things aren't moving along, especially with UTIs and things.
And I always tell people too, with bladder dysfunction specifically, it's a quality of life thing. So if your bladder dysfunction is not interrupting your quality of life and you're okay living with some urgency and frequency or some leaking, then I'm fine with it too. But if the bladder dysfunction starts to interfere with your quality of life, you're no longer want to go out to eat with your family, and or you start having issues with recurrent infections, like recurrent urinary tract infections, then it's something that we should address. And in terms of bowels, the recommendation is really 3 bowel movements a week is really the minimum that people should be having. And recommendations for treatments of bowel dysfunction, like if it's how aggressive we need to be for individuals living with MS and advanced disability, we'll oftentimes recommend doing a formal bowel regimen for people. And so that's kind of addressing it from the top and the bottom. And oftentimes they need a stimulant suppository to help them move their bowels. So kind of how we optimize bowel function changes as their disease changes. So I think that's important too.
Do you see a lot of improvement with bladder function than with clearing out the bowel, getting their bowel movements regular, more than
does help.
other things, other therapies for bladder dysfunction?
Well, I think you start there. Like
Start
if
there.
someone has severe constipation and they're complaining of urgency frequency leaking, the first thing you do is treat their bowel dysfunction or their constipation. And then you see where they're going to land, right? And that may be enough to just continue to optimize their bowel function. Yeah.
And water.
Yes.
How important is water?
Yes. Yep.
But I think really You are asking me if treating the bowel improve the bladder, right?
Yeah. Treating constipation.
Improve the bladder function?
Correct.
Yeah,
If they have constipation, yeah.
yeah.
Okay.
And similarly, treating spasticity improve bladder function.
Yes.
People who are very stiff sometimes.
Oh, yeah.
Their bladder is stiff. You give them baclofen and their bladder relaxes and things are much better.
Mm-hmm.
And sometimes you can get some retentive stuff too. So,
Well, of course, it depends.
yeah.
It's all a threshold thing.
Yeah.
Mm-hmm.
Mm-hmm.
Okay. Sexual dysfunction, way more common than anyone wants to talk about. We call it the silent symptom. And there is a lot of publications out there talking about this specifically, about the prevalence of it, but also about providers' lack of willingness or desire to talk about it. And so people may think that sexual symptoms are rare, that it's psychological, that fatigue doesn't affect sexual functioning, and relationships can't thrive with sexual dysfunction. And none of those are true. It's a very wide range, but they say 40 to 90% of people with MS experience sexual dysfunction. And so that looks different for men and women, obviously. But I think what's so important is just to start having the conversations. And then we have good therapists, we have good providers, urogynecologists that we can refer to if we need to help. And just to know that sexual health is a vital part of MS care, and it is absolutely something that we need to normalize talking about, right? It's part of life. So, Neil, do you have anything? I'm not going to let you add anything. We're going to move on.
Let me tell you about sex dysfunction.
Okay, we're going to just continue to move quickly through this. These next two sections are why I'm really glad that Aubrey's here with us too. So Aubrey and I work together as part of the Multiple Sclerosis at Home Access Program, or MAHA program, for individuals living with MS and advanced disability. So we are extremely passionate, and Kristen Bailey, the nurse we work with, is back there. Super passionate about people living with MS and significant disability. So one of the most common myths that we find is that people with significant disability cannot have a quality of life. And in our work, in our experience, thanks to Dr. Healy starting this program in 2013, we know that individuals living with advanced MS can have meaningful lives, fulfilling lives when complications are prevented and they feel supported in their life. So, Aubrey, will you talk to me a little bit about, like, specifically when we talk about preventing complications and how important that is to improving a person's quality of life, like what those most common infections are and kind of what we do to help prevent those sorts of things?
Sure. Yeah. I think the most common would be infections, right? And oftentimes urinary tract infections. Many of our patients will get to the point where they have chronic catheters, which automatically maybe puts them at risk. You've got something foreign in your bladder on a regular basis. So it's education, right, on how do we prevent infections? What are signs and symptoms that they have? Because they're not going to be typical, right, of like burning isn't necessarily a sign of an infection, right? It could be related to something else. So falls are another big thing that we work on trying to prevent. We make sure that they have the equipment they need in their home and the aids they need to be safe and mobile kind of throughout. So prevention of falls, as well as kind of unnecessary or unneeded hospitalizations. I think we've found in our article, right, that once people have what they need in their home, the right people coming in there, like home health care and things like that, then they can prevent like a long-term hospital stay, right? And go back to their home without having to be in there for a long time. And polypharmacy is another thing that can really complicate matters. And we're fortunate to have our specialty pharmacists so we can kind of look at medications and see if there's anything that we could tweak, right?
Yeah, absolutely. And I think it's it's very humbling to go to have the opportunity to work with people with significant disability. And I certainly have individuals that I see in my traditional clinic that are fully ambulatory. Again, they work full-time jobs and they're doing well and they are struggling so much, right, with their quality of life. And yet I have an individual with spastic triplegia in a power wheelchair and the happiest person that I know. So Neil and I do a lecture to the residents every year on symptom management. And I try to reiterate to them so much like none of us in this room get to determine what someone's quality of life is, right? Based on just how they present to you, what that looks like face to face. So disability does not define quality. And I think that that's so important for all of us to know. And as clinicians, I think that it's important that, Aubrey is so well versed in the kind of the psychosocial and the resources that we have available in our communities. And so if you aren't sure how to help someone in those areas, lean into the people in your clinic that do know, because you really can improve people's quality of life by doing what we would consider to be simple things, right? Just affording them some support. So,
I like that. Disability doesn't define quality.
Yeah.
I'll write that on my wall.
Oh, okay, good.
Thank you.
Okay, so the last thing that we're going to talk about is caregiver burden and supporting the support system. So, myths about this is that caregiving is easy if the person can walk. Not true. Caregiver stress isn't serious. And so, would you say, I'm speaking specifically about like our MAHA patients, but like when we go into someone's home, how do you identify the level of stress that's happening in a home, even if someone may claim that like, nope, we're doing fine?
I think just like energy, right? Like how maybe you'll go in and things are a bit of a mess, right? Like your medication bottles are kind of all over the place. We're not setting them up, things like that. That just if the caregiver or loved one isn't really engaged or they seem like they just reading those signals and those signs that they might be feeling things that they're not, or feeling things that they're not expressing verbally. But I think including them in the conversation is always important and helping the patient understand why you're including them, right? It's not that you don't want their point of view as well. It's just getting everybody feeling empowered and included, right?
And I too even think about like the MS caregivers, primarily when they have more advanced disability. But it's true, like even from the time of diagnosis, you kind of just those individuals assume that role then of being the caregiver. So I think that it's so important that we're addressing caregiver burden because it's real and it exists. And unfortunately, in our experience, we have had spouses, the primary care provider, pass away before the individual living with MS passed away. So earlier this week, one of the spouses of our patients had a stroke a couple of months ago, right? And he's was providing her all of her care in the home. So people do not recognize the amount of burden that stress and how that really does affect us. So I think that it's so important that early identification of caregiver needs, and that could just be to helping them connect with a good therapist or making sure that they have good outlets themselves. So yes.
Therapy real quick. I think this is a good point because you see so much in the home. I don't get to see that in the home. I can suspect it when I see two people interacting in the clinic, whether they're distant from one another or one's kind of poking fun or, criticizing. But when might I consider home therapy? Because one thing I love about you guys on Thursdays, I don't listen in, but I hear you guys talking, having conferences with your therapists that are, close-handed, working hand in hand with you guys. You talk about the case. I don't know if your therapists are geniuses and they are always able to identify risks. When might it be good for me? How early can I get home health therapies and care in the home? Not everyone's like in a wheelchair and
No.
can't get out of their home.
No.
And I think that maybe that's one frustration is that we don't have therapists teaching the the patient and their caregiver, even if
Yeah.
it's like moderate to severe disability instead of profound disability.
So in my opinion, it's really anytime that someone struggles to get to therapy by themselves, right? Like if they can't drive any longer and they rely on someone else to get them there because of mobility challenges, that's a good time to bring therapy into the home. And home-based physical therapy can be, maybe people do not know this, can be billed as outpatient physical therapy. So they don't have to have a home skilled nursing need. They can still do home-based physical therapy and build outpatient. By definition, they have to still be homebound. But if they're not driving, that's certainly a good time. Or if you're starting to see like an increase in falls, like at home, specifically in certain areas in the home, then it can be helpful to have home-based physical therapy come in and actually see them in their environment. And then sometimes what we'll do is they'll complete home-based physical therapy and then potentially can transition to an outpatient setting.
Gotcha.
It really depends on the need too, right? Like if you really want to focus on strengthening of extremities, then sometimes having equipment and things like that is very important. So, but I think that there's a big utility in utilizing home-based therapy services for people that are kind of, yeah.
And I see a great value in the relationships you build with your therapist. It's not like you connect with 3,000 different therapists that are out there, but you make strong relationships and build a rapport with the therapist that you work with.
Yeah.
Yeah.
In the house, in home. Yeah, no.
In home. Exactly.
Yeah. Yep.
Thank you.
Yeah, no, it's good. Okay, so with that, we'll close. I hope we're doing okay. Dr. Spot will leave you 9 minutes. So just to reinforce that myths really do cause delays in care and reduce quality of life. Most MS symptoms are treatable and modifiable. Multidisciplinary care produces the best outcomes. Quality of life is achievable at all stages of MS, and supporting caregivers is part of MS treatment. Thanks for coming.
Thank you, Dr. Stewart, Aubrey, and Neil, for this interesting roundtable, which actually I would consider it, this is the art of symptom management. It's one of the difficult topic, actually, because as we all know, it's not unusual that in an attempt to treat somebody's symptoms, particularly in a polysymptomatic disease like MS, inadvertently, sometimes you cause polypharmacy, you cause more harm, and therefore you have to be quite resourceful and know what's available around you to help the patient. I always wondered why patients name their assistive device, and today I understood it, and I thought it makes perfect sense. You humanize it, you make it part of them. Thank you for that. It's actually fascinating because I always wondered why. And then regarding the dalfampridine, that it works or it doesn't work and all of that, I really think when it comes to things like physical therapy and dalfampridine, almost every trial is negative. But the reason it's negative is because we're not looking at the correct outcome. And maybe there is no such thing as correct outcome. But the way I think about it, it's like you're treating somebody with gait dysfunction. They're treating your gait for a disease that is running. You will never be able to catch up. So, and sometimes patient will tell you, I thought it's not helping, but the minute I stopped it, a while after I realized that it was helping. So I think it's important to tell the patient that this is not something that is going to improve you, but sometimes you might know that the benefit is indirect by just stopping, and then suddenly you realize, that it was helping. And then about fatigue, just to explain some of the things you see in the clinic, patients with MS love their coffee. Now, this is not to say that patients without MS don't love their coffee, but there is a biological basis for coffee in multiple sclerosis. It has an anti-inflammatory properties. It works on the receptor adenosine, and it antagonizes the adenosine receptor. Basically, it is an anti-inflammatory agent, and therefore, patients with MS, not unusually, they actually indulge on coffee, and they tell you, oh, if I'm tired, I don't like my stimulant, I will take a little bit more coffee, and there's definitely biological basis. Thank you. Any question for Renee, Aubrey, and Neil?
Just refill of your mocktail on the way out.
No questions? All right. Okay, like 2 minutes. You can time me. As we conclude today's symposium, I want to thank every one of you for your engagement, your question, and your ongoing commitment to improving the lives of individuals living with MS. This year focus on innovation and advance in MS reflect a field that evolves rapidly and demands that we evolve with it. Charles Kettering, he's an engineer, worked for GM between the 1920 and 1947, once said, if you always done it that way, it's probably wrong. MS is the perfect illustration of that truth. In my 2 decades of caring for patients with MS, I've changed my thinking many times. And people know very well, I'm not your wishy-washy person. That does not make us inconsistent. It makes us progressive thinkers, clinicians who adapt as science deepens, mechanisms become clearer, and patient needs shift. From re-examining MS through mechanistic lenses to addressing real-world challenges in pregnancy, B-cell modulation, aging, autoimmune encephalitis, and MOGAD, and the art of symptom management, today's session showcased the complexity and dynamism of the landscape we all navigate. I extend my deep appreciation to our speakers, sponsors, organizers, and all who contribute to this meeting. Your dedication is what makes this symposium meaningful. I hope today's discussion strengthen your practice, sharpen your perspective, and enrich the work you do on behalf of your patient. And on behalf of UNMC and the Nebraska Neurological Society, I would like to ask all the providers to accept a small token of appreciation. Have a wonderful weekend. Warm wishes for a happy Thanksgiving and a joyful holiday season to you and your families, and see you next year.